Good morning and welcome to day 2 of our 2020 virtual Florida Food and Nutrition Symposium. I hope you enjoyed the first day as much as I did. And again, I would like to thank our sponsors. Thank you to our silver level sponsor, Fresenius Kabi, and to our bronze level sponsors, Advanced Micronutrient Nutrition, Medtrition, and Abbott. Today's sessions continue with our talented speakers and our membership celebrations. And we're also going to hear a legislative update. This was a very active year. I would like to remind you to please visit the silent auction at 32auctions.com. The funds raised in this auction support our foundation that in turn funds our scholarships and our stipends. We all have a story of what brought us to FAND leadership. And maybe it was something that sparked your interest. Maybe it was an issue that you were passionate about, or maybe it was someone that inspired you to get involved. The 2021-2022 FAND leadership ballot is right around the corner, and we need leaders who are passionate about this profession. They have innovative ideas and want to continue seeing FAND progress as an organization. No experience required. So contact FAND nominations at yahoo.com because we need you. And once again, thank you for supporting FAND and for making this event a success. Enjoy day 2 of our symposium.
All right. Good morning and welcome back. It's Sunday morning, day 2 of our virtual FAND symposium. My name is Holly Brennan and I will be moderating today's session. I have spent my career in healthcare, primarily in the acute care setting. Currently, I have the privilege of working for Morrison Healthcare as Division Director of Clinical Support. I am also on the nominating committee for FAND. So hopefully you had a chance to join us for yesterday's session. Today is part 2 of Older Americans and Malnutrition, What You Need to Know. So today's session is a continuation of yesterday's presentation, addressing senior malnutrition and bringing awareness to communities, professionals, and government representatives. This session will focus on achieving quality malnutrition care for older adults. A national blueprint was designed providing goals and strategies developed by Defeat Malnutrition Today Coalition, Avalere Health, and the Malnutrition Quality Collaborative that's supported by Abbott Nutrition. Articulating the goal of reducing and/or eliminating senior malnutrition can only be achieved through strategies, recognizing the severity of this program, and collaborating to resolve malnutrition amongst vulnerable populations. So today's session will be a little bit different. We have one primary speaker who will be joining us, and then we will have a panel of experts. So Meredith Whitmire, who is the Policy Director of Defeat Malnutrition Today, will be our speaker. She is also the Vice President of Matz, Blancato and Associates, and in these roles, she advocates on behalf of a wide variety of aging topics, including nutrition, elder justice, and community-based services. She holds a JD from Georgetown University Law Center. Joining her on the panel today will be Heather Waco, who was one of our speakers yesterday, who is currently the Director of Clinical Nutrition at Lee Memorial Health System. We will also have returning Sabrina Taylor, who is our master's level social worker, specializing in relationships and developing therapeutic projects throughout the Southeast. And Dr. Donna Greenwood will also be joining us, who is a well-known educator in the state of Florida. Adding to today's panel will be Ms. Rosa Carranza. She is currently a nutrition consultant for the Southwest Social Service, Inc., Unidad of Miami Beach, Inc., and Independent Living Systems. Prior to these positions, she served as director of an evidence-based health programs in Miami and also as a nutritionist and training associate at the University of Miami School of Medicine. She has also served on several Florida Nutrition Advisory Councils, helping our communities serve our older Americans. And last on our panel, we will have Ms. Kathy Arft, who currently serves as Food Service Director with Trio Community Meals at the Osceola Council on Aging. Kathy also precepts undergraduate and graduate interns in the areas of culinary and nutrition. She is a program reviewer for Innovations Program, Nutrition Programs, and the Services Grant Review Administration on Aging. So without further ado, I will turn it over to our speaker and our panel. And again, just a reminder to drop any questions in the chat box to the side.
Hi, everyone. Excited to be here today to present on the National Blueprint. So, I'm from Defeat Malnutrition Today, which is a pretty large coalition at this point. We have about 100 organizational members. Uh, Stakeholders, organizations, including some public, some private. We have about 400 people on our policy mailing list at this point. So if you're not on the list, you might want to join. Please go to defeatmalnutrition.today for that. And as a coalition, we are working to create policy change toward a greater emphasis on screening, detecting, treating, and preventing malnutrition in older adults. So, as all of you know, malnutrition is a crisis. This is a new infographic that we have that is available on our website, and I just wanted to point it out. We've found that it's pretty handy, uh, but that is not entirely what I'm here to talk about today. I am talking about the National Blueprint: Achieving Quality Malnutrition Care for Older Adults. We first published it in 2017 to provide a comprehensive review of the malnutrition landscape in the older adult. And we're authoring actions to help improve the health of folks and address malnutrition. We just completed an update, and I want to go through what the blueprint already had and then some of the update points. So, as all of you know, there are a lot of risk factors for malnutrition: chronic disease, lack of function, social and mental health risk factors, hunger and food insecurity. And the fact that these factors are so intertwined really illustrate the need for a coordinated and comprehensive solution. So, our blueprint has 4 goals and a bunch of supporting strategies that I will not necessarily go through here. But the first goal is to improve the quality of malnutrition care practices um, by creating quality standards and ensuring quality transitions of care, that kind of thing. We also would like to see improved access to high quality malnutrition care and nutrition services through strengthening the nutrition professional workforce, integrating quality care into payment and delivery models, that sort of thing. Goal 3 is to generate more clinical research on malnutrition quality of care. And that has actually become a little bit better since 2017, the ancient time of 3 years ago. It's as you'll see when I talk about the 2020 updates, new science has been incorporated, but there's a lot more room. And then goal 4 is to advance public health efforts. So that would be things like training healthcare providers and educating older adults themselves and their families, educating policymakers, and making sure that these programs have the proper financial resources they need. So in 2020, we added things like the 2018 AHRQ data from 2016, which unfortunately is the last data we have. It is the most recent. COVID plays part of a role in that, but we also added some additional appendices to the blueprint, including on malnutrition policy achievements in the last decade and on clinical data registries. And you can see here in this slide the image: malnutrition is highest in older adults, talking about protein calorie malnutrition related hospital stays. And the 18 to 39 bar is very small, 40 to 64 also pretty small, 65 to 84 is a lot bigger, and 85 plus is huge. So the older we get, the more we need to be tracking malnutrition. So the blueprint also contained some updates on the policy front. One of our members, Feeding America, released the State of Senior Hunger in 2017, an annual report. And this, of course, is pre-pandemic. The report was released last year. And, so there's 7% of seniors were food insecure at that point. We can only imagine what the pandemic has done, and there will be updated data, and hopefully that will make it into a future version of the blueprint. HHS, the Health and Human Services Department, Secretary Alex Azar also included malnutrition in a presentation that he gave in 2018. It was one of the first times that a high-ranking federal official had actually talked about older adult malnutrition. And he shared some of that data that I mentioned earlier from AHRQ, the Agency for Health Research and Quality, I believe that stands for, and One Accountable Care Organization's efforts in addressing malnutrition. So they implemented some of the quality standards that I know some of the hospitals in Florida are implementing. They implemented the Malnutrition Quality Improvement Initiative's clinical quality measures that are currently pending before CMS, the Center for Medicare and Medicaid Services. So I just wanted to pop in here some of the recommendations for governments that have been updated because policy changes pretty fast. And so we had some new recommendations for governments that we thought you should be aware of. We are hoping that in the final dietary guidelines for America, which will be released by the end of this year, that the guidelines recognize quality malnutrition care as a priority. We're also hoping that malnutrition care is recognized as a high impact item during health pandemics, like our current situation. We are also hoping that and working toward having Medicare Advantage plans cover home delivered meals beyond the standard that they do. There was some updated policy about a year ago that has allowed Medicare Advantage plans to provide home delivered meals and other benefits as special supplemental benefits for the chronically ill. And so if you qualify for those, your plan can provide some of these meals. So we're hoping the more plans take them up on that. We're also hoping to see expanded coverage of medical nutrition therapy, which is the Medical Nutrition Therapy Act of 2020 is addressing that. It's bipartisan and bicameral. We do not necessarily anticipate it ending up anywhere in this Congress based on the policy issues that we've been seeing, but it has gained some momentum, and we are very hopeful that if action doesn't happen in this Congress, that it will finally happen in the next one. We're also hoping to implement and build, that the government will implement and build on the recommendations of the Government Accountability Office report on federal nutrition assistance programs and how agencies could do more to address the needs of older adults. And some of those things that agencies are supposed to be doing, just so you know, the USDA received several recommendations about improving its child and adult care food program. And HHS, Health and Human Services, received several suggestions on what the Administration for Community Living could be doing with their nutrition programs like Meals on Wheels and congregate meals to improve those nutrition programs. And they also asked that HHS, in the next round of dietary guideline updates, that they make sure to consider the needs of older adults. And that is key. This time around in the dietary guidelines, the ones that are supposed to be released by the end of the year, they really added a focus on children. And that is fantastic, but we would really like to see some more focus on older adults. So hopefully that will be coming with the 2025 version. So a little ways off, but we're still hopeful that this will happen. So some other updated recommendations. As you can see here, we are trying to make sure that malnutrition is taken care of during health pandemics and emergencies. We are asking advocacy groups and aging organizations to participate in professional conferences like this one. And we're also asking individuals, families, and caregivers to collaborate with their clinical team, including dietitians, to check on their nutritional status between clinical visits. And we'd really like professional associations and professionals in general to participate in Malnutrition Awareness Week, which I'll talk a little bit more about in a minute. So I talked about the GAO report. I'd also like to talk briefly about the Malnutrition Awareness Week Senate resolution in a moment, though that all ties together. The Older Americans Act reauthorization is something that just happened as our blueprint was going to press, and that now includes, for the first time, 2020 reauthorization includes the addition of malnutrition screening to the definition of nutrition screening. So that means that programs that are already supposed to be screening their older adults for nutritional needs should be using tools that capture malnutrition as well. So we're looking forward to seeing that implemented as the year and so forth progresses. So we also added some statistics from HCUP, the Healthcare Cost and Utilization Project. We added some Aspen criteria for the diagnosis of malnutrition. And we added some data from the US-UK impact studies. So we're really happy with the increase in statistics we were able to add. And frankly, we're also pleased to be able to remove some of the outdated statistics because, we're trying to focus on studies that have happened more recently. And there have been enough studies happening more recently that we were able to retire some of our numbers. One of the additions that we put in the appendices is on the aforementioned malnutrition quality measures. You can see that they were added to some clinical data registries. And so those include the Premier Clinician Performance Registry and the US Wound Registry. And we encourage you to take a look at the Academy of Nutrition and Dietetics guide on that. I will not get into the details there, but at bit.ly/and-qcdr, and it's there on the slide as well. So achieving these goals requires action today. Those were a lot of goals that I talked about earlier. And, we are hopeful that stakeholders can come together, national, state, and local government, as I talked about, practitioners and institutions, individuals and families, public and private payers. We are just hoping that we can all work together. So wanted to briefly talk about Malnutrition Awareness Week. It is a creation of the American Society for Parenteral and Enteral Nutrition that most of you probably know better as ASPEN. And the web address to check out Malnutrition Awareness Week resources is nutritioncare.org/MAW, here on the slide as well. And that website contains links to things like upcoming webinars during the week. The week is October 5th through 9th, by the way, so it is coming up pretty quickly. And we are, as DMT, we are participating. I know that the National Academy of Nutrition and Dietetics is participating. So we're very excited about Malnutrition Awareness Week this year. We are also excited because we are working on a Senate resolution at the federal level. Last year, it was introduced by Senators Murphy and Grassley, and it got 13 other co-sponsors. This year, it's being reintroduced. We've updated it to have some COVID-19 specific updates. And we are asking that Senators Rubio and Scott support this resolution. So if you have some lines into their offices, definitely ask them to support the resolution. So I also wanted to get into some of the other actions that dietitians can take from the blueprint. Those quality measures that I mentioned, implementing screening standards. We would really love to see you conduct some awareness campaigns. I know that this is a tough one for individual dietitians to do, but if you're working in an acute care setting, you can at least hopefully partner with your hospital administration, maybe as Malnutrition Awareness Week is coming up. And we also ask you to educate your patients and their caregivers on what optimal nutrition is and provide some of those resources to access things like Meals on Wheels or SNAP or the other nutrition programs that can really help make a difference in their lives. So all of this requires collaboration, and this issue requires a coordinated and carefully integrated approach. So ultimately, we would love for you to join us in helping to defeat malnutrition. You can go to our website, defeatmalnutrition.today/blueprint to see the 2020 updated version. We also have infographics. We have all kinds of stuff there. So highly encourage you to check out our website. If you have any questions, you can email me at the address on the screen. Or if you don't have time to write down the address on the screen, you can use the contact form on the website, or you can email info@defeatmalnutrition.today. Any of those methods will get to me. So thank you so much for having me, and I hope you continue to have a great conference.
Hey, good morning, everyone, and welcome to our Sunday morning session. Hopefully you enjoyed session 2 of Older Americans and Malnutrition. So welcome to our panel discussion today. My name is Holly Brennan, and I have been a dietitian here in Florida for, oh my goodness, about 30 years. With me today, I have the entire panel. So we're gonna, because this is the first time you're seeing our names and faces together, we're gonna go around in a circle and do just a quick introduction. Just a reminder, go ahead and start sending those questions in. We have, again, a nice length of time to answer questions as well as to have a discussion amongst ourselves. So I'm going to hand it over to Miss Rosa.
Hi, my name is Rosa Carranza. Good morning, everybody. My pleasure to be here today. I have been a community nutritionist for over 30 years, and I'm presently working at Independent Living System in Miami-Dade County as a consultant nutritionist. I also consult for 2 other programs that are older Americans.
Hi, my name is Heather Waco, and I've been a dietitian for over 25 years. And I'm currently working as the Director of Clinical Nutrition at Lee Health in Fort Myers, Florida. I'm going to pass it over to Meredith.
Hi, I am Meredith Whitmire. You probably just saw me on screen. I am the Policy Director for Defeat Malnutrition Today.
Hello, I'm Kathy Arft. I am a dietary manager with the Osceola Council on Aging. I've been in the community for over 35 years, and I am now at Trio Community Meals, and I'm glad to be here. Donna?
Good morning. I'm Donna Greenwood. I am a professor at Kaiser University, as well as I am the consulting dietitian for Osceola Council on Aging. Sabrina?
Good morning, everyone. I'm Sabrina Taylor. I'm the State Alliance Manager with Abbott Nutrition, and I'm also a master's level social worker based here in Florida. Glad to be with you all again this morning.
All right, welcome everyone. So we're going to do a little bit of a reverse question to start off with. So the panel actually has a question for you, the audience today. So as you think about this, go ahead and put your answer in that same Q&A box. Maybe if you want to put an asterisk at the beginning of it, just so we know that this is a question or this is a response to our question. So what the panel would like to know from you all is, what ideas do you have to bring awareness to your community about malnutrition, especially in our older population? Have there been any activities that you have done at your facility or within a group? And what joint efforts can you think of to heighten senior malnutrition awareness? I think certainly over the last 2 days, we've become very, very aware of just how important addressing malnutrition is really across the spectrum, but especially in our older Americans. So a few questions, if you want to go ahead and send those answers into the question box as well as your questions. We're going to start today off with a few questions from yesterday. We did not do a Q&A session yesterday, so we're holding it off for today. So the first question is, shopping is sometimes the main problem for many. They can afford the food, but they really have no ability to go shopping. So in what ways can we as nutritionists help? So if the panel just wants to raise their hand and we'll try and call on you guys. Miss Sabrina.
So one of the key ways is, certainly utilizing the network, the community network that includes the case manager, also may be known as a social worker, making sure that you can coordinate with patients to ensure that they're able to get access to their food in a timely manner, making sure it's nutritious food, but certainly utilizing that network to make sure that patients are getting their food safely as well as timely. So the role of the community definitely is important as it relates to this particular question and my observation.
All right, thank you. Catherine?
I'd also like to point out that there are a lot of, especially with the Older Americans Act agencies, there are a lot of programs that can actually go shopping for the clients. Mm-hmm. And right now, especially with COVID and the pandemic going on, most grocery stores in the area are doing free deliveries if they have the internet capability. That they can get online and actually order their groceries from home, and it will deliver directly to the door where there's no contact delivery, where they'll leave them there if the client is able to. But again, like Sabrina said, accessing, this is when knowing your community is the most important, knowing where these resources are. There's a lot of different resources. There's a lot of food banks and food pantries that will deliver to the client's home if needed. Yeah. Mm-hmm. There's also other programs, community commodity food supplemental programs, CFSP boxes, that a lot of programs will actually deliver to the client's home. So that it has no cost. So there are a lot of resources out there. You just have to do the research and know your community.
Fantastic. Donna?
One of the resources that you could look to, many counties publish a listing of the different types of resources available throughout the community, and they give a brief description of the activities that they will provide. And you can often get that from your public health department. And that is a really handy start to begin to know your community and where services are available.
Meredith?
I actually have a couple more resources to add to this. I would highly recommend calling 211 in your area. A lot of the 211 staff are trained in finding these resources, so you can direct folks there. I would also point out that if food insecurity along with the shopping is a concern, I believe Florida is one of the states that is part of the USDA's pilot program to allow online ordering with SNAP benefits. So it varies by grocery store or vendor, but that is also an option if there's internet access.
Mm-hmm.
All right, fantastic. Yeah, I think certainly COVID has brought forward the requirement, the need for us to have that online or delivery, which I think many of us have probably utilized as well. So fantastic that that's really front and center and considered quite the norm anymore to have your groceries delivered, certainly if you have those capabilities. Okay, next question. So, and again, this was from yesterday's session. So can this information be leveraged in our ongoing fight for licensure? This is great information validating the work of RDs. So Heather, I'm going to think that that was probably during your session.
Mm-hmm. Yes, I really do think that this is this work that we've done and that other people have done throughout the state and the country. It does really elevate that role of the dietitian. In the past, the dietitian's role was just kind of a reaction to a consult and just kind of pushing, or not pushing, but just identifying nutrition needs. And then you would leave a note for the doctor and the doctor really wouldn't look at it. But at least now with our documentation, and we utilize Epic. And so what happens in our electronic medical record is that when a patient is identified with 2 or more of the criteria, a best practice alert alerts the physician and shows him that the dietitian has diagnosed, provided a nutrition diagnosis of malnutrition for the patient, and asks the physician to put that diagnosis on their problem list. So it not only elevates the dietitian's role, but it also gives that increased coding value. So the dietitian is no longer just a regulatory person, but now they're actually a revenue generating entity, although we're not billing directly, but they are creating revenue for the hospital and then helping with resources so that they won't be readmitted to the hospital. But I definitely feel that the nutrition-focused physical exam and the skills that the dietitian is using do elevate the role of the dietitian.
Yeah, absolutely. And if I remember correctly, you know, we were considered a quote talking profession. So that NFPE really differentiates and demonstrates the value of the dietitian on so many levels. We're not just a talking profession.
Right.
So
yes.
Fantastic example of how that works. Another question from yesterday. So what resources are available for dietitians to use when developing educational resources for older Americans? Anybody want to tackle that? Resources available for dietitians to use when developing educational resources for older Americans. Donna?
I know as a preceptor, many of my students will go to the National Meals on Wheels Association website, as well as AARP, to get some really good information that you can then translate for the patient. I have them develop what are called educational fact sheets, because those can go on the refrigerator, and they're always very visual for the client. I wondered if I could just address the licensure issue from a community standpoint, if that's okay. And Kathy is well aware of what we were doing. Once COVID hit in March, we were not seeing any of our clients anymore. So in the months of June and July, I had dietetic interns, and we started to ride with the employees from the Council on Aging who were delivering the meals. Now, it was a smaller population that we were able to see because of logistics and liability. However, using a visual nutrition-focused physical assessment, we were able to document approximately 18% of the recipients were malnourished. And of that, we identified that 7% lived in food desert areas. And so this is, I think, a way in which the community dietitians can also support and provide data for licensure. Our value in the community is just as important as our value in the hospital. But we need to use some of the tools from the hospital in being able to document our value and helping our clients. Again, this was just an activity we did. It was not a study like Heather, but it certainly could grow into more of a study where we would be able to validate our role in the community.
So Donna, I have a question for you. I come from more of the acute care side. So what tool do you use in the community to diagnose malnutrition? Is there a questionnaire or what criteria is used for the community?
I'm going to go ahead and let Rosa answer that one because she's probably far more familiar with, is it the 701A
Yes,
form?
yes.
Yeah.
I was just about to bring it out. For the congregate nutrition for seniors who attend congregate meal sites or senior centers, we have the 701C, and there's a nutrition questionnaire that gives them a score. There's also one for the homebound. It gives them a score, and if they have a 5.5 or higher, they're considered to be at high risk nutrition. And I think it's between 2 and 3. Oh, yeah, no, 3 and 5, you are moderate nutrition risk, and after, lower than that, it's a low nutrition risk. Is it a good questionnaire? Is it really giving us the information we need? Yes and no. We have something. Let's give it credit that way. We have something that we can use. However, some of the questions, even though lately they've been sort of revised a bit, some of the seniors still find them a bit threatening. I'll give you an example. There's a question that may seem very simple to answer, like, do you eat at least 2 meals a day? Well, I have, in one particular congregate site that I consult for, I did a review and I found many seniors were saying no. However, when I would do the individual nutrition counseling, medical nutrition therapy for them, which is also one of the services provided there, I would say, could you tell me a typical day? How do you eat? Oh, they would give you 2 or 3 meals that they were having a day. I asked the coordinator of the senior center, he says they feel that if they say, yes, I'm having 2, we're going to tell them they can't come to the senior center anymore. I said, what? I said, yeah, they feel threatened. Believe it or not, something as simple as that. You would think it's a simple question. I mean, you ask me, how many meals do you have a day? Oh, I have 3, I have 2, whatever. No, they don't take it like that. Also, there's another question that says something like, have you changed the way you eat because of a chronic condition or because of diabetes, something like that? They all say no, but then you speak to them and they all have, some of them have diabetes, others have high blood pressure combination. So, but like I said, if there's nothing better, at least we have something out there that points us towards certain people that may need additional services, etc.
Perfect. Yeah, we're dragging that skeleton out of the closet one bone at a time, aren't we?
Mm-hmm.
Heather, question for you. Can you share with us a little bit about the funding surrounding your program? It sounds like the program's been going on for several years. So how do you maintain that funding? And I'm sure it's continuing to grow.
Sure. So when we initially started back in 2014, our Culinary Solutions manufacturing facility helped funded the meals for the pilot study. After that, the hospital system, when we rolled it out at each hospital location, each location approved to fund those meals for the patients. And in the 2017-2018 year, it was almost fully funded by Lee Health, and putting the money back into the patients to help support them. And then also we saw that reduction in readmission rates, which was a cost-saving effort for the hospital system. We did obtain the grant from AARP, and that was very generous of them. And we were able to have that funding for a 2-year period to do our ambulatory program. Unfortunately, in the late 2018, early 2019, due to financial issues at the hospital, we did have to kind of cut back on that, the meals for the patients. So it did really make an impact on the patients being discharged. And then we were also granted a fund, we received a grant from the Blue Cross Blue Shield Foundation of Florida. which was, again, very generous. And we currently still have that funding. So we have a small program that we're doing with one of our dietitians, and basically looking at trying to see how we can get the patients to participate more. So if you noticed in the data that we had, we might have had 2,500, 2,600 patients say, yes, I want the meals upon discharge, but when ultimately they went home, only about 1,700 of them actually participated. So we wanted to try to narrow that gap. And so we are utilizing the Blue Cross Blue Shield funds to try to do so. And how we're doing that is by educating the patient more in the hospital about what malnutrition is and how the benefits of either meals or supplements can help them, and try to encourage them to participate once they go home. So I think that now where we are, especially with COVID and the losses that so many hospital systems, including ours, we're really looking to try to find support from other entities and see how we can get that funding to support the people once they go home with the meals. So right now, unfortunately, the only program that we have that people are getting the meals are through the Blue Cross Blue Shield program.
So is there a set number of patients that are allowed in the program? I mean, I assume you have a cap.
Well, right now, we kind of shifted some of the ways the meals are. So between now and the end of our program, we anticipate that we would be able to serve about 150 patients through the end of next June. That's our goal. It's still still a nice group.
Yeah.
That's
so
just
that brings
one
another question to light. Wow. Okay. So that brings another question to light. I mean, many times where we are unaware of the programs and resources available in our community, but even when we connect to them, there's a waiting list. So how do we address some of that, or what workarounds or what advice or guidance do you on the panel have for those resources that are available, but unfortunately, you know, they're capped. There is a waiting list. Does anybody want to address that? It's a tough one. No easy answer. Sure, Kathy.
It's Rosa. Go
ahead, Rosa. Sorry.
No, I was just going to say, we have to get all our elected officials on board. We need more funding. Let's face it. Okay. The elderly population in Florida is growing by day, and yet the funding stays the same. And until people realize that there is a major need, and that the longer you postpone granting us more money to provide the services they need, the meal services, you know, the worse the situation is going to get. And you're going to get a lot more people going back into hospitals after they've been discharged because they do not have a meal, at least one meal a day. By the way, we all eat 3 times a day, I hope, but a meal a day is something better than nothing again, okay? But it's hard to get it. And that was my point. And it brings me back to what Sabrina said in the first question. You can't take for granted when you're discharging a client that if you send a referral by fax, by email to a meals program, that client will definitely be getting a meal. He or she will probably end up in a waiting list, you know, and how long it will take for them to get it, who knows? So you need to follow up, and, you know, don't take for granted if you are on a discharge team coming up with a care plan for the person, make sure that to follow up that this person will be getting, that you have referred to Meals on Wheels, will be getting that meal at some point.
Right.
Okay.
I'd like to go on and also say that timing is important when you're making referrals. And if you're in the hospital setting or nursing home or ALF, waiting till the last minute, okay, we're discharging tomorrow, I'm going to make a Meals on Wheels referral. Honestly, even if there is no waiting list, that's not going to happen. And so, I mean, timing, and we don't always have timing because, you know, hospitals, they'll just shoot you out. But timing is real important. And also sometimes it's more than one service. Refer for Meals on Wheels, but they're, and almost all programs have a waiting list. I mean, it could be funding issue, it could be a routing issue. You live in this heavily populated area and you can only do 15 stops on a route. So, I mean, there's a lot of different issues, but there are other services out there, local food banks and food pantries. I can't stress that enough. The Council on Aging is a food bank and a food pantry, so that there's a stopgap measure. So that if you're on a waiting list for the federally funded programs or long-term care, that there's something else that you've got access. The commodity food supplemental program boxes that most counties have, a box of food that you get on a monthly basis, can also assist, so that there are other services. Local churches have a lot of volunteer programs, especially for their youth. So it's again, and I really feel, working in hospitals and nursing homes myself, is you do have to do the research. 211 is an amazing service, and our United Way locally is fabulous. But there are churches and Boy Scout groups and family members who will be willing to pay while they're waiting on the waiting list. So it is a lot of communication. It ends up putting a lot more work on the RDs and the discharge planners in the hospitals and nursing homes. But for our clients, I mean, we have to do these extra steps, because if not, they're going to come right back into the hospital. Right. Heather?
Yeah, I just wanted to say, you know, just working with this small group in even a small period of time, I've learned a lot, and we can really get in silos. You know, the inpatient dietitian, the community dietitian, and we don't really communicate a lot. I mean, sometimes it even happens within my own health system between the outpatient dietitians and inpatient dietitians. And so I think this is an opportunity for us as a state and here at the Florida Academy of Nutrition and Dietetics to really come together and, you know, mingle and, you know, try to network with each other so that we can find out resources that Kathy was talking about, and, you know, and that Donna's talking about, and Rosa and everybody, because, you know, I didn't know all that stuff. And I know the dietitians that I work with probably don't know all that stuff. So I think it's a knowledge deficit from the standpoint of the inpatient dietitians, and then the community not knowing what we're doing in the inpatient world. So I think that, like you said, the communication, we need to really increase that dialogue amongst our profession so that we can help the patients better and the community better.
I just wanted to add, everything that we have talked about is so valuable, but if we're going to go to legislators or we're going to go for grants, we've got to have data. We've got to have unified data to take to legislators, to funding organizations, to say this initiative is going to be a cost savings, improve quality of life, but look at the cost savings to the healthcare system. So we've got to develop some kind of standardized gathering of data so that we can compile it and make an effective presentation, whether we're doing it legislatively or whether we're doing it for funding. Data talks, and it's just not there. That's what we've got to do. We've got to come together and start pooling our data so that we can make an impressive presentation, again, heightening the value of the dietitian, both in the hospital and in the community.
Absolutely. You know, it really is all about numbers. I mean, numbers speak to us. And it's one thing to, you know, kind of know some of these trends and lack of communication or a lot of people, but man, there has to be some numbers behind it, as well as to, you know, as a form of measurement. How do you know if you've been successful or not? You know, we need that as well. You know, what's working, what's not working. You know, Heather, you really, you know, hit a nerve with me when you were talking about, gosh, as an inpatient dietitian, I wasn't aware. As the other panelists are talking, I'm thinking, gosh, I didn't know what was aware in my, you know, in my community either. You know, whether it's a lack of time, a lack of even knowing that it was my responsibility as a young dietitian to reach out and make these connections with the community. So how do we, as professionals, whether you're on the community side, whether you're in the long-term care or assisted care setting or on the acute care setting, how do we begin to bridge things that we cognitively know, but we just don't have that solid relationship there? What are some ideas from the panel?
I'll say, as an educator, I think as an educator and a preceptor, I think we need to be sharing this information with our students, the students that are going to be going out into practice. As a preceptor, I know that when they come to me in the community rotation, all they want to do is focus on a disease. But the psychosocial environmental influences that can affect one's health can be even more devastating than possibly the disease that the individual may have. They need to realize that there is more in the care of a patient, and in recognizing that, make that extension. I've had several students say to me, well, that's not the role of the dietitian. Yes, it is. Yes, it is a part of our role. And I think, again, from an educator side and a preceptor side, I think we need to start teaching the dietitians coming out that we wear multiple hats sometimes, and you need to be able to accept that responsibility for the care of your patient or client.
Point. Kathy?
I'd also like to recommend, just from the community standpoint, is just a little bit, because I know we all are short on time. There's so much to do and so much to be done, but calling 211 and getting the resources list, and then just calling a lead agency in your community. Let me tell you, we want you to know that we're here and what all the other services are here. We'll come and train you. We would love for you to come, and we'll walk you around our agency. We'll go through, video it and train it. It's out there. I know the community wants people in facilities and hospitals to know what's going, because all of us care about the client. I mean, that's our bottom line. We're not all doing this for the money, that's for sure. We're doing this because, especially in the community portion, I mean, we're doing this because we care and we want to help and we're making a difference. We want you to know. We don't want to be a hidden secret. We want you to know we've got a food pantry. We want you to know about Meals on Wheels and the waiting list and all of these things that are available. And we will come and talk to you. We're pretty nice people. We like everybody. Come talk to us. We'll come to you if it's hard and do a training. There are a lot of resources in the community. Most counties that I'm aware of have well, of course not right now, but have meetings for social workers, case managers, marketing people in there, so everybody can get together and talk about the different services that are available. And then, of course, our fun internet information. The Meals on Wheels Association of America has amazing data backed up with services, costs, studies that they have done. So, I mean, we're here, and we are here for you. So we can all be for the clients together. Sorry.
So I'm going to ask a silly question. So I'm an acute care dietitian and I want to reach out to my community dietitian. Who am I reaching out to? What do I Google? What do I look up? Where do I find that community dietitian?
Well, I guess it's going to depend on what you're looking for. Are you looking if we're looking for seniors, I would go to the Department of Elder Affairs, their website, and find the lead agency in your PSA where you're at, and go to that lead agency, or the area agencies on aging can tell you the lead agency there that can give you directions. A lot of area agencies on aging have a dietitian on staff. Some, like our PSA, everybody has a consulting dietitian. Some of us have wonderful consulting dietitians.
And I didn't pay you to say that.
that can send you in the right direction. And it goes the same with WIC or whichever direction that you're looking at. But that's where I would start.
Thank you. Heather, did you have a comment?
Yeah, I just was going to say, and I'm a bit guilty on this note, but we do have our local dietetic associations in the areas, and I think I'm unfortunately not a member, although one of my dietitians is the lead of our president ours, and so. But I think, again, trying to find the time to do those things. But again, I think it might be important for us to do so. And I know typically those happen after hours, and maybe it could be an opportunity for us to get together, and maybe workplaces approve time for us to get together as a group, because it's not just a social aspect during that time, but it's actually a networking opportunity for us to meet the other people in the area and see what they're doing. And that could be a great resource on how to learn what others are doing in the community as well as at the other hospitals.
Point. Anna?
Kind of building on what Heather said, instead of doing it after work, do a lunch and learn. Let's do a Zoom lunch and learn together, and bring the acute care and the community dietitians together, getting to know each other, what ideas you can share. But let me just build off of what Kathy was saying about what community offers. For my accreditation site visit, I had to do a virtual of some of my community sites. Kathy did such an excellent walkthrough of her facility, highlighting all the different services. My lead for my site visit could not believe what was available to the community and how they truly serve the community of Osceola. And I'm sure there are agencies out there in every single county that offer the wealth of services like the Osceola Council on Aging. But we just, like you say, Heather, we got to come together. And maybe a lunch and learn would be a good way to do it.
And now that we do have that more virtual capabilities, that's a great idea as well, because I know that at least from ours group goes from Tampa down to Naples. So it's a pretty large a geographic area, but now that we can do Zoom, maybe that's an opportunity for us to get together.
I think it's a great way for the dietitians to start to come together and to get to know each other through Zoom. I think a lunch and learn is just a super way to do it.
Technology is fantastic.
Yes.
So we do have a few questions from the audience. So the first one, you have a malnutrition screening tool you use that you feel is better for screening malnutrition in seniors. And do you recommend using a different BMI level for those over the age of 65 that is considered normal? For example, a BMI less than 22 versus current underweight of less than 19. So screening tool for our seniors for malnutrition, and do you use sort of the adjusted BMI? Heather?
I'll start out. So in the hospital setting, we use the malnutrition screening tool. So nurses will use that tool that has been validated. We added 3 additional functional questions, not to the malnutrition screening tool, but in addition to. So it's asking if they have access to food, are they able to prepare food, and one third question, but more functional questions, so that it's more of that food insecurity type questionnaire, so that because at the initial study, those questions were asked, and they were able to note that even if they didn't meet the malnutrition criteria per the malnutrition screening tool, if they had decreased ability to access food, they could still be malnourished. In our AARP program, we initially used the mini nutrition assessment by Nestle. And then if they were at risk, then they would conduct the full comprehensive nutrition assessment, including the nutrition focused physical exam. And as for the BMI, we are currently still just using the below 19. But I do know that the greater than 65 age, and I believe CMS is looking at that BMI of below the 22. So we have talked about looking at that more, so just because they are at more risk, even if their BMI is a little bit higher.
Does anyone else have any other comments about a different screening tool or regarding the BMI?
It's not a different screening tool. I already mentioned the one that we use for the OAA programs. However, I do ask other questions. When I have somebody who has been identified with high nutrition risk, I do not change the questionnaire. It does not appear as part of the questionnaire of the 701C, which is the assessment tool they do yearly with these clients in the congregate, or the 701B, which is used for the homebound. I just add a couple of questions that, like you mentioned, for food insecurity, whether they're in what kind of a budget they have for food, how much of their, the food stamps, how far does it extend. And I've talked to Donna about this before. I even check and see, especially when with homebound, are they sharing that meal with somebody? And that somebody may be another person, or it may be their special pet companion. So,
oh, yes.
yeah. So it's important to just use your imagination. Know that whatever tool you have, there are other things you can ask to, get a better, get more information, a better grasp of what that person needs. That's why I've always said that Broward Meals on Wheels, and now the Meals on Wheels in other places have had their, the food for the pet.
Pet companion.
Great. And I know you have, Osceola too, so it's great. I think it's great.
Okay. We have several questions rolling in, so if we can maybe at least get some questions addressed, that would be great. So what about a person who's at risk for malnutrition, but not actually a patient? They're just a lonely, isolated, no car owning, not much money senior. Is there any vehicle for them to let somebody know that they need healthy food?
I can say that when the students and I were doing our activity, what we found is when we would deliver to someone, we had actually neighbors come out and tell us about a senior that might be living alone or is having financial issues. And we would then gather that information and take it back to the Council on Aging, and we were reaching out that way. So there are individuals out there looking out for their neighbors and sharing with us as they would see us.
Fantastic.
When you have just somebody who's not a client that you see, plain old senior just have like the description is, there are, like I've said before, there are a lot of different resources, but if they're maybe not a hospital client or a nursing home client, you can still refer them to community services.
Yeah, anybody can.
I was going to say, I've referred persons that I know, parents of people I know, for services. So you can go out there and find them, help them even if they're not a client or a patient of your program. I've done it. And what you said, Donna, it's true. Right now I'm looking out for a gentleman, and I can't say I am, the whole neighborhood, this block is looking out for a gentleman who just came out of the hospital. He's 76 years old, and he's alone, lost his wife. And we did get him some meals from his church. So, but we're all working for him, and we take him food, and we look out for them. And he does have a CNA come in and take care of him. So, but we do look out for your neighbors too. Okay.
Right. Sometimes you just have to be creative.
Yeah.
Meredith, I have a question for you. So is there any sort of formal collaboration between Defeat Malnutrition and maybe something at the state level? So like a Defeat Malnutrition Florida. What does that look like?
So we don't have any state chapters at the moment, though if you are interested in starting a state chapter, please let me know, because we do have one local affiliate, which is Defeat Malnutrition Today Philadelphia. And they have started doing some local initiatives with their city and area agency on aging, and just bringing together a big coalition of folks from the local area, local hospitals, et cetera. So if you're interested in starting something at the state level, again, please email me, let me know, email info@defeatmalnutrition.today, and I'd love to talk to you about that.
Fantastic. Hopefully we flood your inbox.
Yes.
All right, Heather, question for you. Do you know of any overlap of patients identified for the meal program after discharge and those getting community meals or eligible for community meals? Heather?
I apologize. My internet was a little shoddy. Can you repeat that?
Yeah. So do you know of any overlap of patients identified for meal programs after discharge and those getting community meals or eligible for community meals?
Yes. Well, usually after our patients finish the 4 weeks worth of meals, if they are in need of additional resources, our Flavor Harvest coordinator will connect them, provide them with the resources that we're aware of in the community, and help and provide them with that list. I agree with Kathy. Now thinking back, we were providing that list to them on week 4. We should have probably provided that list to them on week 1, so that if they knew that after the 4 weeks they were going to need more care, that they could start that application process or whatever it may be. But we do try to help them in that aspect. Sometimes if the patient was readmitted again after the 30 days, and then they were still eligible again upon discharge, they could be eligible for another 4 weeks worth of meals. So we have had in the past people that unfortunately went back to the hospital, but were able to get the meals again over 1 or 2 different times.
Fantastic. Okay, we only have about 7 minutes left, I believe. So I'm going to circle back to our audience panel. So our original question to our audience was if they have ideas to bring awareness to their communities, different activities or joint efforts to heighten senior malnutrition awareness. So here are a few of our answers. I think we need a better connection between the acute care and community care resources. I think we've chatted about that as well. Food bank deliveries to seniors' homes, similar to delivery by Meals on Wheels. Produce trucks weekly at senior centers, senior living centers, including other basic foods like dairy or bread or cereals. And they must have the ability to take SNAP as well. Somebody said, I love the program at Lee Health and wonder how that program could be implemented through at least the large hospital system. Yeah, I think we all would love to model your system. You guys have done just an amazing job. So I have an idea to prepare a brief handout to all of our skilled nursing residents. It will state whether they currently have a malnutrition diagnosis, and even if they do not. They frequently do on admission. The handout would briefly explain how the diagnosis can impact their health status. Lastly, tips and resources to improve or prevent malnutrition moving forward. Malnutrition can also be briefly covered at their care plan meeting for the ones who have the diagnosis. Really some great ideas here. Our diet manual is also a great resource. There's evidence-based materials, and it's easy to print handouts or to copy. It addresses many of the chronic disease states. In response to nutrition education resources for older adults, the USDA has resources and handouts that you can use. I think doctors need to become more aware of this malnutrition problem and should be encouraged to refer the client to the dietitian. Too many older adults who are at home are malnourished, and the doctor often doesn't address the issue. So I think this is even referring to, you know, that doctor's visit, not so much even in the hospital setting. I think so often we expect malnutrition. You know, somebody has surgery, I expect you not to eat well for a few weeks. And it's sort of a natural consequence of something, but you know, those of us in the business know so many times they don't recover from it. That loss of muscle never gets regained. Older persons don't need gifts. Encourage clients to ask family to purchase plans that deliver meals for them. Also, many do not have online access.
That's a good idea. I like that.
It's a fantastic
Great idea.
That's a great idea.
Also, many do not have online access or the ability to do online. I have a friend out of state that I call weekly to do her order for her. I mean, goodness, in the world of technology, you know, you don't need to be in somebody's house to place an online order for them. All right. Remind our members to watch for action alerts from our academy for legislative issues that need our emails sent to our state legislators to support various nutrition issues or bills, like the one that Senator Murphy and Grassley are going to present again about funding for older Americans. Man, the academy makes it so easy just to click and find your representative, you know, cut and paste, send this. Man, they've made it easy for us. So absolutely, great suggestion as well.
Holly,
yes.
Another through the academy is for people to go to the Public Health Community Practice Group, click on their homepage, and you'll see all the activities that they are doing legislatively as well.
Will you say that group one more time?
It's the Public Health Community Practice Group. If you click on their homepage, they're going to list for you the activities that they're doing across the life cycle, and they are focusing on senior malnutrition.
Fantastic. Great resource. Here's we have a few comments in here as well. You know, our large hospital systems spend millions of dollars on advertising. It seems some of these systems can afford to help their community and in turn lower readmits and the costs associated with that. I think that's part of us getting that message out of how important malnutrition is and how prevalent it is. Thank you for the 211 resource for older Americans. Thanks for offering your services to come into our work areas and share your knowledge. Glad to hear that the Area Aging on Council is still available as well. I would like to add to Donna's comment about students desiring to focus on diseases and nutrition. Many seniors are very modest about their dental condition or lack thereof. Many may only have front teeth or missing teeth or cracked teeth that they hide. Consequently, they are malnourished and their dental health may be overlooked. Absolutely.
Absolutely.
We're proud people, and it's hard to show our weaknesses or our things that we need. Many dietitians in Florida and have the certification for the gerontological nutrition. So that's a good research as well. So the CSG. I am retired and currently grounded. You have inspired me to be more involved on serving my fellow team. Just got little chills with that.
Wonderful.
And a great point about sharing food. Some kind of essential clearinghouse to know what resources are available in our area is helpful.
Did we lose
Nutrition
you?
screening tool to
I
give
think
I
all
think
of
we
their
might have
patients.
lost. Okay.
I think, yeah,
Okay, am I back?
Yes.
Yeah.
Okay.
You're back.
In private practice has a physical therapy clinic that refers patients. They asked her to find a malnutrition screening tool to give to all of their patients. Those found would be at risk would be referred to the dietitian. Anyone have a good malnutrition screening tool? Sounds like something that would either be administered by the physical therapist or potentially even self-administered. So SGA?
That or the mini nutrition assessment, although that's only for older, but you could still utilize it for younger, younger
Yes.
people.
Mhm.
It's easily to get, and it's an easy, short questionnaire.
Okay. All right. I think we are out of time. Panel, you guys are amazing. Thank you so much for sharing your insight, sharing your experiences. Audience, thank you for your comments and your questions and for your participation as well. I believe our next session will start in 10 minutes, but just real quick, if you're having any connectivity problems and you go to the YouTube link, you may have to sign all the way back in to get back onto this link. What I was just shared. Come back to the original page and click the link to get back in.
thank
All
you,
right.
everyone.
This video is brought to you by Fresenius Kabi, the U.S. lipid injectable emulsion, or ILE, market leader. What exactly are lipids? Lipids are composed of fatty acids that are needed by the body for a variety of functions. Linoleic and alpha-linoleic acid are essential fatty acids and cannot be produced by the body and need to come from food sources. Fatty acids are found in foods like fish, nuts, soybeans, avocados, olive oil, and coconuts. Lipids are energy dense, meaning a small amount delivers a large number of calories. For patients prescribed parenteral nutrition by their healthcare providers, lipids provide a source of calories and fatty acids. A number of lipids are used in ILE formulations. Soybean oil contains omega-6 fatty acids. Medium-chain triglycerides are a source of rapidly available energy. Olive oil, which contains omega-9, supplies monounsaturated fats. Fish oil, which contains the omega-3s EPA and DHA, is the newest type of lipid source introduced into PN products. Of all the omega acids, omega-3s have been shown to be less pro-inflammatory because they produce anti-inflammatory eicosanoids and leukotrienes. What happens when inflammation is reduced? In a large meta-analysis of critically ill patients, the use of omega-3 containing ILEs versus non-omega-3 containing ILEs was found to reduce the rate of infection and decrease the length of stay in a hospital. Clinical guidelines, including the European Society for Parenteral and Enteral Nutrition, support the use of omega-3s in parenteral nutrition. For more information about the benefits of omega-3s in parenteral nutrition, visit freseniuskabinutrition.com/omega-3s.
Welcome to our member empowerment session for our 2020 Florida Food and Nutrition Symposium. You are going to hear from 3 of our leaders about different aspects of the Academy for this year. We're going to get a national update, a local update on finances, an update from me, and a peek at the future from your incoming president. Our first speaker is Dr. Kathy Christie, the Associate Dean in the Brooks College of Health at the University of North Florida. She is past president of FAND and co-author of 4 books, including the Latino Food Lovers Glossary, Fat is Not Your Fate, Eat to Stay Young, and I'd Kill for a Cookie. Dr. Christie is also the editor of the Manual of Medical Nutrition Therapy, which is published by our organization. A registered dietitian and fellow of the Academy of Nutrition and Dietetics, Dr. Christie earned her PhD from Florida State University and has served for 6 years as the chairman of the Dietetics and Nutrition Council, which regulates the nutrition profession in the state of Florida. In addition to her leadership at the state level, Dr. Christie serves at the national level as well and is our past treasurer of Academy of Nutrition and Dietetics. Our next speaker will be Melissa Cooper, FAN's current treasurer and chair of the Fiscal Affairs Committee. Melissa is a registered and licensed dietitian nutritionist whose career has spanned the fields of public health nutrition, pediatric nutrition, and food service management. Currently, Melissa is the Director of Nutrition for GA Foods Incorporated. Melissa received her Bachelor of Science degree in Food and Nutrition from the Florida State University, her Master's of Health Science degree in Nutrition and Dietetics from the University of North Florida, and is currently pursuing a doctorate in clinical nutrition from the University of North Florida. Melissa has been an active member of FAND, residing in the Suncoast region, and has served in the leadership role of president for 2 district dietetic associations. In 2016, Melissa was also awarded the FAND Emerging Dietetic Leader Award. After you hear from Melissa, you'll get an update from me, and then I will pass it to Mandy Lehman, our incoming president. She is a registered and licensed dietitian and certified diabetes educator for Nemours Children's Health System in Orlando. She specializes in diabetes and childhood obesity, as well as consults on a variety of nutrition-related conditions. Mandy is also a lecturer for the University of Central Florida College of Medicine's Culinary Medicine program. Mandy frequently volunteers for community events and is a board member for Grow Central Florida Kids, which supports grassroots wellness initiatives. She has held numerous leadership positions with the Florida Academy and is looking forward to assuming her new role as president. Take it away, Dr. Christie.
Hi, everyone. I'm really excited to be here with you for FAN's first virtual meeting. While meeting virtually is different, I know that we're all looking forward to getting back together and meeting face-to-face next year. Today, I'm going to highlight some recent developments and activities of the Academy and the Foundation. We'll talk about activities and successes in vital areas such as public policy, advocacy, and malnutrition. Our goal is that every member can proudly say, I am the Academy. It was on March 11th that the World Health Organization officially declared the novel coronavirus a disease and a pandemic due to the number of individuals and countries that were affected. Very soon, all of our daily lives changed, and those changes are still taking place. The Academy began creating resources to help all nutrition and dietetics practitioners stay informed of updates and to reinforce the importance of following science-based recommendations during this time to help our patients and clients and ourselves to stay as safe as possible. There's a professional resource hub that was created and also a resource page for the public. The resource hub contains journal articles, webinars, links to Academy and outside websites, and much more. There's also a question and answer section that you might want to look at, and we've advocated for expanded coverage of RDN services via telehealth during the pandemic and for increased access to nutritious meals for children who are being educated remotely. We've also created an ongoing series of webinars titled the Frontline Series, designed to help you treat patients and clients during the COVID-19 pandemic. This is an unprecedented time, and as our President Linda Farr said in her August Journal President's page, in times of uncertainty and challenge, leaders step up and shine a light on the path forward. Just like FAND, the Academy Board of Directors made a difficult decision on June 19th that the 2020 Food and Nutrition Conference and Expo would be virtual instead of in Indianapolis. I know you'll agree with me that, especially as an organization of health professionals, safety of our members, presenters, guests, and employees was our first priority. The exciting news is that the team has been working for months and will ensure that everything FNCE offers will be brought to you wherever you are. We'll miss getting together as we miss being together here, but visit eatrightfence.org for more on virtual FNCE 2020, including registration information. And the hashtag FNCE will remain the same, so be sure to tag all your social media during the meeting. The board of directors understands the importance of maximizing access to content, so FNCE registration fees were decreased by over 50%, and we increased the amount of continuing education available. The Committee on Lifelong Learning has been working diligently for months to transition FNCE sessions and the full program into completely adaptable virtual environment, 92.5 CEUs available. The amount of hours earned that may be earned over the live meeting and up to 12 months after is shown on the right and is broken down by code as noted in your professional development portfolio. President Linda Farr and CEO Pat Babchak recently wrote to all practitioners, members and non-members alike, saying it is our responsibility to acknowledge and embrace change with honesty, transparency, and humility. The Academy has heard from and reached out to individuals and groups who have expressed concerns, made recommendations, and offered potential solutions regarding systemic racism. The board is listening and shares your sense of urgency. At the same time, as leaders of a membership organization, the board is committed to giving voice and opportunity to the talents and expertise of our members. The board cannot do it alone, and our headquarters staff cannot do it alone. To most effectively address this work, the Diversity and Inclusion Committee and the Diversity and Inclusion Strategic Planning Task Force are leading the efforts to make sure everyone's voice is heard, and they have the full support of the Academy's board. Together, we can and will move our organization forward to address the difficult issues that face not only the Academy, but our nation. The Dietary Guidelines Advisory Committee's scientific report was released in July. Thanks to the 10 Academy members who served on this important panel. Their report includes the recognition that an inclusive 2020-2025 dietary guidelines for Americans must be informed by rigorous scientific evidence that represents all of us. Learn more about how you can contribute your input on the Academy's Online Action Center. The Departments of Agriculture and Health and Human Services will release the next iteration of the dietary guidelines later this year. The Academy's 2021 national elections will take place in February. It's the job of the nominating committee to select individuals for the ballot with proven skill sets for each position to provide our membership with qualified candidates for the future of the Academy. Nominations for Academy leadership positions can be submitted year-round, and anyone can nominate, from students to new members. Self-nominations are also encouraged, so if you are interested in a position, nominate yourself. Only one nomination is needed for an individual to be considered. Multiple nominations are not needed. So nominations closed September 14th for President-elect, Speaker-elect, and Treasurer-elect, but nominations for all other positions are due by November 6th. So you've got plenty of time to nominate our fellow Floridians for these important national positions. You can submit your nominations to nominations@eatright.org or visit eatrightpro.org academy.org/elections. As you may have heard, the Academy is bringing back one of the most popular leadership development activities it's ever had, the Leadership Institute. I was really excited to attend that many years ago, and it certainly helped me to become a better leader. The new Leadership Institute is designed for high potential members at any career level who are looking to advance your leadership skills and accelerate your career growth. It'll be a combination of self-directed study, in-person trainings, network opportunities, and small group projects and virtual learning. More information will be available soon for the 2021 Leadership Institute, so please stay tuned. The Academy offers tools and resources we all need. Like our profession, they are based on scientific research and evidence-based approach to practice. Academy membership offers you more than $3,000 in savings and benefits. You can't get these professional tools and resources anywhere else. And so really, membership saves you money. And here's some really great news. On average, the median salaries of RDNs and NDTRs is increasing much faster than the inflation rate. The Academy's 2019 Compensation and Benefits Survey was recently released and is available for free to members on Eat Right Pro. Among many findings of the latest survey, on an annual basis, an RDN's median full-time salary in 2019 equated to $68,600 per year. And that's an 8% increase since the Academy's most recent survey in 2017. For NDTRs, the annual salary was $45,800, up 9% since 2017. The two-year inflation rate over that time, as measured by the Consumer Price Index, was 4.7%. You can get your copy of the Compensation and Benefits Survey now and use the salary calculation worksheet to estimate what practitioners with similar characteristics and similar situations earn on average. I want to talk to some of the students that are in the audience today, and I hope you know that there are many reasons, both tangible and intangible, why students should be members and part of the Academy. Student members have exclusive benefits to help you get a head start on your career and make a difference in the health of the public. You receive a monthly e-newsletter called Student Scoop, which includes Academy resources and updates, as well as articles written for students by students. You can also apply to serve as a student liaison with the Academy, which gives you leadership opportunities that can be highlighted in your resume. And you can also apply for scholarships and grants awarded by the Academy's foundation. And these awards range from $500 to $10,000 each for members only. I'll bet everyone here knows at least one student who's eligible for membership but hasn't become a member yet. So encourage your students to join the Academy. I also want to talk a little bit about after graduation, because when you get your first job, you're probably at a lower salary than you will be later in your career. And so what the Academy has done is design a dues program that gradually raises the dues amount. And what we hope this will do is encourage students to join immediately after they graduate and then stay with the Academy. Even as their salary increases, the dues go up to that level. And we hope that's going to make a difference for students to make it easier for them to stay a part of the Academy. Malnutrition is defined as nutrition imbalance, including undernutrition and overnutrition, and it's a pervasive but often underdiagnosed condition in our country. Nutrition interventions have been repeatedly shown to be effective and cost-effective in improving health outcomes among malnourished patients. The Academy has made a significant contribution to eliminating all forms of malnutrition in our country and around the world. It's part of our strategic plan. So to help RDNs working in inpatient care settings and with support from Abbott, we partnered with Avalier Health to develop the Malnutrition Quality Improvement Initiative. And this initiative and collaboration continues, and we're beginning to see the results. MQI has a dual-pronged approach, maximizing clinician resources and reporting measures so that we can implement malnutrition quality improvement. And just this past December, in a significant and long-sought win for registered dietitian nutritionists and the Academy, the Centers for Medicare and Medicaid Services approved inclusion of the malnutrition quality measures into 2 qualified clinical data registries for RDNs to participate in 2020 in the merit-based incentive payment system. Including malnutrition quality measures in the Premier Clinician Performance Registry and the U.S. Wound Registry will promote healthcare team collaboration with measures for both physicians and RDN reporting. Another thing we want to focus on is our advocacy to policymakers. And you can see eatrightpro.org advocacy, where you can find all of these things online. What we want members to do is respond to those action alerts. Those are timely things where we need to see quick support for members of Congress and Senate. You can become a trusted resource for those legislators if you follow up after meetings and routinely send emails to congressional staff and use social media effectively. And we're counting on you to help us make a difference in the policy arena. Many members seek privileges to order therapeutic diets in the hospital setting. And I just wanted to highlight how much of a difference we've made in the last few years since 2014. So the states in green had no statutory or regulatory impediments to qualified RDNs seeking hospital privileges to order therapeutic diets. So that means those are the states where we can get them and get them fairly easily. The yellow states were where there are not definitive impediments to obtaining privileges. However, there is some statutory and regulatory language that leads us to recommend affiliators work with state regulators to try to get privileges for therapeutic diets. And the red states pretty much preclude RDNs from taking full advantages of these opportunities presented by the Centers for Medicaid and Medicare Services. Strengthening the Academy's Political Action Committee, ANPAC, is one of the most effective ways you can help elect and support pro-nutrition decision makers. While the logo has changed, the Academy's Political Action Committee, ANPAC, is still the only PAC broadly focused on food, nutrition, and health. Your ANPAC donations shape the future of our profession and the health of Americans. ANPAC supports pro-nutrition candidates regardless of political party. I want to talk for a few minutes about the foundation. It is the only charitable organization devoted exclusively to our profession. Through the foundation, you can make a national and also a global impact on nutrition and health. Your donations empower Academy members with tools and resources to be leaders on the global stage, and you do it by investing in the future of our profession. The foundation recognizes excellence in our field through annual awards to our members, funds food and nutrition research in emerging areas, disseminates results to position registered dietitian nutritionists as experts in public health, more important now than ever, and provides public education programs that equip our members with tools and resources to take these programs into their communities. I'm excited to tell you that the foundation has reached its $5 million Second Century member campaign goal ahead of schedule. Thanks to all of you who showed your commitment to the foundation and contributed to this tremendous achievement. Foundation looks forward to celebrating this milestone with all Academy members during our virtual Food and Nutrition Conference and Expo. The celebration will include videos from donors and recipients, as well as an impact report that will demonstrate the significance of this campaign throughout our profession. And in closing, I want to thank all of you for the important work that you do in advancing our profession, nutrition and dietetics. Thanks very much, everyone.
Hello, everyone. I'm Melissa Cooper, Treasurer for the Florida Academy of Nutrition and Dietetics. During this session, I'll be providing you a financial update for the 2019-2020 fiscal year. Before we dive into the numbers, I thought it was important for us to review the mission, vision, and values, and most importantly today, the fiscal goal of the organization. So with the mission, we want to empower our members as leaders in promoting optimal nutrition and health for all Floridians. This aligns with our vision as well as our values, which drives the performance of our organization. And with our fiscal goal, we want to operate the association to yield a strong financial position. An overview of our revenue, we have a general fund, which is primarily utilized for our operations. And we also have our foundation fund, which we utilize for scholarships and stipends. In our general fund, we have several sources of revenue. One of those sources is our Academy membership. If you designate Florida as your affiliate, we are able to receive $46 for active members and $10 for each student member or retiree. We also sell our diet manual as well as something new this year, which is our Healthcare Communities Manual. Also, we hold many symposiums and workshops throughout the year. With our many symposiums, we are able to offer continuing education credits for health professionals. And we ended up having 2 early this year, as well as our legislative workshop. Florida Fans Annual Meeting is our largest contributor to our general fund. And with Florida Fans, majority of our income comes through our registrations as well as our sponsorships. We also hold additional fundraisers throughout the year, and some of you may have participated in our big ticket sales, where we are able to raffle off some amazing locations throughout Florida, as well as some common household items such as kitchenware. We have also sold t-shirts that were health and nutrition related. And something that became very popular this year is utilizing advertisements through our web pages, through our e-blast, and we are able to have significant contributions through this funding source. And lastly, thank you all to those who provide generous amount of money in the form of donations. And this has also been attributed to our general fund. In our foundation fund, much of this is comprised of member donations, as well as Florida Fans fundraisers. So at this time, you are able to participate in the silent auction. So please make sure you go to that website and submit a bid, and that way we'll be able to fund more scholarships and stipends for our dietitians as well as students. And traditionally, we have Florida Fan fundraisers in person, and this is through our Dollars for Scholars and ribbons and jewelry sales. The foundation fund is strictly for scholarships and stipends. So for this reason, we never utilize any funds towards our operations. And we have been very strategic in being able to provide this each year. So we've saved some of this funds through our investment account, where we're able to earn interest and quite a bit over these past years. In our overview of expenses, again, we're going to be taking a look at our general fund and our foundation fund. For our general fund, majority of our expenses is attributed to expenses for our headquarters. So this is in payroll for our headquarters staff, as well as office expenses. We also have limited amount of expenses towards our diet manual. So whenever we have to print and ship out any of our hard copies of our diet manuals or our healthcare communities manual, then we do have a very small amount that we attribute to the expense there. Also, to protect our Florida licensure, we hired a lobbyist firm, which we really have been able to utilize these past several years due to some of the outside organizations who have been really active in trying to deregulate our license. So we have been very successful in maintaining our license, and this is in part to many of our dietitian leaders throughout the state of Florida, but also with the help of our friends and lobbyists. And also, there are some funds that we utilize for our planning and implementation of our Florida Fans annual meetings, such as maybe print materials or storage, or maybe some videography that we need to uphold so that we can be successful in offering an outstanding program for our members and guests. We also utilize general fund expenses for volunteer travel. So oftentimes our board of directors or our additional volunteers would need to travel so that we can meet in person to plan band activities throughout the year. And lastly, a small amount would go to everyday expenses and other administrative services such as accounting. And overview of our foundation fund. Again, we utilize the foundation fund for our scholarships and our stipends. And as you can see, we have numerous amount of scholarships and stipends available to our members. And we are pleased to offer over 12 scholarships and stipends throughout the year, where many recipients have been able to utilize for continual education or career advancement skills and or leadership skills. So in review of our budget for today's session, we're just going to focus mainly on our operations. And this table is a depiction of the amount that is received and compared to the amount budgeted. So for membership rebate, we received close to $92,000, which is a little less than our budgeted amount of around $98,000. For sales, again, this is in our manuals or t-shirts. We received close to $29,000, which is $9,000 a budget at $38,000. For continuing education events such as our mini symposiums or our annual meeting, we received close to $87,000, which is significantly less than what we planned this year at $198,000. And for other sources, such as our big ticket sales or our donations, we have received close to $8,000, which is a little bit more than what we budgeted for at a close to $7,000. An overview of our expenses. For headquarters, we spent close to $104,000, which is less than $104,000. And other expenses that we utilized for sales, we spent $43,000, which is less than the budgeted amount of $64,000. In continuing education, we have spent over $5,000. Again, this is in part primarily to our symposium, which we had budgeted $165,000. We were not spending as much this year. And lastly, in our volunteer travel, we are very conservative in our travel, utilizing other sources such as Zoom or other online platforms to hold our meetings. So we reduced our expenses there and only utilizing close to $1,100 where we had planned to spend around $8,000. So this year, we were very conservative in our spending, and we realized that we had some very challenges that we had to overcome, and being able to be conservative in our spending allow for us to have a net income for our next fiscal year. Next slide. So lastly, an overview of our year-to-date income and expenses versus our budget. This table depicts what we would have left over to start our next fiscal year. So in looking at this table, our total income year-to-date has been close to $226,000. And our budgeted amount was $348,000. Our total expenses have been $153,000. Again, looking at what we have budgeted for, it is $378,000. So overall, our net year-to-date, we have been able to preserve $73,000, and in total cash on hand from all of our accounts towards operations, we have a little over $104,000. So lastly, we thank you all for your support of the Florida Academy of Nutrition and Dietetics. Without you, our organization would not exist. So we thank you for your Academy of Nutrition and Dietetics membership, as well as your participation in our FAND events. In particular, this is our first year of holding the virtual annual meeting, and we received enormous support this year with having over 400 people registered and generous sponsorships through our vendors. So we thank you very much for your participation today. And also, we thank you for your participation in fan fundraising activities throughout our year, such as purchasing our manuals, participating in our big ticket sales, t-shirts, as well as your donations. Again, thank you, and this concludes my financial update.
Thank you, Kathy and Melissa, for your updates. And now I would like to give a little bit of an update of our year in review. I chose the theme this year of All In, and little did I know how meaningful that theme would be for this year. I chose it at the beginning of the year because I really knew that it was going to take everyone from every part of our profession and our membership to come together to have a successful year. But little did I know that All In was going to take on such a different meaning for this year. I want to talk about our past year with 4 themes in mind: innovation to overcome challenge, power in our united voice, dedication to our mission, and hope for our future. We started out this fiscal year with some challenges. We had a budget that was not as easy as we thought it was going to be, and we started out the year behind in the financial state. Our meeting last year in Marco Island, although a wonderful venue and an amazing meeting, did not bring in the revenue that we had anticipated. So we were starting out the year behind with our finances. But we were motivated, and we thought that really getting innovative and really looking at some ideas for the future, we would be able to overcome some of that financial shortfall. So I want to talk about some of the innovation that we put together for this year. We really felt that it was important to reach non-members. We know that membership is one of our revenue streams, and that we do a lot of things that benefit not only our members, but also our non-members. And so we wanted to reach out to those non-members and let them know, especially in the legislative space, what our academy does for our nutrition profession across the state. So we sent out a letter to our non-members. So we have the ability to look at a list of all the RDs in the state of Florida, and we sent out a letter talking about the legislative activities that our academy does, the benefits that all of us receive from that work. And we asked our non-members to give us a donation. And we raised a little over $1,000 from that one communication to our non-members. And so we saw that as a win to begin to unite our dietitians across the state and begin to get the word out about what the Academy is doing and the value of this organization. We also wanted to connect with our regions. So we know that we have gone through a lot of different changes with our districts to regions, and we wanted to connect with our regions. And I am very pleased to say that Central Florida region did a fundraiser, again, to support our legislative efforts. And a special thank you to David Trinkle and to Amy Sindler for assisting with that event. It was a huge success. It was a great venue, and we raised a little over $1,000, again, to go straight to our legislative efforts. As you all know, we do have a lobbyist that we have used for several years, and those budgetary dollars are part of that, but still continue to be something that we have to raise additional funds for. So I'm very grateful to our regions and connecting together to put out the word about those efforts. The other innovation is bringing the CEU to you. So we tried this actually last year in doing symposiums that were regionally based, and we decided to do that again this year, to have a local symposium. We had a winter workshop in the Panhandle area, and I'd like to thank Afav Kesem and Deanne Bruner for their help with organizing the event in the Panhandle. This meeting had great turnout, and it was another opportunity for us to bring the CEU to our regions. We also did specialty workshops. This year we did a pediatric workshop. We have heard from many of our members saying that they would like to have some specialty information in CEU in the pediatric area. And so we brought a pediatric workshop to Orlando this year. Thank you to Elizabeth Bobo, Mandy Lehman, and Allie Peacock for doing a lot of the heavy lifting and organizing of that event. It was, again, another great success. And communication on multiple platforms. So a thank you to Omar Guerrero and his communication team for really taking our communication to the next level. We are on Facebook, we are on Instagram, and this year Omar and team developed some really nice logos and color schemes for us to really look official on our social media platforms. So the other thing around communication that I wanted to mention that we hope to be able to do once we have our next annual meeting that's together when we're live is we looked at an app. We've seen that at lots of different conferences, and we explored that to have an app this year to really advance the way that we communicate during our meetings and before our meetings. So we weren't able to utilize that this year, but it was certainly an innovative thought that we wanted to do to bring us to the next level. Serving as an information resource. So we have our diet manual that everyone is very familiar with, and it was brought to our attention that maybe there was a niche market for the diet manual in the ALF and long-term care space. And so a new diet manual and a smaller version of the diet manual was developed, and we did some advertising. And although this venture was not as successful as we would like it to be, it is certainly an innovative way to be that information resource to other dietitians and to other nutrition professionals in our state. I also want to talk about the power of unity. So we certainly demonstrated that power with our public policy and during our legislative day. And thank you to Jen Ross and her team for putting on a dynamic legislative day. Again, even with our financial challenges, we had a huge turnout. We had a lot of interaction with our lawmakers, and I will let the advocacy group and Stephanie Petrosky talk to you more about the legislative year, but we had some successes for this year that I am very excited about. There is also a lawsuit out there. Many of you are aware of the lawsuit with the health coach, and that is continuing. There will be more information to come with that. It is not over. But it goes for a reminder that the power in our unity, the power in our profession, the talent that we have together will help us get through these next challenges. The other thing that we did was every year with these legislative challenges, we gain a better understanding of our legislative system. We understand the strategy. We understand who we need to talk to. We understand how everything is done from a strategy point of view with these bills. And the other thing that we learn is the power of relationships. So this year we had quite a few dietitians that have personal relationships with several of our lawmakers, and that has made a huge difference in our ability to talk with lawmakers and to convince them of the importance of our profession for our Florida communities. So we'll be hearing much more about the legislative year, but I want to thank you as the members to responding to action alerts, to staying vigilant, to what's happening during session and up on the Hill in Tallahassee. Thank you to those of you who communicated with your lawmakers this year. Thank you to those of you who continue to forge those relationships. Please continue to do that. And I hope that if you were inspired this year by the public policy events, that you will continue to be a strong participant in that arena, because we are learning year over year that public policy is so very important to our profession. I'd like to talk about the dedication to our mission. The mission of the Florida Academy of Nutrition and Dietetics is to empower our members to promote nutrition and health for all people. So we have talked a little bit about sponsoring relevant education opportunities. We've talked about serving as a central resource for information for our profession. We've talked about protecting our communities through public policy. And I want to talk a little bit about owning difficult decisions. At the beginning, I talked about the beginning of our fiscal year being a challenging one. And we talked a little bit about the revenue stream from our annual meeting last year not being as strong as we had anticipated. So although we were very innovative and very motivated at the beginning of our year to overcome some of those things, once our meeting was canceled in Boca Raton, we had to refund quite a bit of money to our vendors and to members who had registered for a meeting that unfortunately was not going to occur. We ended up refunding almost $20,000, and so we found ourselves yet again in a financial crisis. We looked at our brick and mortar headquarters and we began to make some changes. We went from 3 offices down to 1 office, and we went from 1 office to working remotely. We no longer have an actual office, so our headquarters is all remote. And we continue to forge ahead, but again, we were still finding ourselves with financial difficulty. So we had to look at one of our other expenses, and that was staffing. Jackie Mitchell has been a dedicated member of our headquarters staff for many years, and she retired in July. And at the end of July, after a rebate check that came back that was not as much as we had hoped for and budgeted for, we had to make the very difficult decision to push pause on our executive director position. This was not a decision that we came to easily. This was a decision that we made after looking at our financial situation, after projecting our finances, after many conversations, sleepless nights, and some tears. And we decided to push pause on this position for right now. We are hoping for a good future. We are looking forward to success with this program and this event and for others. But this has been a very difficult decision. Christine Staple has been a cornerstone of FAND, has been the face of FAND for over 30 years, and pushing pause on that position was very difficult. Chris is incredibly dedicated and has done an incredible amount of work to help us with this event and to continue to support us in the best way that she can. And we are very grateful to everything that she has done and grateful to our headquarters staff for their continued support. But we know that we must stay the course. We know that this organization is bigger, and the work that we do is bigger than any one of us. And so we look to the future. And so I want to talk about hope for the future. We will regain our financial footing. That is our goal. Membership is certainly a key to that success, but it is not the only one. We need to develop partnerships, and we need to evolve. We need to stay relevant as an organization. I want to just briefly touch on the licensure change that happened this year and the carve out for obesity counseling. And I know that in some respects that is viewed as a loss, but I would also like you to view that as an opportunity. It is an opportunity for the Florida Academy to be a resource. It is an opportunity for us to forge new partnerships. It is an opportunity for us to be a beacon for those who do not have the expertise but are searching for that information. At some point, we as dietitians cannot conquer obesity alone. So there's just not enough of us. So we need to be open-minded. We need to open doors, and we need to look for ways for our association to evolve. We need to be a resource to others, and I am hopeful for the future. I think we all know that we cannot sit on the sidelines and watch things pass us by. We need to be all in all the time, and I hope that we will continue to forge those relationships, to create those opportunities, and to be that open-minded resource to others as we look to the future. If this has inspired you, if you are wanting to be a part of what that future looks like, if you want to be a part of this leadership and shape the future of this profession and this organization, I hope that you will take advantage of the 2021-2022 leadership ballot. Like I said, self-nominations are welcome, and I hope that you will choose to get involved. It's a great organization with great people and great experiences, and I hope to see you around the table and hear from you all as the future of our FAND leaders. And finally, I would like to end with some gratitude. I want to say a very special thank you to our headquarters staff. I want to tell Christine Staple what a wonderful resource, and thank you for your dedication. Thank you for being the face of FAND. Thank you for being on this journey. We are so grateful to you. Thank you to Cindy. Cindy is still remaining in our bookkeeping position. Thank you for everything that you've done to make this organization a success. And thank you to Jackie Mitchell for all of your years. We wish you well in the next chapter of retirement, but thank you so much to our headquarters staff for everything that you've done for us. And I'd like to say thank you to the board of directors. This has been an amazing year. I think that, again, thank you for embodying the all-in theme. We have been doing lots of work behind the scenes, and I want to say a special thank you to Melissa Cooper for crunching numbers on refunds and discounts, to Jennifer Berry for stepping up at the beginning of this year to be our secretary, and for all the work that you've done for our awards program. I'd like to say thank you to Elizabeth Bobo for your ideas, for your thoughts, for your fearless ability to speak up and give us ideas, and for organizing all of our vendors. I'd like to thank Jennifer Farrell. Thank you for your work on the communications plan. Thank you for jumping in with feedback and ideas. To Allie Peacock, thank you for your work on member recognition and for the awards program and doing all of that work behind the scenes. I'd like to thank Gail Smith, my mentor, who has been by my side for many years, and this past year being no exception. Gail, there is so much that I am just so thankful to have you, and thank you for all that you have done this year to help me through this presidency. Bonnie Watson, there is so much behind the scenes work that you have done for this event, and I am so grateful to you. We could not have done this without you. And to Mandy Lehman, my president-elect, we have made a great team this year. I am excited about what's to come. I am excited about passing the baton to you, and I'm excited to see what you are going to do for your presidential year. You're an amazing leader, and I am excited for you and just excited to see what the future brings. And I'd like to thank you, our members. Thank you for standing by this organization. Thank you for your support. Thank you for being there. Thank you for your presence and your engagement in whatever area, whether it is education, symposiums, diet manual, whether it's looking at sponsors, whether it's being a part of these events, your leadership. We are all in as a family, and it has been an honor and a privilege to be at the helm of this organization for this year, and I thank you for this opportunity. And I'm going to hand it off now to your incoming president, Mandy Lehman, for some comments on the year to come. Thank you again.
Hi, everyone. My name is Mandy Lehman. I'm your incoming president. I'd like to start off by thanking Melissa Payne. Melissa is our outgoing president, and she has led fearlessly through this difficult year. To say that 2020 has been crazy is an understatement. Wouldn't you agree? And even with that, Melissa has been a steady ship through the chaos. She has led with confidence, with precision, and poise. And I think I can speak for the rest of the board when we say that we really value leadership skills. So thank you, Melissa, for all your hard work. I'd also like to thank three special ladies who have worked as part of our headquarters staff for many, many years. Chris Staple, Jackie Mitchell, and Cindy Crisp. We thank you for your years of loyalty and service to our organization. Just like many of you who have struggled through this time of COVID, it's affected your personal life and your professional life as well. Our organization is not immune to that. And unfortunately, we had to make some very difficult decisions when it came to our office and our staff. Now, we are hopeful at what 2021 is going to bring for us. Even just a few months ago, we were under a very difficult financial situation. And I'm just very blown away with the response that we've received with our virtual annual symposium. We really had no idea what people would think about us having a virtual meeting, but your support has been enormous. We've had lots of registrations come in and sponsorship, so it's really helped turn the corner for our financial situation. So thank you so much for your support. So because of that, I'm really hopeful what this next year is going to bring. In fact, we may be able to bring on paid staff again. I got to be honest with you, it's not going to be as a robust staff as we've had in the past, but I am hopeful that we will be able to bring that back in some capacity. Until we really get a good look at our budget and see where we're at, see what we can afford, we are going to be a volunteer-run organization, at least for a little while. So we ask that during this time of transition that you are patient with us and that you are understanding and flexible. This is a pivotal year, and we're going to have to look at doing business a little differently. So with that, I have to tell you, I am extremely excited about our incoming board, our committee chairs, our district presidents, and all the leadership that they bring. I met recently with the board, and I was just blown away with the ideas that they have and the confidence and the passion that they have for driving this organization to success. So even though we're going through this challenging time, we're going to end up stronger in the long run. I'd like to share with you that my theme for this upcoming year is courageous steps. And the reason for that is because we're really stepping out of our comfort zone here, and we're going to be trying some different things, and change can be painful sometimes, but we're going to be courageous about it, and we're going to get out there and we're going to make some positive changes. Our focus for this next year is going to be on member benefit. So as we make our decisions on how to move forward, we're going to ask ourselves, how does this benefit the members? That is going to be our motivation for the decisions that we make moving forward. So I'm going to give you just a little sneak peek of some things that we're going to be working on over the next fiscal year. We've heard you loud and clear that you need a website that is more user-friendly, where you can find things a lot easier and find that helpful information that you need. So it's going to take a little time, but we will be making some updates to our website. We are also pushing out more communication through our social media platforms. I am so excited about our strategic communications team. They are super talented, and we're going to tap into that talent, do a little bit more branding, use that to even market our materials, market our profession. So we have some work to do there, and it's going to look good when it's all said and done. We have some challenges to face with legislative issues, and it's important that we keep our lobbyists. They have been there for us. They keep their ear to the ground. They talk to lawmakers on our behalf. So it's important that we keep them, and they don't work for free. So we are looking at doing some fundraisers so that we can continue to have that support. In addition to that fundraiser, we'll have some other ones. In fact, we have one going on right now, and that's our virtual silent auction. Get your bids in before 4:30 on Sunday, because that's when it ends. You should have gotten a link in your email to access it. I can't tell you how excited I am about the new board coming in and the new leadership team coming in. Everyone has lots of wonderful ideas, and we look forward to meeting very soon, the beginning of October, to come up with a plan of how we're going to put those ideas into practice. So we're going to come out stronger on the other end of all of this. So thank you very much for taking time to hear what I have to say. And thank you very much for hanging with us as we take these courageous steps together. Thank you.
Okay, I think we're back now. So thank you, Mandy, for all of your kind words, and we're excited about the future. And I just want to take this opportunity to answer some questions from our members. Thank you for being here. I've gotten a couple of questions and comments so far, so let me just dive right in. The first question that I've received is about the new master's degree that is coming up and becoming a requirement for RDs. And how do you believe this will shape our field, especially knowing the cost of those degrees and seeing on the compensation report that the hourly wage difference between a master's and bachelor's was only $1 to $2 per hour? That's a really great question. And I know that there was a lot of thought and planning put into this requirement. And for me personally, I think it's going to be positive for us as a profession. I think we are going to elevate our status. I think that we are going to continue to elevate not only our educational status, our compensation status, but also the role that we play in the healthcare community. We know that some of our friends in rehab arenas and different things are already having advanced degrees as being something that is required. And so I think it's a positive step for us to continue. So thank you for that question. Let me move on. Another question. How much did we save this year not having to pay for staff or speaker travel to our meeting, or the wonderful meals you normally serve the first night and the update breakfast and housing? So that's a great question. And so let me tell you a little bit about this year's meeting. So, we had to make these decisions pretty quickly to go from canceling a live session to moving into maybe a hybrid session to going full virtual. So what we tried to do was retain local speakers. So a lot of the speakers that you have heard during the session are from Florida. So that was one of our first commitments, was to honor some of our local speakers. In terms of how much we pay and how much we budget to put on a live meeting, it is somewhere in the neighborhood of about $165,000. So, we are paying for room blocks, we are paying for conference services at our hotels. There's a lot that goes into a live meeting. So we have certainly saved some of those costs from an overhead perspective. There are still, speaker honorariums that we are honoring. There's not the travel, but again, we are working with a deficit with our meetings this year. So we are looking at some creative ways to put this meeting on. And we were able to offer this CEU event at a lower cost to our members. So there's some benefits and there's some drawbacks. So I hope that in the future we're going to be live. We're going to look for some type of way to be together again. We know that it's good for networking. We know that it is good for our students to be able to have that opportunity. It's just fun to be together. So I'm hopeful that we'll be able to do that as we move forward. But in the other breath, I would say this virtual event has been amazing. Thank you all for your feedback. I've gotten lots of comments, and I was looking at the question box yesterday and just really appreciate your comments and your feedback to what a great experience this has been. So we really do appreciate that. We are working on a survey that we're going to send out to you all that registered for the event just to get more of your feedback. We are learning and we appreciate your patience. We appreciate all the different ideas. We've gotten a lot of questions about whether the sessions will be available later, how to get the handouts later, and we're working through all of that. And this has been a first for us. So we appreciate you hanging in there and being patient as we work through some of those solutions. So let me go back to the question board. I've got some comments. So one comment is, really looking at the challenges with our laws as turning them into opportunities. So thank you for that comment. There's a lot for us to do together. The legislative situation, which is actually going to be our next session, there was a lot going on this year. And, having to carve out obesity, it really did feel like a loss, but I do want to encourage the membership to think of it as an opportunity and to think of it as something for us to work towards and just continue to embody this all-in theme and courageous next steps with Mandy and look for ways to really turn that into something positive. All right. Next thing, I've got a comment. It is a comment of thanks and gratitude to Christine Staple. And again, this comment is, cannot imagine our association without Christine. Such an incredible contribution and body of work, guidance and leadership and innovation, just a debt that cannot be repaid. And thank you. We all echo those sentiments and just all the work that Chris has done even to put this event on as well. So, Chris got out there, she called the play, and she threw the ball, and the board caught it and ran with it. And so thank you to that viewer for that comment. We agree wholeheartedly. Other comments just coming through about really loving this virtual space and loving the way this conference is organized. For those of you that kind of stick to that pattern of 15 CEUs a year, this is a nice way to be able to get a full year's worth of CEUs, hopefully in your comfy clothes and you're drinking some coffee and relaxing and really getting some cutting edge, up-to-date information on nutrition. So it's been a pleasure and an honor to bring this to you this year. And again, I think I thanked our speakers at another session, but I want to say also thank you to our presiders. Those of us who've never done virtual, this is kind of new for us. And so the presiders have been outstanding with rolling with recording some intros and going along with a live question and answer session and manning question boxes and emails, and it's been a lot of fun behind the scenes. Holly just did that awesome panel with Zoom. So I think what we've learned is the virtual space is our new frontier. That we can certainly do this. We can adapt, and I think that's pretty exciting. So thank you for that. All right, I'm gonna keep going here. This is a shout out to Patrick. So just this is saying this has been like their 10th virtual conference. AV connection wise, one of the best. Huge thanks to Patrick and team, and I will echo that. For those of you who know behind the scenes, we are constantly talking, and poor Patrick, we have just driven him crazy, I'm sure, with all of our questions and everything, but he has hung in there with us, and we really appreciate it. This is a viewer that has not been able to attend in several years because they live in Kentucky. They're thankful to have this opportunity to attend by virtual access. So the question is, will the virtual access be an option for the future? I really hope so. I hope we can do some type of hybrid arrangement in the future. I hope this is going to open up new opportunities for us. And I think there's a hope that we can also have people from other states to reach out to other associations and other state academies to partner for even more opportunities. So thank you for that comment. Okay, same thing. More virtual events in the future? I think so. I think this is our new way to communicate and to share information. Here is a question about the status of the districts, updates at the district level. So that's an interesting question. So this year I really did some thinking around our districts. You know, I talked a little bit about us coming together with the districts, but we considered having the district presidents also sit on the Florida Academy board. And we kind of realized that was hard, that for our district presidents, they're really focused on their local membership. And, you know, maybe it's a lot to have them in the middle of their local membership as well as their state. And so I think we always want to continue to improve communication and ensure that our districts feel very connected with us, but also make sure that we're not asking too much of our district presidents to be able to right size where that sweet spot is, where they feel very connected to the state level, but also don't feel that they're being taxed in both directions. So I think that we will continue to hone that. Allie has been awesome with really helping us formulate what's the best, you know, way to stay better connected. And so I think we will continue to move in that direction. So really appreciate your feedback from the district level too about those district leaders. And I think we want to continue to hear from you about how we can better support each other as we move forward. So thank you for that question. That's excellent. Going back to the question box, another kudos to Christine Staple. Absolutely, absolutely. Thank you. All right, some housekeeping questions. So where do you find certificates for continuing ed? I've gotten a lot of questions about this. So on the resources link, which is below the viewing box, you will be able to find the handouts to the sessions as well as the CEU certificates. So I know it's a little different this year. Virtual is a whole different ballgame, but we have one CEU certificate for you that is for the virtual symposium. We have one certificate for med errors and one for human trafficking. So what you'll be able to do is, if you'll take the sessions that you've attended, and there's also a program guide that was loaded on the resource page for you, and be able to see which sessions you attended. On the program guide, it has the learning codes, it has how many CEUs each of those sessions provides, and you'll be able to utilize that. We went in and did the entire program as an approval. So if you attended everything in the live symposium, you will have 12 credits that you will put on the one page, and then you will have 2 CEUs for med errors and 1 for human trafficking for a total of 15. So the other thing I wanted to point out and do a little plug for the auction, the silent auction tag is just below me as well. You can link on there and go over to the silent auction page and bid on some really nice things. So thank you for that. Going back to the chat here, still awesome, loving the virtual space. Thank you. And thank you. This viewer has said it's been a very informative and exciting presentation, and I hope we can continue this moving forward. I have to agree that the speakers and the information that's been presented so far and what is also yet to come is just very high quality information. And we are lucky to have Chris and all of her connections with pulling all of these speakers together. It's been a really awesome program. So thank you. Okay. So this viewer is asking, since there's no longer a home office, what is the address to send donations? I continue to want to support the association. Thanks for everything that you do. Thank you so much. So we do have a donations link on our website that will remain, and we certainly appreciate that, donations that you can make. As we continue to move forward, we'll probably be taking a look at what is going to happen with our address and our headquarters. And there is a lot more things to work through in the coming year. And so I think my piece of advice would be to stay tuned. Keep checking the website. Keep looking at those emails that are coming from Florida Academy from our constant contact. Mandy and team will be working through that and giving you more information on what's to come. Looking again. Oh, thank you. I did just get a message. We are still going to have a PO box that will remain. So we do have that now. The PO box is there. So we will continue to utilize that PO box. So if you would like to send donations, that has not changed. Thanks, Mandy. Another question, do the CEU certificate hours count towards hours for CDR? Yes, they do. This whole program has been approved by the Commission on Dietetic Registration. So all of these count towards CDR. And as usual, you will need to upload your hours to CE Broker. The Academy does not do that for you, so you will need to take care of that. But the med errors and the human trafficking are required for your licensure renewal for next year, and we are very happy that we're able to provide that to you during this session. Another question, since ethics is required every 5 years for registration, is it possible to include a 1-hour CEU yearly or every other year? Yes, it absolutely is, and we did not do ethics this year. But we will hope to provide that in a future symposium opportunity, so look for that in the future. I have another comment. So Mandy and team, this viewer would please like to have the worksheet back. So for those of you who have attended our live events in the past, you know that we have a very comprehensive worksheet that talks about the sessions. And a lot of times the sessions are running in tandem, and so you want to make sure that you are indicating which sessions you've attended. And we didn't do a worksheet this year, I apologize, but we really didn't do one because our sessions are running straight through. And so you really don't have a choice to attend, you know, 2 sessions that are running at the same time. And so that's why we didn't bring the worksheet back, but we will keep that for the future. So thank you. This is another question. This is, please share with us what percentage of members are master level or above. Requiring that level of education going forward will likely decrease much needed resources who cannot afford the cost of obtaining advanced credentials. Seems counterproductive in view of a growing and aging population that needs our services more than ever. I agree, and I'll be honest, I don't know those numbers. we'll have to look at our membership roster because I'm not positive off the top of my head what numbers we have. And um, I know it's going to be a hardship. I agree with you. I think there's going to be some growing that will happen through those years. I know that I sit on the board for one of the internships that's here locally, and they're working through what that looks like for their class as well. So I think there will be some challenges. I think the hope is that on the other side of that, we'll be stronger as a profession. One other comment, loved the yoga session yesterday. So thank you for that. I thought that was a unique way to show that expertise, and we really appreciated Marilyn being a part of that. Thank you for your comment. Let's see. This question is, what can the district groups do going forward to put ourselves back together and support FAND? I think that, really the key to some of that is good communication. Both sides of the street, the state level needs to make sure we're plugged into the district level and the region level, just the same way as the region's being plugged into the state. I think that we continue to progress with that. Having those region presidents invited to our board meetings and being a part of as much as they can to hear what's happening at the state level. But I think you bring up an excellent point to just ensure that we are communicating the needs. And really, Mandy touched on this as part of her focus is what do our members want and need, from our association. And so there's a lot of things. We have a diverse group of professionals within Florida Academy. So how do we meet those needs? We know that we know what our mission is, and we know that empowerment is part of our mission. But how do we accomplish that? And we know that we've got some good foundational things with information and diet manual and education. But how do we continue to grow? So we felt like a lot of our focus this year was on the legislative space and supporting our licensure efforts. And so we felt like that was a huge focus for this year, which put a lot of effort into that. And as Mandy said too, that's not going to go away. The carve out on obesity, I think we sort of sat back and said, oh, well, maybe this is going to be good. We've started to come together, but I don't think it's going to end. So deregulation is something that's just always out there. So I think it is, it's members, it's staying strong as a group. I think we know that we're dealing with new generations of dietitians, and I think it's learning what their needs are and what they see as the purpose of this organization, and just continuing to meet those needs. Thank you. Another comment about the virtual symposium being exciting and informative. And this viewer said, we appreciate the board for putting it together. Thank you. Thank you so much. I had a question earlier about what platform Fancy was running on. And I did try to reach out to Kathy Christie, and she is not sure either. But she has had a sneak peek and said that it's going to be an outstanding event. So look for that. The announcements will be coming soon. Thanks, Kathy, for that. Let's see, I'm going to keep going. This viewer said, I love the virtual meeting. It saves travel and hotel expenses, allows you to stay home and be a mom, do laundry, feed the family, and be a full-time RD, getting the most cutting-edge information. We're so glad we're able to provide that for you. Thank you. So this viewer has also talked about Zoom. That was a pretty impressive session with the panel on Zoom. So pretty cool. I think that's going to be something we're going to be able to use in the future. I think to be able to have some breakout sessions, to be able to really elevate this session and provide different opportunities for connection, even when we are all apart, I think is awesome. So thank you for that comment about Zoom. I was also really impressed with that as well. So this viewer is asking about recordings in the past. So this was a really hard one for us. We really struggled with how do we manipulate this in the future? How do we save this? Do we allow it for viewing later? What does that look like? So what we did come to a collective decision this year is that we are not offering this as something that you are going to be able to save and look back on later. It's something that we will look at for the future. And we apologize for the inconvenience of that. But we wanted this to be as much of a live event as possible and to mimic what we have done in the past. And so that is why we kept the sessions just available as live. So this comment is about breaking out medical errors as two. Yes, so you will load two separate certificates. You'll have a certificate for med errors and you'll have a certificate for human trafficking that you can load to CE Broker to satisfy those requirements. So this is another comment about the CEUs. So you are going to load your CEUs as one event. So we had it for 15 CEUs. So you will turn in that certificate with how many CEUs that you attended. So thank you for that question. So this viewer also echoing some gratitude for Chris Staple. Chris, I know you're out there and I want you to know that you are very loved. We've had lots of wonderful feedback, so please know that. And thank you. This member is expressing some gratitude for having this interactive session with members right now. Really wanted to make this be an opportunity for you to talk directly to me and so that I can answer your questions. That's why we didn't do a moderator for this. I wanted to be able to look at the box right there and answer questions. So thank you for that feedback. Yes, and one reminder for the handouts, you can save your handouts and you can reference your handouts later. So those are yours to keep. So feel free to keep those and reference them later. This viewer is asking, can you send out a blank CDR form to create the certificate to send to CDR? So you would have received that. They are down below on the resources page. If you are having an issue getting your CEU form and getting the handouts, we have some viewers who are only able to look at this session through YouTube, and we know that that is a problem. Please email the info at eatrightflorida.org email address. I think I have that right, info. You can find it on our website, but we will get the CEU certificates to you. So just let us know if you're having some difficulties with actually accessing the CEU certificate for today's session. And I think I am almost out of time. I know there was some work being done behind the scenes to look at percentage of members with master's degrees. So I'm not sure if we will get that information out there to you, but we will work on that, and it was a great question. So as we look to the future. So just in closing, because we are going to be moving on to we're going to go for a short break at 10:30, and then we're going to roll into our legislative update session. I want to just say again, thank you. It's been an honor to be in this position. I just want to express my gratitude to the board and to the members, to the presiders, to the volunteers, to headquarters staff for just everything that you've done. It's been a hard year with a lot of challenges. But we came together and we will continue to do so. as we move ahead. So enjoy the rest of today's symposium, and thank you for being here, and we'll see you soon. Thanks again.
Welcome, Florida Academy members. I'm Karen Sutters, Director of Nutrition at Medtrition and a proud registered dietitian. Medtrition is honored to be a sponsor at this year's symposium. We realize that 2020 has been unlike anything we've ever experienced, but we continue to stay strong, move forward, and support each other the best we know how. At Medtrition, we believe evidence-based intervention and foundational concepts of medical nutrition therapy play a main focus. We're here to help support both the patient and the clinician to more easily meet their specific nutritional needs. As we know, nutrition is not one size fits all. Whether it be protein provision with our ProSource liquid protein line, natural diarrhea intervention using Banatrol Plus, or dysphagia support with our line of ITSE Level 4 shaped purees and Level 5 minced and moist meats, we're here to help support your patient population to meet the nutritional needs of even the most complex conditions. After all, we help people feel better. For more information about our product line, please visit medtrition.com.
Hi, my name is Carly Rush, and I'm a registered and licensed dietitian. I work as a neurology dietitian for the UF Health Bixel Institute for Neurological Diseases, and I'm also pursuing a doctoral degree in nutritional sciences at the University of Florida. I've been a practicing dietitian for 4 years and currently serving as president for the Gainesville Academy of Nutrition and Dietetics. This morning, I have the honor to introduce the next session, the Purpose and Role of Dietetics and Nutrition Practice Act Challenges. Question and answers will be held at the end of each session. Use the chat box during the presentation to submit your question. Now please welcome the following speakers, Stephanie Petrosky and Chris Cheney, our advocate for licensure. A veteran of Florida's legislative and appropriations process, Chris Cheney joined the advocacy group at Cardenas Partners after having served at the highest levels of state government. He served as the Legislative Affairs Director at Florida's Agency for Healthcare Administration and was the chief lobbyist on all policy and appropriation issues before the legislature, including the licensure and regulation of all healthcare facilities in Florida, as well as operation of Florida's Medicaid program. Prior to his time at AHCA, Mr. Cheney served as a member of then Governor-elect Rick Scott's Health and Human Services transition team. Stephanie Petrosky has enjoyed a diverse and exciting career as a registered dietitian nutritionist and loves making nutrition fun. In addition to clinical practice in hospital and outpatient settings, she has held executive operational roles within national healthcare companies and senior living communities. She received her professional training from Florida International University and earned an MS in Health Services Administration from Capella University. Stephanie is completing an advanced practice doctorate in clinical nutrition at the University of North Florida. With 30 years of teaching experience, she has been active in many leadership roles. She is proud to be a past president of the Florida Academy of Nutrition and Dietetics and currently serves as the chair of Florida's Dietetic and Nutrition Practice Council, which oversees the licensure in Florida. On a personal note, Stephanie enjoys the beach, reading, long walks, learning new things, and mentoring others.
Good morning, everyone. This is Chris Cheney with the advocacy group at Cardenas Partners. Our firm has had the privilege of representing the Academy for several years now, and I'm here today to walk you through a summary of the 2020 legislative session. Just a bit of background here on sort of the general mindset of both our governor and Governor Ron DeSantis and our legislature, very deregulation minded. So in Governor DeSantis' first month in office, he convened a public meeting in Orlando that they dubbed Deregathon. And he, along with the lieutenant governor and the secretary of the Department of Business and Professional Regulation, Halsey Beshears, they met with representatives from each of DBPR's 23 licensure boards, and with the goal of gathering some ideas about some outdated or less useful regulations that could be removed in order to allow Floridians to get to work a little easier, to start a business a little easier. And I say that just to sort of give this background to kind of where we are generally speaking as it relates to these policy issues that the legislature has to grapple with every year. The activity around Deregathon resulted in the filing of two bills, Senate Bill 1640 by Senator Albritton and House Bill 27 by Representative Ingoglia, that would have removed or eliminated around 50 different regulatory pieces of language that mostly were housed under DBPR. And those bills did not include any language around the practice of dietetics or nutrition. But there was some deregulation activity during the 2019 session as it related to healthcare. Like many times in the legislative process, a negotiation sort of, took place around the DBPR dereg bills. And ultimately, the House and the Senate were not able to get those packages across the finish line, even though they were priority bills for both for leadership in both chambers, and they were priority bills for Governor DeSantis. Be that as it may, they could not come across the finish line because of differences of opinions on a couple of different matters. But the legislature did take pretty major actions around deregulation in the healthcare space that year. So Speaker Jose Oliva from Miami, his top priority during the 2019 session was the elimination of the Certificate of Need program. And for those of you who work in the hospital setting, you're probably familiar with CON. Basically, the state requires a certificate of need, or basically permission from them for any hospital to build a new hospital, in many cases to expand bed capacity or add specialty lines, to add lines of tertiary care, et cetera. And Speaker Oliva saw that as something that was hindering growth and competition in the hospital industry. Those issues were priorities mostly for House leadership. Going back a decade, bills were filed that would eliminate CON for several years, and ultimately they were never able to get it done until 2019. And it was amidst fierce opposition from the hospital industry, who, you can imagine they're very significant political players in Florida. And so I say that, is sort of just further background on where the legislature and the governor has been on some of these issues. So during this session, the 2020 session, the DBPR professional deregulation bills were back again. Both Senator Albritton and Representative Ingoglia filed those pieces of legislation again. They were House Bill 1193 was Representative Ingoglia's bill, and Senate Bill 474 was Senator Albritton's bill. There were the House and the Senate packages were different in a handful of ways. They took different approaches to certain pieces of the deregulation, but the one major difference that was included in the House bill the Senate bill was silent to was essentially the creation of a Title Act for the practice of nutrition and dietetics, and that was contained in House Bill 1193. The House sponsor is going through and continues to go through something of a health transformation of himself. He's worked very hard to lose weight. He works out religiously, and when we went to speak with Representative Ingoglia, it became clear that he had tried to access the services of a dietitian or nutritionist, but reported that he was unable to find one that could see him inside of 6 months. So that led him to further explore how to create a little more access to these services, and he chose to do that by essentially deregulating the profession was the goal. It wouldn't have completely eliminated our Practice Act, but essentially it included language at the very end that said anyone could do this for remuneration as long as they didn't hold themselves out to be dietitians or nutritionists. So as long as you didn't call yourself an RDN, for instance, you could basically serve, you could provide the entire scope of services that an RDN is allowed to provide without any of the education requirements being met, without any of the internship or experience requirements. And so that obviously was very concerning to us. You'll see kind of what we did initially and how we engaged. So the lobby team, our firm, identified the language that was problematic in House Bill 1193, and we immediately notified the Academy's leadership, and we set out to engage members of the legislature and explain some of our concerns with the proposal. We did sit down with Representative Ingoglia pretty much immediately, and he explained that explained the health journey that it was on and some of the things that I discussed just a minute ago. We also went to meet immediately with the Senate sponsor, and we wanted him to know and make sure that he was aware that there was language in the House bill that was very concerning to the Academy, and that we had hoped we would hope that he would not include that provision in his bill as it moved through the committee process and ultimately went to the Senate floor. We also went about meeting with some members of the legislature who have historically been very supportive of the Academy and our mission. Those members include folks like Senator Gail Harrell, who chairs the Senate Health Policy Committee, Senator Aaron Bean, who chairs the Health and Human Services Appropriations Subcommittee. We met with Chair Magar, Speaker Magar, she's the Speaker Pro Tem, expressed some concerns. We met with Representative Colleen Burton, who chairs the House Health Quality Subcommittee. It's the committee that has direct jurisdiction over healthcare practitioners, and sort of explained, two different messages. Sort of in the House, it was, what can we do to help leadership understand our position, and in hopes of an open-minded sort of dialogue moving forward. And then in the Senate, it was, please let's support the Senate position of no language. I will say that regardless of any member's position on the language itself, we had an open door to everybody, and Stephen Shiver, my partner who works on your issues at our firm, and I very much appreciated that, given the importance of the bill both to House leadership and to Governor DeSantis. And that's sort of a nice dovetail into some conversations that we had with Governor DeSantis and with his executive staff. We met with folks on plaza level, so folks that the deputy chief of staff that oversees healthcare issues and the Department of Professional Regulation. And we also met with folks in the Governor's Office of Policy and Budget and expressed some concerns. It was made clear to us that Governor DeSantis wasn't super engaged one way or the other on the dietetics issue. It was a new issue for him. But the bills themselves were very, very important to the governor. They were very important to Secretary Beshears at DBPR. And so, ultimately they wanted the bills to pass. And so it became very clear to us at that point that, our mission was to make sure that, if these bills pass, that the language was in either not in the bills or in a position that we could live with. So we also sent out some communication to the FANS membership and asked them to engage with their local elected officials in the House and the Senate in the form of email communication, calls to their office, social media engagement, etc. That was very well received by the membership, and you folks always mobilize very, very well, which is an important tool for us in your representation. And so I want to thank you for your continued engagement on that level. It's very, very important to your cause. And so that sort of leads us to the negotiations that took place. At a certain point, it was explained to us that the Senate was going to include the House's language in their package, and that was not good news at the time. Something that we had hoped to avoid. But again, given the importance of the legislation, both to the bill sponsors and to leadership, they felt like something had to be done because it was so important to the House sponsor. He made it clear that of all the issues in his legislation, it was amongst the top 1 or 2 or 3 issues that he wanted to see get across the finish line. And so we continued the dialogue with our supporters in the Senate and the House. We continued the dialogue with the bill sponsors themselves. And then your leadership at the Academy went about drafting some language that we felt would be something of an acceptable middle ground that would protect the sickest Floridians who required nutritional intervention, while also meeting House leadership's goal of providing a little more access to more general and less medical or clinical weight loss advice and counseling. So essentially where leadership landed was, and I say leadership, I mean the Academy's leadership, where you all landed was basically allowing for general advice to be given about weight loss, general nutrition advice. That some of those exemptions already existed in the statute, but we made it clear that if a patient was under direct care of a doctor for a disease state or a condition that required nutritional intervention, then those services had to be provided by a licensed professional, either a dietitian, a nutritionist, an RDN, et cetera. Some of the practice that's still, that's in the statute, that was in the statute currently and continues to reside there. And so that was sort of our way to have the compromise that was necessary. Our fear was that if we dug in and simply tried to create a situation where we were whipping votes against the bill, that we would be, unsuccessful, and it was clear that the bills were going to pass in some form. And so, worst case scenario would have been for us to dig in and have, the bills pass with the House language in it and go to the governor. He would have signed the bill, and essentially your practice would have been deregulated. So we felt it was prudent to take that approach. Candidly, the leadership in the House did not want to accept the compromise language. We really kind of take it down to the absolute wire. House Bill 1193 was one of the last bills to pass during the legislative session. We were able to continue to make our case to folks who support the academy in the Senate as it was making its way to the floor. Folks like Senator Harrell, folks like Senator Bean. We had them ready to, armed with information to testify, to speak on the matter, et cetera, to express some concern about the deregulation, in an effort to sort of provide an environment where the House partners would be a little more willing to accept the language. And I think ultimately we were successful in doing that. It was one of the last bills to pass during the session. It was one of the last, big and important contentious issues for leadership. There were other issues in the bill that needed to be worked out as well. Things like the interior designers come to mind. They had to have a compromise, and they accepted some language as well. And so it was a scenario where, while ultimately we didn't want anything to pass, we found ourselves in a situation on day, call it 58, 59 of a 60-day session, where if we didn't push hard for the compromise language, we were going to wind up with the really bad language from the Senate and from the House. And so, I was pleased that we were able to get that language included in the bill. Ultimately, we would have preferred for nothing to happen, obviously, but nothing happening was never really an option, and that became clear pretty early in the process. And so, when the House agreed to accept the compromise language, we were very pleased. And while I know that there are some members who are disappointed about the change, I hope that you understand that your leadership worked extremely hard all hours of the day and the night to try to get a result that was workable for you. And ultimately we landed on protecting essentially medical nutrition therapy as a practice that only a licensed provider could practice. And I'll just provide a little further background on some other big issues that passed during the 2020 session. House Bill 607, direct care workers, by Representative Pigman, and Senator Albritton was the sponsor of that bill in the Senate as well, essentially created autonomous practice for APRNs for the first time. That was an enormous issue for the Florida Medical Association. That's the trade association for Florida's physicians. They're a major political player and fought tooth and nail and ultimately were unsuccessful in defeating the legislation, and that passed. And also the practice of pharmacy, which is House Bill 389 by Rep. Sirios and Senate Bill 714 by Senator Hudson, expanded the scope of practice for licensed pharmacists in the state and allowed them to both test for and treat minor medical conditions, things like the flu and strep throat, et cetera. That also was opposed very strongly by the Florida Medical Association, and they were unsuccessful as well. Those bills were sent to the governor and signed into law on the day they passed the legislature as something of a message. And so, the environment remained very, very difficult for protecting regulations around healthcare and scope of practice, et cetera. And, where others, lost completely, the Academy was able to land on something of a middle ground that we think will continue to protect Florida's most sick individuals who require nutritional intervention. So, thank you for your continued confidence in our firm. Our relationship with the Academy has been just a great one over the years, and we're very grateful for the opportunity to represent you in the Capitol. And I want to just take a moment to thank the Academy's leadership, who takes time away from their practice, takes time away from their home and their families, and comes to Tallahassee and fights for you and the members of the Academy. Without your engagement, without the leadership's engagement, our job would be next to impossible. And so I want to thank you for that. And at the appropriate time, I'm happy to take some questions. So thank you very much. And I hope you're having a very successful virtual conference.
Good day. This is Stephanie Petrosky. I'm the current chair for the Greetings. This is Stephanie Petrosky. I'm the current chair for the Dietetics and Nutrition Practice Council. Today's meeting, I'm kind of prepared an overview of some of the current issues related to the council and trends within licensing. These are my disclosures. I work for Nova Southeastern University, and I'm here today representing a volunteer position on the council, which is appointed by the Florida Board of Governors. And I have no personal or professional conflicts that would limit my presentation today. This is an overview of the session. I thought it would be helpful to talk a little bit about some of the trends and changes in the Florida license. You have also heard from our lobbyist who will have gone through this in detail. So I'm going to focus a little bit more on the council and the unlicensed activity. So I'd like to always start with the question, what is a nutritionist? Most of us get that question a lot in our practice. It is definitely a little bit more complicated to answer these days. And the other question that we always get is, what does a nutritionist do? Both of those questions are relevant in the scope of licensing and trying to explain a little bit further about how the laws regulate our practice. So let's talk about Florida practice. Let's kind of lay some ground rules down. Licensure began in 1988, and there's lots of details in our licensing presentation that went before me. Just a little bit about some of the obligations that we have to do is renew biannually and keep up with our continuing education, as well as really trying to advocate and protect for the public. Some of you may not know that when this license first took place, that there was an adoption of nutrition counselors, a profession that was kind of acting in its own interest and was grandfathered in, but right now their numbers have dwindled quite a bit. Currently, we have 5,465 active licensed dietitian nutritionists and about 76 in counselors. This slide was borrowed from the Academy of Nutrition and Dietetics that really plays a very advocate role in tracking and trending where licensing occurs. And you can see Florida is one that really has a primary specialization related to licensing, but there are a few states that don't have the same level of regulation, as well as some that have maybe a title of practice that we've been fighting very hard to keep that sole propriety. So who is eligible in licensure? There's a few bullets here that will come in as we move through, but most importantly, it's a minimum education qualification. Also 900 hours, a minimum of pre-professional practice. There is also an alternative pathway that individuals can put together 900 hours of pre-professional experience. Individuals also have to have a minimum of a licensing board exam. For many years, it was the Commission on Dietetic Registration exam. It's now, since 2015, we are accepting the Board of Clinical Nutrition, Certified Nutrition Specialists, and the diplomates of the American Board of Clinical Nutrition. We also have endorsement from another state, so a licensee can petition to receive licensure reciprocity here in the state of Florida, and also temporary permits. Just so you can kind of center yourself, it is important to read what the law provides. There is really an effort to articulate that basically minimum requirements are placed, and then a license would be required for the scope of practice that's related to nutrition assessment counseling, especially when there is remuneration or payment exchange for those services. One of the things that I want to start to help you understand that this licensing bill or Licensing Practice Act really is specific to our profession, and that many other health professions are exempt under the license. And that actually can be a very extensive list. This is actually there's 13, the numbering's a little bit off, but there was 13 different professions that were articulated there. So as long as the individual is performing services within their scope of practice, for example, nurses are allowed for nursing nutrition education, psychologists may be working with therapies around feeding and eating behavior. So those are just some good examples. Further into the exemptions, there's actually more exemptions in our bill than the true licensed practitioner. So dietitians work in U.S. government or cooperative home extension services, students, educators, and those educators that also work for state government and municipal agencies. Anybody who markets or distributes food or dietary supplements, employed by a hospital, a nursing home, assisted living facility, anybody under regulatory laws, and possibly employed as a diet technician. Or basically the bottom line is, if you're giving out free information, is also exempt from licensing. So then you wonder what is the kind of requirement for us. This is actually something I want you to take note of, because I'm going to address it a little bit later in the presentation. I've highlighted it in green because it's very similar to the language that came up this past year in House Bill 1193. And the reason that it's there is because for many, many years, the weight loss and weight management industry was lobbying against this, and it was a compromise originally to kind of afford the supervision in terms of this industry. So that is actually already existing in our law as an exemption. One of the next parts of my presentation, I'd like to address a little bit about the individual license responsibilities. So if you have a license in the state of Florida, and there's, as I mentioned, nearly 6,000 of them if you count inactive or delinquent licenses that are kind of in that overall group, you have the responsibility to keep the Department of Health informed of your changes. And I think that that's actually one of the things that I see most people do not pay attention to. So you change a job, you move a house, you really need to follow up and prepare that update to the Department of Health. It is a lawful obligation. You also have to keep up with your continuing educations and file them through the CE broker. And you are responsible for your timely fees renewals and the mandates that come forth. For example, the mandatory education that has been put out for human trafficking, that is a requirement now of licensees in the state of Florida. And of course, practicing under the safe standards of practice that are under the law. In the standards of practice, which follows under the Florida Administrative Code, 64B8-44. That is the very specific administrative code that outlines the way that practitioners as licensees need to abide by their practice. It does give a lot of detailed information about assessment, fraudulent and deceptive practices that could also be marketing and leading false, misleading claims, You can also really get a lot of detail about the fines and the values of some of your actions should you come into conflict with the law. And then really the most important part of that administrative code is what is the scope of practice and how those things are defined. This is the most common question I get from people is, what am I allowed to do? And I will never interpret the law for anybody. I will say, get in touch with your lawyer, find a copy of the administrative rules and read through them so that you have a very good understanding of what they mean. A really good example of that would be in good faith of trying to work with the relationship of physician. What does that mean? Are you going to take a prescription? Are you going to have a phone call documentation? There's lots of ways that you have to make decisions about your practice, and sometimes that could be ethical. So these are the ones that you kind of want to pay attention to. There are even specific guidelines related to procedures. For example, even colonic irrigation and naturopathy procedures, acupuncture that may come into alternative or holistic health. You are restricted from doing that if it's not related to dietetics and nutrition practice, unless you have a license in that alternative profession. So lots of really good detail that you need to take a look at. Two really important things that I've basically copied and pasted from the law today to share with you is the up at the top, the first bullet, and it really is the verbatim language of what you have to do when you are seeing a patient. As we go forward into the future and looking at our practice, and even in the history of our licensing bill, we are organized under the Florida Board of Medicine. And in that spirit, there has been this obligation within our administrative code here that says that we should take every reasonable action to inform the patient's physician and encourage the patient to consult with a physician and to document that in the record. So that's what the law says. What you're allowed to do and should do kind of are open for interpretation. But you should really use good ethics and judgment and seek legal counsel when you're trying to make interpretation about your business practices. The second bullet deals with the new introduction to telehealth, which came into play in 2019, when we actually worked very hard to get the rules adjusted to allow the use of video technology and software to even be able to do a face-to-face consult as long as you had that initial assessment available so that you could have that face-to-face. So a telephonic initial assessment isn't possible, but with a lot of the HIPAA compliant platforms now, this has really become a very important advancement for our practice, and even more so now in the COVID situation, it is pretty much the standard of practice. I did mention human trafficking. It's one of the most recent updates that has come out, and unfortunately, part of this meeting, you should be able to get those continuing educations document. It's a one-time situation, not something you'll be renewed on a regular basis. Now let's talk a little bit about House Bill 1193, which was certainly the highlight of the legislative session last year, where compromises had to be made. And you'll recall a few minutes ago, I showed you some language in our law that actually limits or actually has an exemption where it does not allow for sorry, I'm getting a telephone ring. The exemption in the licensure practice actually allows for weight loss, weight products, and the language is actually very similar to what you're seeing on the screen here. And the advocacy part really happened when this presentation first came through. House Bill 1193 is actually 103 pages long. It is definitely a small component to all of the deregulation of several licensed professions. So it did include interior decoration and many different professions that were different than us, but we happen to be the only health profession in there. So we got to work on trying to expand the language. When it first came out, and I'm sure you heard some of this as well in Chris Cheney's talk, that we had to do a lot of negotiation with bringing in the language from our bill, and I actually helped kind of advise some of that as we were going through the process. So now at least it says that a person might be exempt from licensure, which is almost similar to what we already have in the bill, but they could expand a little bit to give wellness information and giving advice concerning nutrition. The marketing and dietary supplements were already kind of in there, but the stipulation is as long as that person is not under the direct supervision of a physician. So we don't have any way to really regulate the practice of an unlicensed provider or practitioner or health coach or whoever's going to take this job up, but it could be a situation where you might find it or see it, and you need to kind of look into that situation, and hopefully the ethics is in place for the other person who's providing that service to really find out the due diligence of working with a physician. I just wanted to kind of highlight that for you. It's hard to see so many different lines on the page. I did also mention the telehealth. I wanted just to bring it out a little bit further about the licensing rules and regulations under telehealth. If you're not aware, you should, and you are providing telehealth services. If you're not working for a company that's looking into this, definitely want to check it out. It is a requirement now also that in the state of Florida, if you are providing telehealth services from outside of the state to a Florida resident, you also have to have a license or register yourself with the telehealth service. So that is a helpful development that we have to also regulate in some fashion the individuals that are reaching into the state of Florida to serve our citizens. Now, besides the updates in the laws that I've kind of shared with you, the council continues to stay very active regarding a couple of items that are on our agenda. We meet on a quarterly basis, and right now we have an active call for rules, which means that an open workshop has been noticed to the state and is going to happen on November 5th. We recently, we met in August, and we sent forward recommendations to update the disciplinary action and a health history questionnaire, which has been moving throughout all the licensed professions in the state of Florida to be standard in terms of language and health history questions, really looking into the opioid crisis and some of the sensitive nature of what is asked of applicants when they fill an application for licensing. We have also discussed as a council the need to make any alterations in the continuing education requirements because of COVID, but right now it's just on hold because we feel that so much, and like even today, virtual tools are available that we don't perceive any issues with health licensing being able to, under our practice, get enough continuing education. So we're going to be reviewing that maybe in January to kind of revisit and see, and hopefully if you have any feedback, you can send that into us. But most importantly, two big developments that have come up in the practice of nutrition and dietetics is more and more dietitians are getting involved in ordering lab tests, particularly related to personal nutrition. And it was brought to our attention by an advocacy group not too long ago, and they actually submitted documentations for our council agenda that really showed an incongruency between the Florida law and the current practice or the administrative rules, that they were not congruent. And this often gets us into trouble if we don't apply the rules in such a way that mirror the intent and spirit of the law, or even verbatim what the law is telling us. And therefore, the ordering of lab tests by dietitians, which was restricted in our rules, has now been removed, or at least we've sent it forward to the Board of Medicine for their next meeting. And we are going to be working on the rules development of that into the standards of practice. I think this is actually a positive opportunity for practitioners because now they're able to have a little bit more liberty in practice, but it still continues to drive home the point that the ongoing effort in the law has to always be mirrored in the Practice Act. There's two other things that are kind of on our mind, or possibly, looking towards the future trend and what we're going to be seeing in licensure, and that is the fact that in our profession, the master's is now the entry-level place, and our law currently says a minimum of a bachelor's degree. And this does not take place until 2024, but it's really an important thing that we'll have to think about. Many states have left their licensing law at a minimum qualification. There's even states that allow associate degree. And we have to really decide in Florida what we want that minimum standard to be. So that's going to be a point of concern. The other thing about it is some of these future education model programs do not necessarily have to give 900 hours, which is required in our law. When the academy changed from 900 to 1200 several years ago, the state of Florida did not make that same change. So we only have 900 hours requirement. But so technically, some programs in the future education model of bachelor's might be able to meet that requirement, or that would be more just a diet technician in the future model. So there are some things we're going to have to come into alignment, but every time we have to make an adjustment, that's opening up the rules, and opening up the rules and opening up the laws takes a lot of effort to really manage that. So most of the time we don't take a very active approach unless it's a real important viability thing we want to straighten out. The other thing that I just want to share is in the current Florida law, and this was actually brought to our attention by the Board of Medicine, there is a language where it says that the individual has the minimum of this and or the equivalently prepared. And or equivalently prepared really gives a lot of latitude to what people can submit in their application to say that they are qualified. So it's part of the housekeeping piece that is really very difficult when you have years and years of history. But right now, we are challenged as the council to look at applications in a fair and equitable manner and compare them to the lawful requirements. And in many cases, people with advanced degrees, such as a doctorate or additional training or an individualized pathway that maybe isn't even through ASCEND accreditation, could demonstrate enough proficiency and competency within the profession to successfully be licensed because of that language. And it continues to be an issue every time we get together. And I definitely would suggest either looking over the agenda and minutes that are posted on the website, or taking time to listen in on a call. They even have recordings and you can submit for CEU activities. So let me tell you a little bit about the council and why the council even exists. It is part of the law originally when we achieved the lawful establishment of licensure in the scope of practice in nutrition and dietetics. However, it is organized under the Board of Medicine and quasi-judicial practices that really limit our ability as a rulemaking authority without a secondary review. So we always have to be accountable to the Board of Medicine. The council currently established of 5 different people. 4 of those are professional licensees, and that could be a registered dietitian, or it could be a licensed dietitian, and it could be somebody from the CNS route. And we actually have 2 open positions at this time, and then 1 layperson that comes to us from the general population, usually somebody who's very interested in nutrition and has to be at least 60 years of age or older. And because it is required that the professional licensees are proportionate to the licensees in the state of Florida, right now it's been traditionally 3 professionals and 1 licensed nutrition counselor. So an interesting development is because the LNCs have diminished in volume, we actually could not get anybody to replace the vacant position this year. So we actually put forward to the Board of Medicine 2 qualified applicants under the professional licensed dietitian realm. So that's kind of an interesting development. We'll see what they say when we get back the information from them. The main reason the council exists is to really make sure that we have those minimum standards of practice. Now that we have it and we're holding fast to keeping a scope of practice, not just a Title Act, but a scope of practice, that anybody who falls below that minimum is prohibited from practicing in the state of Florida. But you think back to the list of all those exemptions, that really requires the employer to advocate for licensing as the standard. In education, we don't have to have it, but everybody on my team is specified to have a license. We train dietitians in the state of Florida, so we will only have a minimum of a licensure. So that's where we really have to promote and support licensing, of course, to protect the public health and give that recognizable standard. I mean, I get my hair cut, I get my nails cut, so I certainly look for the license when I go for those services. So I think we have to help our consumers find that same standard for nutrition practice. That's where it gets dicey all the time. Okay, these are the current members. Right now, it's down to just Carol Elliott and myself. We have 2 vacancies. We hope to see that information come back to us in the next month. We may continue to operate as we are, and we also have a consumer member. So right now we're down to 3 out of 5 positions. All right, so a couple of things I want to mention about trends in applications. We still by far have the majority coming through the RDN pathway. The last committee meeting we had, it was about 140 that come through after taking their new registration exam. So we still have a lot of activity in the state of Florida. But there is a lot of uptick going on with those coming through alternative pathways. And I think when we started working with the Board of Certified Nutrition Specialists in 2014 and finally got it through 2015, where we made a pathway possible, that is really a very, I think, major development in how new licensees have come through. And now that we are, really trending in that direction, I think it's catching on, especially because Florida is just becoming a very popular state to live, especially with people moving from the compacted northern cities in California. We also started seeing a big trend in individuals that were seeking reciprocity from Puerto Rico after the hurricane. So we usually have a few on every agenda that are asking for us to compare law-to-law comparison. Also, telehealth providers, because of those new regulations. Now we're seeing a lot of people that have licenses in other states that are asking to get a license in Florida so they can serve telehealth clients. So just again, reminder about the Practice Council. Now, we didn't have the fortunate opportunity to have Mr. Chilo from the Unlicensed Bureau activity in the state of Florida. He usually comes to tell us a little bit about what they've been doing. But I wanted to give you the website there. So floridahealthsource.gov.ula for unlicensed activity. It's a very meaningful effort in licensing or looking at unlicensed activity, because we do have concerns about that. Protect the consumer and, of course, protect licensure in yourself. And one of the things I will say over and over is really take pride in your licensing and make sure you proudly protect that and do everything you need to keep it. There have been several calls that I've been on where individuals just got sidetracked and did not take their professional responsibilities and then ask for leniency. And it's much more difficult to go back after that. We've actually had somebody who was a new graduate last time who thought because she had the certification of her degree and had applied for her RD exam that she was able to just go ahead and start practicing. So before she was even out of her program for 6 months, she'd already had a cease and desist order from the Bureau of Unlicensed Activity because she just opened up a website and started working in that transitional period before she she was qualified but hadn't done the work to get that license in place. So it is a very important piece to be informed, educated, and manage that license. These slides will go a little bit quicker just because I want to, kind of get to the bottom line, which is why does it matter? The Division of Medical Quality Assurance is the one that oversees all the licensing bureau, and they help kind of investigate the issue. So there's 4 different components, just so you're aware. What happens if somebody potentially is acting either fraudulently, or we have the issue of discipline under a licensee? That's kind of a separate issue. This is really what happens when somebody is practicing illegally. It's straight up practicing without a license, the nutrition and dietetics practice. So 2 different complaints that, I kind of referred to would be just issues about the licensed health professional, and then is that person performing unlicensed activity? And getting yourself informed about that is really important. The website I have up there is how you go into reporting. And a lot of the issues that we see are because we're in the practice and our patients come to us, and we are well aware of our own practice. So we tend to see the other issues develop, and it's good that we take a stand and get involved. To file a complaint, you can use the call, and you can actually use the online form, which is supplied in the website before. Under the Consumer Service Unit, they are the ones that really act as the advocate or liaison between the consumers. They receive the complaints and assign a tracking number and really go through the process. Once it's been logged, it gets transferred to the Investigative Services Unit, and that process is really to kind of triage and decide which ones are more higher priority or more relevant to the safety and protection of the consumer. And then they will also assign an investigator who really follows through the complaint, and most of the time will present themselves as an unsuspecting consumer to follow through the process. So it does take a lot of time on the investigation side. Once they have determined that there was cause, the whole process or the case gets transferred over to the Prosecution Services Unit. These are the different activities that could happen based on the severity. A lot of times a cease and desist order is given, and fines are applied, and it can really be a very extenuating situation. And then if they find that the issue is founded of cause, it's then turned over to the prosecution, and then we see all of these other pieces that come in terms of criminal charges and penalties that go with that, and you typically go before the council and before the board, and all of this is adjudicated and on public record. Finally, I'm just going to wrap up with the actual report on an annual basis that you can find on the website under the annual reports for the Medical Quality Assurance webpage. If you kind of put it in perspective, of course, this is just the top half of the chart. There's pages and pages. This is actually the results of investigative complaints. So in our profession, in the last calendar year, there were 8 complaints received. That was it. One second, my view over. 8 complaints, none were legally sufficient. No injuries, no investigations, and no completed inspections. So you have to think about the relevant time period. This is lagging because I know of a few active ones that have actually been happening right now. So the problem with data is that sometimes it's a little bit behind, and the nutrition counselors have equally low activity when you compare to, for example, dentists and some of the other numbers that you're seeing here. So basically, our profession is doing a pretty good job in terms of educating our own practitioners but that we're not seeing a lot of activity on the unlicensed side of what's happening out there. And I think that that's really where the opportunity is, because we know that it exists, and more there's a lot of confusion between what is legitimate legal practice and what can somebody do. So go back over that information in your mind about all the exemptions. Now the changes to the House Bill 1193, it starts to raise a lot of questions about, what is the future of our legislation. The biggest benefit for us is that it allows us to bill. It also allows us to be recognized as a licensed health professional within the group. So it is important to protect it still. There's no doubt in my mind that we want to keep moving forward, even though we don't have the prevalent malpractice that's happening, or not really malpractice, but unlicensed activity. Malpractice would be somebody who has a license and isn't practicing to the standard of care. So this is where you can find the activities and the reports and my contact information related to just how you can get in touch with me. If you send me an email with your questions or would like a copy of the current law, I'd be happy to do it. Everything's available on the Dietetics and Nutrition Practice Council website, but the best thing I could suggest is that you take the time to get yourself a copy and really read through and inform yourself and think about practicing forward.
We do have quite a few questions and comments coming in, so thank you everyone for submitting that. We have plenty of time, but I'm going to try to prioritize the questions for our speakers too, so that way we can make sure that we get those answered. So I'll direct my first one to Chris. Lots of comments coming in about how much we appreciate you, and lots of our members appreciate all the hard work that you do, so thank you for that. So the first question I have is, I'm curious how the congressman attempted to locate a dietitian. Maybe can you, do you have any knowledge that you can expand more on that? And then also, and that just a comment probably towards fan leadership, maybe there's a way the Academy can work on advertising to the general public about finding dietitians better. So any thoughts or comments that you can expand upon that, Chris?
First of all, thank you for the kind words. We absolutely cherish the relationship that our firm has with the Academy, and really enjoy working on your behalf. It's nice to approach members of the legislature with a cause you believe in, and I absolutely do believe that an ounce of prevention is worth a pound of cure, and you folks provide such an important role in the healthcare continuum here in Florida. So thank you for that. Chairman Ngoglia did not, I'm trying to remember I think he basically just went to the internet and, went to Google, tried to call some folks. Now it's important to note that he lives in, I believe he's in Pasco County. He's in Brooksville, Florida. He's pretty close to Tampa, but he's an hour or so away. It's not, I don't know if I'd say it's rural, but it's certainly not, a big populous area where there's a ton of healthcare practitioners out there. So, not super surprising that there isn't like a ton of dietitians in Brooksville, but be that as it may, I think he just kind of took to the internet and called some people. But I do believe that he was being genuine in his saying that. And so, the comment about how the Academy could potentially help folks, advertise their services better. I mean, that's something that I think would be great to explore for sure.
Great. Thank you. Stephanie, lots of questions for you. I'll start off one with about the Practice Act changes. So this question is, many people with obesity also have chronic illnesses like type 2 diabetes, especially older adults. In their opinion, it seems like this legislative change didn't address this. How are health coaches going to deal with it, or maybe just kind of expand more on how this current law, and Chris too, you can expand to how this current law differentiates between obesity and then other chronic illnesses associated with obesity.
I really think it might be better for Chris to talk about it. One of the challenges in the role of the council is that we oversee what the law provides, and we aren't as active in the process of changing, other than kind of establishing how we interpret what's given to us as the law, and then in the regulations of putting forth suggestions and dialogue and opening up the conversations to the whole public regarding how that practice act should be stipulated in those Florida Administrative Code. The challenge is that the licensing deals with the licensee profession. It doesn't deal with people who are unlicensed, and there is a lot of ambiguity. So it has to, I've always thought of that as buyer beware, and the education to the consumer of trying to really help inform the difference between an education qualified person with a license versus the health coaches and some of the other less prepared people that are advocating for nutrition. It's a really complex issue. I don't have a lot of input in terms of what we can do other than to keep doing the work that we've been doing in preparing our own professionals in our membership advocacy role. That we've never had enough activity in that. That's the one area. From the very beginning, I was a student dietitian when the licensing law became a law, and I remember years before all the efforts to try to put that forward and acquire data and look at how we can show value in the services that we provide, distinguishing than others. I, kind of have a opinion about the fact that we do have an obesity epidemic, and we need a lot of help in that realm. So even though I see some of our, restrictions to who can and who cannot provide those services, we also have the reality that as a licensed profession, we don't have enough providers to do the job that needs to get done. So I think, in my mind, I come from an interprofessional background, so I'm really open to helping other professions understand the value of dietitians, working alongside with them. And really, I think the path forward is looking at that universal standard in the state of Florida and keep trying to hold that standard up. I think Chris might have a little bit more on how the old legality works from his background, perhaps.
Yeah, thanks, Stephanie. I will say that first and foremost, I'm not an attorney, and so this is not to be misconstrued as legal advice. But what I would say is, when the statute was going through the revision this last legislative session, the intent was that, our entire sort of strategy was to lay out, some of the potential harm for someone, for an unlicensed or an uneducated, say professional or practitioner, giving poor advice for someone with, say, a diabetic on dialysis, for instance, right? I mean, you could do really serious harm. And so the intent was, while we absolutely understand that, many, if not most folks with obesity are going to have other chronic healthcare issues, when they present themselves to whoever they're getting their nutritional advice from, if they say, look, I want to lose weight, I want to be healthier, it's important to me, but and also, by the way, if they say, I'm on dialysis because I'm a diabetic, or I have liver disease, et cetera, those types of things, then those professionals are supposed to not, give the nutritional advice, and they're supposed to refer them to a licensed dietitian or nutritionist. Now, how that, comes into practice, that may be the kind of thing that would require, some sort of rulemaking. I don't know. It also, the way I see it, it would be a lot like our current sort of reporting of unlicensed activity would go. If you see these types of things happening, and that a patient is receiving nutritional advice and has these other comorbidities that they're being managed at the physician level, then that it's incumbent upon us to report that activity is, I think, the advice that I would give.
Yeah, absolutely. And excuse me. It seems like this is probably a gray area. I know, Stephanie, you said that we can't regulate unlicensed professionals, so it's probably going to be maybe more of a gray area where if they don't ask and the unlicensed professional doesn't know, then it's kind of hard to intervene without reporting the unlicensed activity is kind of what I'm hearing. And I guess kind of jumping off of that, Stephanie, maybe can you explain the whole process of reporting unlicensed activity and if there's a way to anonymously report?
Yeah, that's a great question. I have been in that position now a couple of times where information comes to my attention, whether I'll give you a good example. I happen to love the Florida Panthers hockey team, and one time during a game, there was a quick little advertisement for a personal training outfit that was helping our goalie get in his fine, status, and they advertised that they had a dietitian, and I was like so excited, so I Googled it up right away, trying to figure out what was going on there, and slowly and surely began to realize that they had somebody who was performing nutrition counseling services, and you could follow, really into the process by linking into everything, and it was clearly practicing without a license, because the next thing I did was go to the licensing lookup for the state of Florida. That's the very handy website. You just look for Florida Department of Health licensee lookup, and you could check the status of any license in a health profession in the state of Florida. And once I did that and realized that the individual wasn't currently licensed, I had a personal decision to make. Here I was, the chair in this, active role that I felt like I had to walk the walk. It would have been so much easier to just kind of close up my laptop and forget about it. But I felt like the duty had to be fulfilled. And so I went through the process. It's a simple form. And I had learned through the process that even though there's a requirement on the form or a notation on the form to leave your name and contact information, because it certainly adds to the validity of an investigation to learn more details about what you found, it isn't required. They will investigate the complaint with or without information about the person who's reporting. I chose to report, so I was able to get a contact directly by the investigative officer. I was actually very impressed with the level of detail. She informed me of how she had investigated, how she had spoken to the owner of the gym, as well as the individual in the allegation, and helped inform them that this was indeed practicing without a license and unlawful practice. When you start using those terms, it does really help people understand the context. And in the health and industry business, it is very predominant that sports nutrition doesn't see themselves in that area as being under the realm of medical nutrition therapy, even my own conversations with individuals. So you have to make a personal choice. The licensing, the reporting of unlicensed activity means you have to get involved. And it's easier sometimes to forget about it because you think that you might be exposed, or there's a very small distance between you and that other provider, perhaps, and you want to keep professional appearances. So there's lots of things that cause us to not report. But the data in the system and the dedication of the state of Florida to really investigate that unlicensed activity is what we pay for. Our licensing fees that we pay is to, really have that activity monitored, investigated, and let somebody else be the judge. But when you start seeing questionable practices, and certainly the use of internet and telehealth have really opened up the fraudulent as well as legitimate practice. So it is difficult for us sometimes to really know the difference related to the law. And the best thing I could say is go to the unlicensed activity webpage, take the time to understand how to report. Another really good example is somebody I dealt with on a personal level that came to my attention as a friend of mine had gone to a yoga fair, and at the yoga fair there was an individual who was giving vitamin B injections at the yoga fair, was using the credential of registered dietitian, was a licensed acupuncturist, and we thought about what that really means. And we went through a lot of even contacting the Commission on Dietetic Registration, because that is improperly using the RD credential, I think. So the person gave up licensing in the state of Florida under nutrition and dietetics practice when she achieved status as an acupuncturist, but then was putting together questionable practices in a public setting where I think health and safety were an issue, as well as non-scientific evidence-based practice not really being used in vitamin B injections for energy boosting. So there's another complicated issue, but the question of whether or not that's unlicensed activity is complicated. It's an ethical issue. It's an RD credential issue, but not really unlicensed in the scope of nutrition and practice because she didn't have that license. So all of those kinds of things should be looked at as well. So again, go to the online form. There's also a manual form you could print, send it in. And if you have any additional questions, my contact information was provided. I'd be happy to, talk with individuals in terms of specific cases. But again, I just want to reiterate, the council doesn't do the investigation side of it. We interpret the licensing of applications and the scope going forward. So the unlicensed activity is done through the unlicensed activity agency.
Great. Yeah, and kind of what I'm hearing too is like really just this call to action for professional duty and responsibility to see it, if we see it, to report it and let the state, work through the logistics of, is this unlicensed activity or not? And that way we can just really further, one, protect our profession, and also just the health of Floridians too in the state. And with that too, I want to ask Chris, how, this is just a question of mine, how important is reporting unlicensed activity for our public policy efforts in Tallahassee and maintaining our licensure?
Well, look, to the extent that the unlicensed activity exists and it's potentially, harming Floridians, I think it's important. To Stephanie's earlier point, there isn't a ton of unlicensed activity, reported annually, and so it's not necessarily something that we run around the Capitol, with a paper waving it around saying, look, there's all this unlicensed activity. We need to protect the license. I think a much more effective message from that standpoint is, look, there's real potential harm for folks who are sick to be receiving these nutritional interventions from untrained people, and that's why the licensure is there. The education is super important. The experience requirements are super important, and the last thing we want to see are folks who take a 4-hour course online and they're prescribing diets for folks with with serious medical conditions, and then we've got some bad outcomes. That's that's a worst case scenario. So I think it's important when you see it, but from an advocacy perspective, it's less impactful than just explaining the science behind why we think why we believe this education and experience is so important to the health and welfare of Floridians.
Gotcha. Thank you. Let's see, Stephanie, we had a question in about what do you think are chances of FAND having its own professional board? I think the context of this question was outside from under the Board of Medicine umbrella.
I have thought about that so many times, discussed it a lot with the public policy committee and the FAND leadership about the advantages. When I go on an annual basis, Carol Elliott and I attend the annual boards and chairs training that is done. We look at across, so many different professions, the pharmacy, physical therapist, acupuncturist, everybody that's licensed in the state of Florida goes to this training. And we are becoming a very small group. And you have to give, appreciation to the original spirit of that compromise was Chris in his presentation talked about the Florida Medical Trade Associations that were really up against us when we wanted to seek licensure way back, over 30 years ago. It was a compromise to work with the physicians. And if you go back, and I presented it today in my notes, that the law really has a little bit of a latitude, interpretation. Read that and see for yourself. It says that we'll be diligent in trying to notify a physician. Most of the health insurances now in the state of Florida do not necessarily require an order by a physician. They ask sometimes under managed care for referrals, and certainly the whole billing and reimbursement piece is another whole presentation. But in the law, the interpretation could be that, the relationship is there for the physician. And while several years ago, I was, all about getting out from underneath the Board of Medicine so that we would have more autonomy and power to make these decisions, the Board of Medicine has not been a problem at all. They've actually been very supportive of changes. And in this current situation that we just went through, actually turned out to be a very important piece that we had that relationship between the physician, who is really the primary care, provider with clients, specifically those that are sick and need medical nutrition therapy. I can also tell you in the last couple of years that I've been to the Board of Medicine meeting several times. They have been very vocal about who should be qualified to give nutrition care. So there's really an opportunity for all of us in the state of Florida to continuously work with our physician partners to help them understand and, again, appreciate the value of dietitians and our training. And just a really good example of how they have supported it is recently some very brave dietitians in the Central Florida area actually petitioned for basically clarification of duties and ask for a formal statement from the council, which was then deferred up to the Board of Medicine to determine whether or not they could place feeding tubes. And I thought it was extremely brilliant. I've, from years ago being in nutrition support, we've always said we need to be there on day one. And ultimately the delays of feeding compromised, hospitalized patients go several days. And why not get the dietitian skilled and trained to the competencies to be able to do that? Because our preparation is very similar to the background of knowledge of anatomy and physiology. And it was actually a very interesting challenge to see how the Board of Medicine really supported us. And yet, while I went to those hearings to support the dietitians who were basically on trial, so to speak, to advocate for themselves and get a declaration statement formally to allow them the privileges that they needed to do this in their hospital, I could also see that the physicians didn't really clearly understand the level of fortitude and competencies that we have continued to evolve. And I think that goes along with supporting the change in our profession to the graduate entry level at a minimum, so that, with speech language therapy and physician assistants and, in line with all of the changes in those health professions, we come up in equal footing and continuously, work in training future physicians as well about our role. And I think that relationship is vital. And so right now, I think the climate is such that we are suited well where we are. We have a very good relationship with the Board of Medicine. Any of you can attend their meetings as well. They're open to the public, and it's phenomenal to see some of the things that go on, especially when people start to cross the line with what their licensure practice allows. And the health and aesthetics industry is a really good example of that in terms of practicing medicine unlawfully. So that's kind of my view personally on it. But I think it will take a lot of effort from a lobbyist standpoint to make any changes in the law, because it's not just in the Florida Administrative Code, but it's in the law that stipulates how the council reports. So it will mean going to a sponsorship from either a senator or a representative to put forth action. And now that you've heard a little bit more from Chris Cheney and the atmosphere of deregulation, that could actually be an open can of worms that may not be advisable for us right now. And I don't think that it's limiting us in any forward motion of our practice, and has also given us some protective benefits, at least for right now. Chris, maybe you have some comments?
Yeah, I can add a little bit to that. I mean, I think, Stephanie, you touched on it just, at the end there. I mean, the general environment in Tallahassee, both in Governor DeSantis's office and in the House and the Senate, that are controlled by, folks who would probably identify themselves as free market Republicans. There's generally not a lot of appetite to create more bureaucracy in state government, which is how, a new licensure board would probably be viewed. We actually, this is going back, probably maybe 4 or 5 years now, sort of toyed with the idea of approaching some members of the legislature to create our own licensure board and move us out from underneath the umbrella of the Board of Medicine. It was not super well received, and we did it at the time when we were, I think we were looking at independent diet order writing, and so we really sort of narrowly focused our efforts on that issue during that year, and we were successful in getting that across the finish line. And then the next year, really, the big moves for deregulation kind of started, and we made a strategic decision at that point to sort of back away from anything proactive and to retain all of our political capital in defense of just protecting the license, frankly.
Gotcha. Yeah. And Stephanie, can you provide us on more information on how, if we wanted to join some of these, the Dietetic and Nutrition Practice Council meetings and listen in, or any of the other like Board of Medicine meetings, like you mentioned, how someone can do that?
Gosh, I would love to see more individuals. So even if your time does not commit, typically the council meetings, we meet on a quarterly basis, and they usually last an average of about 3 hours. I'm really proud to say that since I've been the council person, chair for the last 3 years, we have always been telephonic. And I have been pushing and pushing to get, at least with some of our technology, a platform that would allow us to have a little bit more nonverbal communication, as well as just make it a little bit easier to manage the conversation. Sometimes it gets very difficult with some of the sensitive information we're trying to sort through. So by now, this last meeting in August, we actually have it on a GoToMeeting platform, which can be done either with a downloaded app or a web browser. But I had provided the information in the presentation, which I see the copy of the slides are also posted to give you the link. So go to the Florida Department of Health Dietetics and Nutrition Practice Council. We have a website. It will articulate both the council makeup and when our terms are changing. It's a rotating basis. And it also lists the meetings. And when you click on meetings, you will see all of the meetings. They're posted a year in advance. We have to set our calendar that far up. We post the agenda, and then we post the minutes and an audio recording after they have been completed. So what you read in the minutes do not by any means reflect the detail and the conversations and some of the real subtle pieces that people are very surprised to hear. It is definitely a labor of love. I will speak, for myself and those members. Stephanie Norris rotated off recently. Her term just ended. It is a 4-year term, a lot of time that we take. We think of ourselves as guardians of the profession, but on the other hand, we're also peacemakers and trying to move forward with how does the future of dietetics and nutrition practice look in the state of Florida. So once you listen to a call, the first part of the meeting is typically all the license applications that are non-traditional. And we typically outline the guidelines for the council office. We have an administrative staff in Tallahassee that does the routine work. So we don't get into the details of every application. The only ones that hit the agenda are the ones that are non-traditional. And the last meeting we had, I think, was over 16 applications. A good meeting is 2 to 3. Sometimes the typical has been more closer, anywhere between 8 and 10. And these are where we go piece by piece, page by page of the documentation supplied by those individuals. And they also do a public book within the brief time period, which shows you some of the handouts and details of information that we're looking at behind the scenes in our file. So that's for the council. The Florida Board of Medicine, which is the allopathic practice. There's also Florida Board of Osteopathic Medicine. So we are not associated with them other than working with them as qualified physician providers. But our council is under the Florida Board of Medicine. If you look for their website on the internet, they also follow the same process where they'll post the meetings and the agendas. They have been actually moving their meetings across the state of Florida, and they rotate. So sometimes they're in Miami, sometimes they're in Tampa. I look for the agendas, and anytime anything related to nutrition is up there, I at least monitor and try to go. They've been working by virtual meets recently, so you can take a look at that. And I'm waiting for those results to come back. So once we send our work up to the board, we are waiting for those to be seen and heard on the agenda. We're typically on the last part of the agenda, so it's a real diehard service. But you can also get continuing education for attending both of the meetings. You just write to the council office and they'll send you the CEU activity for that.
Perfect, thank you. So we only have a couple more minutes. So a real quick question for Stephanie. Can you share how the requirement for a master's will impact those who don't have a master's but have been practicing for about 20, 30 years?
Actually, in the state of Florida, there will not be an impact until the law is changed. That's what I tried to bring up in my comments, because I'm trying to make sense of how we're going to follow along. And every time the profession makes a change in the standard, the state of Florida has to consider the benefit. So right now, the law says at least a minimum of a bachelor's degree. So the master's degree requirement by the profession does not necessarily have any impact on the state of Florida. The issue that I want to bring up is that because the future education model, which will be, kind of the main pathway after 2024, is a coordinated program. And right now, there is not a minimum requirement of hours set by the Ascend guidelines that may be interpreted that possibly, if we don't change our Florida law, that those in the future education model for bachelor's programs, which are really producing nutrition and dietetics technicians registered, may have a difference in terms of clinical hours. So the law right now says at least a minimum of a bachelor's degree, 900 hours of supervised training and or additional training, equivalencies to offset that. So somebody could get just the bachelor's degree as a technician prepared program and then do their own 900 hours documentation and then be qualified. The licensing exam currently in the state of Florida is the CDR exam. So even those that don't graduate from an Ascend program can take that licensing exam. They can't use the credential of registered dietitian, but they can qualify for licensure and then use the title LDN, licensed dietitian nutritionist, which is the state of Florida. So it is a little difficult. And that's why I was saying, I think going forward, our leadership in the association should be working with our advocacy group and considering these long-term implications of what standard we want to be forward with. The Board of CNS, just as an example, requires at least a graduate degree and 1,000 hours of training. So even though we're using their board exam, they still have to meet the Florida requirements, and we put them through that as well. So not clear pathway, but we just got to keep moving forward. Thank you again for your time and your attention to this very important topic. It's been a pleasure co-hosting with Chris Janey. We appreciate all the work that you've done. And we definitely appreciate the association's efforts to be active in the council's happenings.
Yes, thank you both. I'm going to say too, I'm sorry if we weren't able to answer some of your specific questions. I would direct definitely those specific licensure questions to the Dietetic and Nutrition Practice Council's website on the Department of Health. Stephanie's email is also in those PowerPoint slides, so if you want to reach out to her about those specific questions, you can do there. Chris, Stephanie, thank you so much. I think we had a really great discussion. We really appreciate your time.
Yeah, thank you, everybody. We just, again, so, honored and humbled to be able to represent the Academy and its mission in Tallahassee, and, looking forward to continue to do some more work. And once again, just if there's one takeaway for everybody, please stay engaged and look for those action alerts when sessions are rolling around, because things happen quick. So thank you.
Thank you. So we're going to transition to about a little less than a 15-minute break, and our next session is going to start at 12:30. Thank you, everyone.
Heal Right is a delicious food that comes in these convenient micronutrient squares. Heal Right is totally different from anything else. Some have called it the most nutrient-dense food in the world. It was scientifically developed and clinically tested by an esteemed group of doctors and researchers in collaboration with the USDA. In clinical research, Heal Right positively impacted factors related to obesity, diabetes, heart disease, and digestive disorders. The outcomes were groundbreaking, some even life-changing. Heal Right has all the missing micronutrients and the other building blocks of health that are missing from the normal diet. It gives your gut's microbiome what it desperately needs to be healthy. When our microbiome is healthy, it is our defender and healer, and serious health conditions can be managed or even prevented. Learn more by visiting healright.com. Heal Right, health from within.
Good afternoon. My name is Jennifer Beery, and I have been honored to serve as FAND Secretary with this amazing Board of Directors and committee members these last few months. It is my honor to present to you the 2019-2020 Florida Academy of Nutrition and Dietetics Awards and Recognition Program. I invite you to sit back, relax, and share with me as we recognize our fellow Florida Academy of Nutrition and Dietetics members who were nominated by their peers and education leaders for their outstanding achievements in academia, careers, and in the communities they serve. The Florida Academy of Nutrition and Dietetics Foundation offers stipends and scholarships to Florida Academy of Nutrition and Dietetics members. They are awarded to further education, obtain certifications, gain leadership skills, and involvement in professional activities. This year, the Scholarship Committee awarded 5 stipends to attend this year's Legislative Day in Tallahassee on February 25th. Congratulations to the following recipients of the 2020 Legislative Day stipend. Laura Chismar, Suncoast. Carly Duffy, Suncoast. Lauren Larger. Kelly Urbanic, Central Florida. Brittany Wood, First Coast. Legislative Day stipends provide reimbursement toward registration, travel, hotel, and meals in order to attend Legislative Day activities. A list of stipends available may be viewed on the eatrightflorida.org website. Congratulations again to our Legislative Day Stipend Award winners. As you may have noticed, we asked all of our awards recipients to tell us their favorite fruit or vegetable. This is a fun way to learn more about each other and to be more engaging with you. As you can imagine, narrowing it down to just one fruit or vegetable for us dietitians can be hard. We've also included the district that these recipients represent. Next, we recognize each of our scholarship award winners. Established in 2018, the Gail Caldwell Scholarship is awarded to a graduate student accepted or enrolled in a graduate level dietetic internship program with a GPA minimum grade point average of 3.2 to 4.0. This year's recipient of the Gail Caldwell Scholarship is Elena Torna. Congratulations, Elena. In memory of Sister Helen Marie Pelliser, the Sister Helen Marie Pelliser Scholarship, established in 1969, is awarded to a junior or senior undergraduate student in dietetics. This year's Sister Helen Marie Pelliser Scholarship is awarded to Laura Chismar. Congratulations, Laura. The Ambrosinia Dietetic Internship Scholarship was established in 2005 to provide scholarship funds for students accepted into or currently in a dietetic internship program. This year's Anne Brezina Dietetic Internship Scholarship is awarded to Verena Vansel. Congratulations, Verena. One of the most prestigious scholarships awarded to students is the FAND President's Scholarship. This is awarded to a graduate student in dietetics or a registered dietitian working toward a master's or PhD to enhance his or her career in dietetics. The President's Scholarship has been awarded since 1975. This year's FAND President's Scholarship is awarded to Haley Martin. Congratulations, Haley. I'd like to take this moment to give a special thank you to Lori Johnson, Scholarship Chair, and Scholarship Committee members Christy Gardner, Holly Forbes, Brandis Thompson, and Delaney Fort for your service to FAND. If you are a student and interested in applying for a FAND scholarship, please visit the eatrightflorida.org website for more information about qualification and deadlines for application. Moving on to our special awards for members nominated by their peers for their achievements and contributions to FAND and the field of nutrition and dietetics. The Outstanding Dietitian of the Year Award recognizes a member's commitment to excellence and who has demonstrated outstanding leadership and service to our profession. Outstanding Dietitian of the Year's selectees' names will be published in a full issue of the Journal of the Academy of Nutrition and Dietetics and will receive special recognition from the Academy President. With over 15 years of experience in clinical nutrition at one of the largest healthcare facilities in Central Florida, Gail has been an advocate for her team members and for Florida dietitians. Gail has been instrumental in fighting for order writing privileges for therapeutic diets and helping to modernize our Practice Act. It is my pleasure to present this year's Outstanding Dietitian Award to Gail Brezzi Smith of the Central Florida District. Congratulations, Gail. This special award, the Emerging Dietetic Leader Award, recognizes the competence and activities of dietitians regardless of their age, who have made distinctive contributions early in their dietetics careers to the Academy of Nutrition and Dietetics. Please join me in congratulating this year's recipient of the Emerging Leader Award to Allie Peacock of the Central Florida District. Allie was nominated for her strong leadership qualities while serving as president of the Central Florida District and served on additional year without hesitation. Allie served on the District Transition Task Force. She's an outstanding asset to the Board of Directors and has developed valuable resources and guidance for region presidents. Allie also volunteers as a subject matter expert specialist for the CDR. Congratulations, Allie. The Florida Academy of Nutrition and Dietetics recognized Young Dietitian of the Year Award recognizes the competence and activities of younger dietitians in the Academy of Nutrition and Dietetics and encourages their continued participation in association affairs. These individuals will be an additional resource from which the leadership of the Academy will develop both at the district, state, and national levels. This year, we recognize 2 members for their contributions to the field of nutrition and dietetics, FAND, and have demonstrated leadership and influence early in their career. The first award is awarded to Omar Guerrero of the Central Florida District, nominated for his dedication to providing concise and consistent communication to members since day number 1. Omar frequently reaches out to FAND leadership with updates and seeks support to make better use of our communication tools. Omar and his Strategic Communications Committee developed an innovative business plan, including a tracking system to evaluate the effectiveness of the communication tools used that can be used year after year, which demonstrates how high of priority Omar places on the long-term success of FAND. Congratulations, Omar. Our second recognized Young Dietitian of the Year award is awarded to Carly Rush of the Gainesville District. Carly quickly advanced in her career as a clinical dietitian in oncology before transferring to a unique position within the UF National Sciences doctoral program. Carly practiced half the time as a clinical dietitian in the Norman Fixel Institute for Neurological Diseases, and the other half of her time designing and conducting scientific research related to Parkinson's disease. She's currently being awarded a $40,000 grant to complete her research. Carly has applied for additional funding through the Michael J. Fox Foundation to further his findings. Carly has excelled academically and often speaks publicly at support groups and clinical meetings about her research. Congratulations, Carly. We all remember our internship experiences and how the role of our preceptors shaped us into who we are and how we practice today. FAND recognizes one deserving preceptor each year who demonstrates a strong desire to teach and prepare students for their career in nutrition and dietetics. This year's Outstanding Preceptor Award is presented to Carla Savinian of Central Florida. Carla is recognized for her commitment to guiding her students through their M&T rotations with Kaiser University and challenges them to critically think in a kind but firm manner while always bringing out the best in her students. Carla also encourages her students to display empathy and be sympathetic to the patient, reminding her students that often we are clinicians and wear several hats. Carla enjoys educating students as a preceptor and hopes to one day work as an educator in academia, where she can have an even greater impact on the young minds emerging in our field. Congratulations, Carla. The FAND Collegiate Award is awarded to 2 recipients, one undergraduate and one student currently enrolled in their internship program. This award recognizes young dietetics students who have demonstrated professional or volunteer excellence rather than in the academic setting. The Collegiate Award for an undergraduate student is awarded this year to Anna Crum. Anna stepped forward during these unprecedented times to help increase engagement with social media platforms, create a variety of plans that include showcasing the value of FAND to members, and created a new platform to help track metrics and provide valuable tools to members. The Collegiate Award for a student currently enrolled in a dietetic internship program is awarded this year to Alexa Hosey of the Volusia District, who is currently enrolled in her second year MSDI at the University of Florida. Alexa volunteers with her local district, Gainesville. During this spring semester as a teacher's assistant, Alexa helped transition on-campus learning to virtual learning. She also volunteers with Putting Families First and the Florida Center for the Blind. Alexa also tutors UF athletes, all while maintaining an excellent GPA. The Public Service Award is given to an individual, company, organization, or association in the field of dietetics or an allied profession who have made an outstanding nutrition-related contribution to their community, whose support enables FAN to accomplish its mission, and whose products or services support good nutrition and nutrition messages that improve health. The UNF Center for Nutrition and Food Security is this year's recipient of the FAND Public Service Award that recognizes their all student-led programs, Food Fighters and Meals on Wing. These 2 programs transition excess prepared food from the UNF Cafe and local hospitals into nutritious meals that are then delivered to community organizations and homebound seniors throughout the Jacksonville area. The pandemic especially hit seniors hard, and the Meals on Wings program expanded to providing meals to almost 80 seniors each week, thus making improvements in nutrition status, food security level, loneliness, and overall well-being. The video clip we are about to watch highlights the hard work, dedication, and compassion that Dr. Laurie Wright and her students have for providing meal assistance to vulnerable citizens in their community.
Now to a Positively Jack story about local people helping our most vulnerable community right now, senior citizens. Meals on Wings is a program run by the Center for Nutrition and Food Security at the University of North Florida. Its focus is to fill the gap by helping to feed seniors who are on the waiting list for Meals on Wheels. And donations are low because of the coronavirus.
The food in these blue bags is a lifeline for 25 senior citizens living here in Duval County. It comes from 4 local hospitals, the food they never used. Instead of being thrown away, it's donated to the University of North Florida. It's divided up added to, and then individually packaged.
It may be rice and veggies from one hospital, protein from another, and then we bring it back and figure out how to put that into a healthful meal.
Lori Wright is a clinical nutritionist at UNF. She runs the Meals on Wings program. They were all supposed to be on spring break this week, but
We were just really worried about those seniors having the ability to access food given the short supply of food, and these are homebound seniors.
she and her coworkers did not want their clients to worry about how they'd get their next meal with the panic many are seeing at local grocery stores. So they're packaging 7 meals for each senior citizen and delivering them to their doorsteps. The reaction that they are receiving is heartwarming.
And I brought him the 7 meals, the food, and the toilet paper, and he just burst into tears. He was so grateful for that food and really didn't know where he was going to be able to get it.
Lori is talking about this man, Jack. He had a stroke recently. This is his second delivery in 2 weeks. And even though he has difficulty speaking, the smile on his face reminds us all about the importance of taking care of our neighbors.
That's 7 meals a week, by the way. Meals on Wings delivers to an assisted living facility as well, but leaves the food at the door to maintain social distancing. And for deliveries to individual homes, as you just saw, senior citizens leave a chair outside their home where the food is left. Now, the program is powered by students generally, but they're not allowed in the kitchen because of the coronavirus, so staff at UNF is trying to fill the void. Hospitals are very busy right now, as we know, so they have less food to donate to Meals on Wings. So you can help. They really need canned vegetables and canned starches. To donate, look for a link inside this story on the morning show page of news4jax.com later this morning.
As you know, each year throughout the month of March, nutrition and dietetics professionals celebrate National Nutrition Month. This year's theme was Eat Right, Bite by Bite, and districts were challenged to develop a campaign in their community to help spread the word about good nutrition. This year's runner-up for the National Nutrition Month campaign was Gainesville. Although many of the district's planned events were canceled due to the COVID-19 pandemic, the Gainesville district donated money to the nonprofit Bread of the Mighty Food Bank, which provides basic essentials to over 190 community organizations. Members of GAND were highlighted in the media at the beginning of the year, and members provided in-services to non-food service staff at their local hospital. Some of their members also volunteered at local community events in January and February that included Veg Fest and Southern Smash. Congratulations to the Gainesville district. The winner for this year's National Nutrition Month Award is presented to Volusia. Members of the Volusia District served at the 2nd annual Empty Bowls of West Volusia on March the 12th to benefit the Neighborhood Center of West Volusia. Tasha Brickhouse was a National Nutrition Month chair who coordinated this activity. The event raised over $7,000 for the Neighborhood Center, and the funds raised went towards their food service programs. VANT members helped with the setting and cleaning up and serving soup to attendees that was prepared and donated by local restaurants. Additionally, some individual VAN members hosted events and activities at their facilities prior to the quarantine. Let's enjoy this brief video clip showcasing the efforts of the Volusia District during National Nutrition Month. Congratulations to Gand and Band for promoting nutrition and healthy eating in your communities. And thank you to all of the districts for continuing to do great things throughout Florida. A big thank you goes out to Layla Silverman for her service to FAND this year as FAND Awards Committee Chair for collecting and painstakingly reviewing applications for each of these special awards. At this time, the Florida Academy of Nutrition and Dietetics would like to recognize the current Board of Directors and introduce you to the incoming Board of Directors for the 2020-2021 membership year. President, Melissa Payne, Central Florida. Incoming President, Mandy Lehman, Central Florida. President-elect, Peggy O'Neill, South Florida. Current and continuing Treasurer, Melissa Cooper, Suncoast. Current and continuing Member at Large, Bonnie Watson, Suncoast. Secretary, Jennifer Beery, Central Florida. Incoming Secretary, Jennifer Roth, First Coast. Chair of Delegates, Elizabeth Bobo, First Coast. Delegate, Jennifer Farrell, Panhandle. Incoming Delegate, Dr. Claudia Seeley-Potts, First Coast. Chair of District Presidents, Allie Peacock, Central Florida. Incoming Chair of District Presidents, Adam Lax, South Florida. Nominating Chair, Darlene Moppert, South Florida. Nominating Committee Members, Dr. Judith Rodriguez, First Coast. Holly Brennan, Central Florida. Nominating Committee Members, Rick Parks, Panhandle. Ellen Bowser, Gainesville. Thank you to all of our members of the board and committee members who served FAND for the 2019-2020 membership year, and to those who will carry the torch through 2021. Nominations are currently being accepted until October 2nd, 2020 for open board of director positions. If you or someone you know is interested in deepening their leadership skills while learning more about FAND and its service to our fellow members, please consider sending your nomination notice to fandnominations@yahoo.com. This concludes our awards and recognition portion of our program. We hope you continue to enjoy the rest of our program.
You may not know that Abbott has been around for over 125 years, and during that time we have been focused on helping people achieve their best possible health through the development of our products and technology that actually span the breadth of healthcare. Our commitment to helping people improve their lives has led to the development of advanced science-based nutrition products and solutions to support growth, health, and wellness. Today, our innovative science is behind many of the most trusted names in the nutritional marketplace. Names like Similac, Alimentum, and Isomil for infants, Pediasure and Pedialyte for children, Ensure to help people stay active, and Glucerna for people with diabetes. And we continue to innovate today by gaining insights from our customers to ensure our growing portfolio of products is meeting their everyday needs. Inspired by our patients and our consumers and you, our partners, we aspire to elevate the role of nutrition and to fulfill our responsibility to help millions of people who consume our products each day. Our commitment to you is to deliver breakthrough products with a promise of exceptional service. And our vision is to be the trusted worldwide leader in providing innovative and superior nutrition products that advance the quality of life for people of all ages. Thank you for your partnership.
Hello, everyone. My name is Claudia Rivero, and I have the honor of introducing our next speakers for our next session, which is Preventing Medical Errors in Dietetics Practice. I don't know about you, but I attend this particular seminar every single year because I love listening to Dr. Christie and Dr. Mitchell with all of the experience that they have. So without further ado, let me read you their bios. Dr. Christie is the Associate Dean at the University of North Florida's Brooks College of Health and a professor in the Department of Nutrition and Dietetics, where she has worked since 2001. She was named the university's Distinguished Professor in 2017. From 1988 to 1996, by appointment of the Governor of Florida, Dr. Christie chaired the state's Dietetics and Nutrition Practice Council of the Agency for Healthcare Administration, supervising activities of the council regarding licensure of dietitians and nutritionists. She has published dozens of research papers and book chapters on the prevention and treatment of excess weight and obesity, nutrition and chronic disease prevention, and interprofessional collaboration in education and healthcare. Dr. Christie is the editor of the Florida Academy of Nutrition and Dietetics Manual of Medical Nutrition Therapy. In her lengthy service to the Academy, Dr. Christie chaired the Member Sponsor Review Committee, Professional Development Committee, and Nominating Committee, served on the Licensure, Scope of Practice, and Competition Work Group, and Publications Committee, served several terms in the House of Delegates, chaired the Nutrition Counseling Task Force and the Ethics Committee, and is a past president of the Florida Academy of Nutrition and Dietetics. Dr. Christie received the Academy's 2010 Excellence in Practice in Dietetic Education Award and the 2007 Outstanding Dietetic Educator Award. She served as the Academy's treasurer in 2019 to 2020, and Dr. Christie is a graduate of Florida State University, where she also earned a master's degree and her doctorate. Amazing. Next, Dr. Mitchell. One of our first dietitians to jump feet first in the media world, she spent 19 years providing real-world nutrition tips during drive time on News 96.5 WDBO Orlando. From interviews with national talk radio personalities like Sean Hannity and consumer warrior Clark Howard, she is known for her straight talk about nutrition, food, and fitness. 4 years she spent at WFT-TV Channel 9 in Orlando, sharing practicalities, points, and nutrition segments honed with media skills, and ultimately that led to a career as a media dietitian, professional speaker, and author. Her media work includes 6 years as a media dietitian for Target, Super Target, and co-author of 3 books, including I'd Kill for a Cookie, with interviews on Today, CNN, Fox, and all other news shows. She learned about podcasting while doing weekly drive time radio segments at News 96.5 WDBO Orlando, and led her to a host of other things, such as podcasts of Breaking Down Nutrition for Medical Professionals and Breaking Down Nutrition and Beyond Bariatric Surgery, Everything You Need to Move On. Her years of experience in the media have sharpened her skills as a medical nutrition therapist in telehealth and provides enhancing patient engagement and success. Her speaking engagements include continuing education for medical professionals, such as the annual Florida licensure course on preventing medical errors in dietetics practice, and she has taught for over 12 years with Dr. Christie. It is my pleasure to have both of them speak once again, this time online, Dr. Mitchell and Dr. Christie. Take it away.
Good morning. I'm Susan Mitchell.
Hi, everyone. I'm Kathy Christie, and I want to welcome you to another year of medical errors. We're happy to be here, coming to you from our homes and offices, wondering what our jobs, practices, and lives will be like by this time next year. I'm sure that all of you have stories to tell about how this year has been unlike anything you've ever experienced. So the only thing for sure we know is that medical errors training is still required, and we will meet that requirement just like in every other year. So what's new and what can we do? What's new is COVID-19. Speaking of stories to tell,
wherever you are in this unprecedented time, you can probably relate to many of these things, like going to bed early and not going to a party, just like your childhood punishments have become your adult goals. I hope some of these will make you chuckle like they have us, but you can't stay home right now. You've got to sell the toilet paper. What is it about the toilet paper?
I really like this one. My face masks have finally arrived. I know some of us can relate to that, whether your wine choice is red or white. And we finally found out why the fish aren't biting. They were wearing masks too.
Well, of all of them, this is the one I know I can relate to. How about you, Kathy?
Yep, that's another one for sure. Now here we see some very enterprising folks making good out of a bad situation. They're making hand sanitizer.
Okay, John Morgan, known all over Florida for sure, but I'm laughing because the toilet paper we just talked about, have you been traumatized by it? So you just might be entitled to compensation. And remember this because we'll talk about it a little bit later.
I love this one. You practically have to put on your hat to go to the store, right?
Oh, and remember this one, the original song that was sung by Queen some time back? All together now. We will rock you. And so today we're going to help you pasta time over the next couple of hours and give you the latest and greatest updates on preventing medical errors that we hope you can use in your day-to-day practices.
So what's changed in our professional world? One of the things that's changed for me at the university is we are seeing a tremendous increase in the number of public health students that want to major in that field. And that's really interesting because there's never been a time, I think, before that public health has been so important to all of America. So now we have students who are interested in becoming public health professionals and doing what they can do to help us get through a pandemic. Hopefully we'll never have another one like this, but those students will certainly be prepared. The other thing that we're seeing is that nutrition students, the numbers of nutrition students are actually down a bit. And we think that's because this is the first year that the master's degree will be required for those students. And so it's going to take them a little longer to get to where they can take the exam and become an RD. Some programs are looking at accelerated programs where they combine that last year of the 4-year degree with master's courses. So it only takes them 5 years to get through. But we're going to have to figure out what's the best way to keep that pipeline of nutrition students coming too. Because those of you that are nutrition students with an emphasis in public health, you're going to be equally in demand. As well as the other aspects of nutrition. And think about all the clinical nutritionists that are working in the ICUs and in the hospitals taking care of COVID patients. So all of our professional areas are really making a difference right now. So thinking about what we want to try to do in this time, we're trying to make sure that what we do with COVID is consistent with the latest evidence. And the Academy had a webinar just yesterday talking about what have we learned from COVID and what do dietitians that are on the front line know about how to treat it. One of the things they talked about was that people who are malnourished or not eating as well prior to may have more severe cases of COVID. So again, nutrition plays a big role in this. And we also need to determine things like who's spreading the disease and the degree to which young people who don't have symptoms are spreading the disease. But we can also learn from past pandemics like polio. Now, a lot of you are probably not old enough to remember that, but I remember it clearly because my mother was diagnosed with polio as a little girl. And in fact, she was put in the hospital in New York City. They lived out on the island on Long Island, but she was hospitalized in New York City. And in those days, they didn't let the parents come to visit the children in the hospital. They thought it was better for them to just concentrate on what was happening there. So they couldn't come in. And so my grandfather, my mother's father, used to come and stand on the sidewalk, and she was like 9 floors up in her hospital room, and she could look down, and he would come every day and wave to her in the hospital. And she was there for several months, had many surgeries, and ended up with one leg shorter than the other and one foot smaller than the other. So one of the really interesting things about this, and this was before computers and all the connections that we have now, was there was a group, a nonprofit group that matched people who had polio and had 2 different sizes of shoes and different heel heights. And so Mom had a person in Pennsylvania who had the opposite of what she had, so that when my mother bought a pair of shoes, she had to buy 2 pairs, 2 sizes. This woman needed the other half of each pair of shoes that she couldn't wear. And so they got connected. So I remember days when a new pair of shoes would just arrive in the mail and how exciting that was. She still had to have the heels raised and lowered when she got them, but it was really kind of cool to get a new pair of shoes. And every time my mom bought a pair, her connection got a new pair of shoes sent to her in Pennsylvania. So, you know, people cope during pandemics. We figure out ways to make things work. And this is just kind of an example from my childhood about how that worked with polio.
I love that about your mom and those shoes. It's like an early subscription clothes service. Here come your latest ideas. What a fun thing that is. Well, during this time of COVID, in Florida law, we've passed that a healthcare professional, this is typically for doctors and nurses because that's where the biggest need has been. So not licensed in our state, but they can provide healthcare services here in Florida using telehealth if that said person registers with our board, or if there's not a board and whatever they're doing, they can provide within the scope of practice. So this would also apply to dietitians in other states if they wanted to come here and practice right now, but it seems to be more focused at MDs and nurses because that's where the shortage has been. So what about medical errors in COVID times? I mean, there's certainly things that we would have never thought of in the past. And I think if you look at it, testing has been a big issue. Is it actually a false negative? Maybe it's a false positive. There's always or has been a delay in getting those test results. That's picked up, but some people still have several days in between. So you have a lot of things going on. And I think people are scared. And because they're scared, they're not going into the doctor. So we may be missing other diagnoses. Maybe they've had a stroke or a mini stroke. Maybe they have cancers, but they're getting delays in treatment just because they're scared of going in and being exposed to COVID. And no doubt you've noticed on the radio, if you're in your car, on television, that all types of unproven medications, supplements, and treatments are being promoted highly right now. And I don't think that's anything different from what we have always seen in our field. There have been bogus products out there forever, but right now you're seeing those bogus products being aimed at COVID. So here's some more medical errors that have been COVID related that have been reported to the Institute for Safe Medical Practices. The one I want to focus on is number 3, because I think that's the one that hits home to most of us in doing what we do. And particularly if you are doing telehealth right now. I've been doing telehealth for the last, almost 2 years now, I guess. And what I see is this number 3, the inability to weigh patients is an issue. Why is it an issue? Is because if you're doing telehealth, you can't weigh, and you're asking them, okay, what is the current weight? And then they're giving you a reported weight, which sometimes is the weight they want you to hear. Now, I don't think weight for many of us is a focus like it was years ago anyway, so it's not as big of a deal. Where it becomes a big a deal is when the weight is really important to assure the correct dosage of some weight-based drugs. So if you're getting a reported weight that's not accurate, you can see that then they could receive an incorrect dosage of the drug that they need to have. So again, I think that we think about weight today in a very different way when we're counseling on lifestyle. Where it's important is when it's going to be tied to a weight-based drug.
So this is a really recent study just published this year that looked at medical errors during surgery. And we're not doing surgery, but it's interesting what we can learn from what the surgeons are doing and what they're trying to cope with. So we see elective surgeries being canceled. So that means that they're doing more emergency surgeries. They don't know what's coming in when, and so they have less time to prepare or think about it. They have to support COVID patients in ways that they may not have done before, and they may be doing surgery in emergency departments and, of course, in intensive care. The other thing is that patients wait, as Susan said. They're afraid to come in because they don't know what they might catch at the hospital. They're worried about COVID. And so whatever the reason for the surgery is tends to be more advanced and worse by the time they actually get there. And they're operating in different places, so it's not familiar. And the other thing is, of course, is they need PPE. So the other thing that can help this is using simulation, and we're seeing the need for simulation centers more than we ever have before. And that's where we can practice in different settings. Dietitians and all medical professionals need that kind of safe environment where they can practice and make those mistakes before they're actually out in the real world. We can share resources and try to stay up on the latest things. But I think some of the things that are most important are helping the team perform at its highest level. And I'm sure you see this if you work in the hospital with groups of people and groups of different professionals. Helping others, looking out for ways to help them if they're tired or they need a break or they need something to eat. And stopping whatever they're doing if it doesn't feel right, if something's not going well. And then the last one is something I thought was really interesting, and I'd never heard this term before. It's called assertive followership. And followership is checking in order to ensure that somebody's okay. And I just think that's a very cool thing to do. And maybe that'll be something that'll last post-COVID, that we do more checking in with people just to see what's going on with them, to make sure that they can operate at their absolute highest level.
And going back to that toilet paper, where is the toilet paper? I do think that one thing that has come out of this, and not necessarily for the better, is that you're going to see a lot more attorney solicitation for COVID cases, for these things that we're talking about, delay in treatment, medication error, is there a liability somewhere? So even though we're into something that we've never dealt with before, I've already started to see this in my area, and you might have been as well. So what are we learning so far, and what are we learning? I think there's going to be a lot more to come out of this as we look back. They always say, hindsight is 20/20. But I can tell you that if you look down, virtual care number 3, that's where I want to go for just a second and focus on this. I think it's here to stay. Yesterday, I sat in on a webinar out of the University of Chicago on global telehealth, and where this was going to go from this pandemic, since it's not just affecting the United States, but so many other countries. And it's interesting because telehealth is here to stay, especially one of the biggies was if the pay continues to have parity with what an in-person fee is, then you're going to see telehealth continue on and be a benefit in many, not just MD consults, but those of us that do nutrition and PT, OT. It was interesting, the different groups that are also doing this. But I've noticed is number 4, where mental health must be a priority. I don't know about you and your work, but I've seen the telehealth consults for nutrition be slower right now, and the mental health consults are way up. And actually, every time I start with a new client in the last 4 or 5 months, it's interesting because I've had several say to me, you know what? I just can't do this right now. I'm mentally not in the right place. I can't focus on my health or my nutrition because I really am so stressed about COVID. I need to focus on my mental health. So I really believe that mental health has to be right now a huge priority, and that our role will come back up and continue to be very important.
So what about RDNs? I know that those working in critical care and in hospitals are under additional stress, of course, with the COVID patients coming in and trying to figure out what is the best nutritional support and treatment for those patients. But the good thing is we've been able to maintain the high standards that we have in our accredited programs, even though the students may not be getting the exact same preparation that they had before. Those standards are being maintained, and the program directors are doing an amazing job finding placements for students in these times. The competencies were recently updated, and we've already talked about the master's degree being required for new graduates in 2024. We also have licensure exams that'll help maintain the standards, and of course, malpractice insurance. But clinical skills are one of the hardest things to train, and that is going to be an issue for programs for a while because we can't get into the hospitals at the same rate as we used to. So program directors will be working to make that up, to make sure that the new graduates will have exactly the same standard of care and level of practice that we need and have seen in the past. We also still have the ethics requirement that's required every licensure cycle and medical errors, as you know, since you're here. But I wanted to talk about an email that was sent to all members of the Academy on September 1st. And that email talked about the incident reporting tool. And if we were in a room with all of you, I'd ask you to raise your hands if you'd heard of the incident reporting tool, but we can't do that. But this tool is from the Academy to help protect the public and enhance the quality of nutrition care, and also promote self-regulation. What you can get from the incident reporting tool is anything that didn't go well, or anything that's below the standard of care. And that includes others that are doing things in nutrition that they really shouldn't be doing or haven't been trained to do. So think about how wonderful that would have been in our licensure fight this last year if we had had a list, an extensive list of things in Florida that others were doing that maybe weren't RDs in the nutrition realm, and they caused an incident. So this tool is really something I think very important for the Academy and for our profession, because we're going to be able to have documentation ready when the legislators say to us, why do dietitians need to have all of this training? Why do we need licensure? Here and in other states, we'll have data from this incident reporting tool as to the why. We certainly have had isolated incidents that we knew about, but now we're hoping to have a lot more of that, so that not that we want bad things to happen, but we want to record when they happen so that we'll be able to use that to justify licensure in the way that we've been able to over the last 20 years in Florida.
If I can jump in just for a second, I'll say that if you go back and look at that email that came on September 1st and read it, it actually shows you right there how to click and go right into documenting information. So it's not something you just have to read and learn. It will take you right to it and start you right into reporting something. So it was meant to also not just be informative, but to use it right away. It's pretty easy. So go back if you didn't see it and check your email around September 1st.
We're going to show you how you can get to it. There's the link. The Consumer Protection and Licensure Committee of the Academy has been working on this for a long time. And anyone can enter incidents. It doesn't have to be a dietitian. So if you have patients that have something that they could document that happened to them, they can go in and enter it into this tool as well. Even if it didn't cause an injury, even if there wasn't a negative outcome, you know, we have things called near misses, and those are things that could have caused a problem, but for some reason didn't. Those can be added as well, because what that does is let people see what is the risk of not having a credentialed person, or you know, having someone who isn't a trained dietitian providing advice or whatever the issue is. Most of this is probably going to be in the community setting, because obviously hospitals and medical centers are not going to hire people that are not qualified. But out in the community, we do see sometimes people that are not dietitians hired to do nutrition work. And so that's something that licensure should take care of. But now we have the requirement that it covers MNT only. Now, think back of all the patients that you've seen during your career. How many of them have obesity alone and no medical condition? I would suspect that most of them have some kind of medical condition which would require a dietitian, but that's the sort of gray area that we're in now because of the changes in our licensure law this last legislative session, and we're going to have to work through that. But the incident reporting tool is a great way to document when somebody recommends something that really may not be appropriate. Patient can go right in and put that in, or you can go right in if the patient comes to you afterwards and asks for your advice.
So one of the questions we get asked about is, well, what about nursing? They seem to have these compacts. Can't we have something like that? And nursing, yes, does have a licensure compact right now. That is an agreement between states that allows nurses to have a license in one state with the ability to practice in a lot of other states. It was developed for them back in 2000, so it's been in place quite a while now. And it includes, 25 states at the time, and that number is increasing. And you can get a feel here for just exactly what is happening with that. If you look at the nursing compact in the navy blue color, you'll see that this was in 19 and they've since added a few more, that this nursing compact is spread pretty well throughout the US for them. One of the things that they do that's really important is that in this enhanced license that they have, and that this part that was implemented in 2018, it does include national standards for licensures. And for part of that licensure requires a state and federal based criminal background check. So I think for them, if you've gone through this in one state, then you know you're cleared to work in the others. It's been a very beneficial thing. So how does this affect you and your practice? Well, currently we don't have a compact. So what does that mean to us? If you want to practice in multiple states, like you live here in Florida, but you think, okay, I might like to practice in Georgia or South Carolina, you then have to become licensed in each state where licensure is required. So if Georgia has licensure, you have to become licensed there as well. If South Carolina does, you have to become licensed as well. The Academy is working to establish a system right now where there's kind of like reciprocity, but it's very, very expensive, costing hundreds of thousands of dollars. That's one reason for us it's so critical that we be Academy members, because remember that a lot of that money goes into these type of compacts that the Academy is working on our behalf. Oh, and another thing that's interesting is that, sure.
Yeah, I just wanted to say that the Academy is trying to figure out, is a compact the best thing for us, or is some other arrangement? And there are lots of creative things we could do to try to get reciprocity among the states. So going through each state legislature, as you know, we did last year when our licensure law was under threat, is really labor intensive, and you'd have to have lobbyists and people in every state trying to do this to get a compact. So we don't know exactly what's going to come out of this, but this is one of the priorities of the Academy right now, is to try to figure out ways to make it easier to practice across state lines once you meet the licensure requirements.
And one thing, to bring this back home to real world practice, it's our responsibility then to know, not just to become licensed in the state. So if you're going to practice in Florida or you're going to do telehealth, to become licensed, but you have to know that license and what it entails. So for example, I met a new RD that moved from another state into Florida. She was asking me some questions about telehealth, and I asked her if she had become licensed. She said yes. And I said, great. What EMR system, like electronic health record system, are you going to work with? And we were talking back and forth. And she did not realize that our licensure law requires your first visit to be face-to-face, in person or on video. And so she was doing telehealth by telephone only. And I said, you know what, you might want to just go back and take a look at our licensure law closely, because you'll find out that in order to practice under the license, you have to see people face-to-face on the first visit, either face-to-face or via video face-to-face. So it's really important to remember that that's up to us to find out, what does the license in the current state mean in terms of how you practice day to day.
So here's the latest map, and we've made a lot of progress in the last few years in terms of trying to get licensure in every state. We're not there yet, but you can see there are a lot more red states than there used to be. Green states are where it's a Title Act only, so you can do what you want as long as you don't call yourself a dietitian or nutritionist. And then the gold states, there's title protection without formal state regulation, and that's just the 3 states that you see there. So there are lots of different schemes, and that's why it's confusing, and that's why when people move from state to state, they need to be really careful, as Susan mentioned, about looking at that state's licensure law and seeing what it particularly pertains to. So here's how to do that. These are some of the links that will help you figure out licensure by state. Some of these were put up by the Academy's Consumer Protection and Licensure Committee. Others you see Eat Right Florida, so you can look at that. And you also have the link to the telehealth and reimbursement policies. So those should help as well. But the biggest news, and this is just so exciting, there's a new Medical Nutrition Therapy Act that was just introduced in the House of Representatives, and it would expand what we do to beyond diabetes, renal disease, to include all the other conditions that you see here. And that would make a huge difference in the reimbursement rates for dietitians and for our profession. So this was introduced in the Senate as well by Susan Collins. She's the sponsor, and it has wide bipartisan support. This is something the Academy's been working on for years, and it's going to add lots of options in terms of what we can be reimbursed for. So we need to be out there talking to our legislators, both in the House of Representatives and in the Senate. It's moving through kind of slowly right now because everyone is so COVID focused. And I hope COVID gets added to the list of things, because it certainly should. But this is going to be huge for us. And so I wanted all of you to be aware of it and be able to do whatever you can to work with your House of Representatives and our state senators to make sure that they are supportive of this. The other really cool thing about this bill is that it isn't just limited to what it starts with. The U.S. Secretary of Health and Human Services could add to this list, further expand access to MNT without additional legislation from Congress. And that would allow all of the extenders, the physician assistants, the nurse practitioners, clinical nurse specialists, even psychologists, to refer their patients to RDNs for MNT. That would be huge, because then we have a whole nother group of professionals that realize the importance of what we do, and people would get referrals from them. And so this is the companion bill. You can see it in the House, and this is, if we can get this passed, it's going to be absolutely what we've been needing all these years in terms of the recognition of how important RD services are and when they're needed.
And just one more reason, really, Kathy, for why all of these other professionals should refer to us, because there are so many things that set us apart as professionals. And one of them are just the resources that we have access to. And I know we bring this up every year, but I think it's a hidden gem that so many of us don't utilize enough. And it's the EAL, or the Evidence Analysis Library. It's another tool in your toolbox, and it's free. If you're an Academy member, your dues pay for this. And if you're not and you want to join just the EAL, it's $250 a year to use the library. So you can see the benefit. Part of our dues go into that, along with the journal and the smart brief that we get, and the Food Nutrition Now. It's a digital magazine. You've probably noticed it's gone from print to digital, but we have all of these resources providing us with evidence-based data right at our fingertips that comes from being a member. And that's another reason, just a huge reason, for these other professionals to say, you know, see a dietitian. They're the ones with the expertise. Next slide.
Susan, I just wanted to say one other thing. Yesterday, I was on a webinar from the Academy, and they now have a coronavirus resource on the eatrightpro.org website. It's called COVID-19 Step Up and Shine a Light. And it's a professional resource hub that has all kinds of data about COVID-19 practice tips, what you can do, and you know, how you can be effective during this time. So check out the professional resource hub on the Academy website.
You know, that's good to know, because the EAL does have COVID data, and you can find quite a bit of information there. So between the two places, so I don't know if they've mirrored the information onto both places or not with what they've put up on the site, Kathy, you might know, but this is a great place, the site and the EAL, to find data if you're needing information right now about COVID as well. But the scientific content, and people have done the studies, done the work, and if you're talking on a certain topic, this is a great place to go and see, okay, what has someone already done here? Are there position papers in here? What does the research say? And it's right there at your fingertips without you having to reinvent the wheel. So why evidence-based? Well, we know it improves the quality of healthcare, and there's so many wide variations in practice that when you get on a focus on providing quality evidence-based care, it's going to improve that quality all the way across. It just reduces the gap between what is known and what's happening in real life. It lets us take into account and take advantage of so much biomedical knowledge that's coming out. And we're just seeing all kinds of studies come out right now. And I'm sure they'll be put into the EAL, by the way, as we go along. Well, we know we always have to take a closer look at medical errors here and what we do. So remember, our goal here is to stay down here at the base, right? We want to be where the error is caught and it's a near miss and it never does get to the patient, right? Or if so, it's just in the middle there. It reaches the patient, but the harm is so minimal that it's basically not detectable. What we don't want to happen is to have the medical error result up there at the top of this very serious, some type of serious event that does result in some type of harm. So we want to stay at the base. We don't want errors at all, of course, but we certainly want them to be caught before they happen or before they affect the patient if possible. So no doubt, I bet, boy, I could just say what's going on with you that you've seen in COVID, you've seen in medical errors. So normally, you know, we get to chat back and forth as we're going, but we're saving some time at the end for a few minutes of Q&A. So if you have a story to share, that's going to be a great time for you to tell us.
So here's some of the statistics. We're 400,000 deaths a year from medical errors, and it costs the nation's $1 trillion per year. And one of the things that they're talking about is that if we can have some algorithms that predict what might be missed or delayed, that would help. And that's something that we're working on. But the data says there are 10,000 serious complications resulting from medical errors occurring each day in our country. So that's why medical errors training is required, because we have to get a handle on this and we've got to figure out how to prevent these. The EMR is one of the ways that we think we can document what happened and then know how to fix it. And we'll talk about some other situations where that can be used. But all of the healthcare systems are working to minimize medical errors because we know we have to do it. And cognitive errors might be helped by some kind of computerized algorithm that tells you the next step, so you don't have to have it all memorized in your brain. And that may really make a difference. In ambulatory care, it tends to be missed or delayed diagnoses that is the most common, and failing to order appropriate tests or initiate follow-up when a patient comes in. So it's not just in critical care, it's also in ambulatory care where we're seeing this happen. So I think we've talked about the IPASS initiative in the past, but this is gaining more traction because they're gathering more and more data over time. So you can see that if you can standardize how the patient is handed off in the hospital from one person to the next, when the next nurse or the next physician comes in to take care of the patient, how do they bring the other person up to speed in terms of what's going on and what's needed? So 70%, remember sentinel events, those are those terrible events that happen that cause severe injury or death. 70% of those stem from miscommunication, including during patient handoffs. The handoff program is the IPASS initiative. And you can see what that stands for here. So these are the things that need to be communicated to the next person who's taking care of the patient. What's the severity? What's changed? What's happening with the patient? What needs to happen on the next shift for that team? Situation awareness, and what if this happens? What if that happens? Here's what we'd recommend, because we've been working with the patient for the last 8 or 10 hours. And then you ask the incoming team to synthesize what did you hear, what's the most important, and then read it back or tell it back so they know that you've got it right. And they're trying to work on a handoff documentation so that it's integrated into the EMR. So the team that's previously been there puts all of this information in the EMR and they tell it to the person so they hear it, but then it's also documented so they can see it. So where do most of these changes of shifts occur? Typically at the nurse's station. And as of you that work in clinical settings know how easy that can be at the nurse's station during times of shift. So we're trying to figure out ways to make it take less time, increase the communication, even include the family members if they're there so they can talk about what they've seen with the patient so that the new people coming on can know. And what they found is if you do that at the bedside, instead of at the nurse's station, it's more private, it's more focused on that one particular patient rather than the whole group that's being seen. And they found that it's resulted in improved patient safety. So if you have a loved one that's in the hospital and you happen to be there at change of shift, watch how they do it. And you might want to recommend that you talk to the next person alone with them in the patient's room next to the bedside so that everybody knows what's going on. So, and again, these are the things that need to be communicated at that time. And you can see at the very end, you ask, what did you hear? And state what are the key actions that need to happen during that shift change. Next slide.
I think that last part is so important, Kathy, when you have to mirror back and say, I think what I heard you say is, because sometimes when you go back and say that, it's not correct, that they didn't hear it correctly. Anyway, one slide previous. Let's look at what is improved. You know, when we first started talking about IPASS now, probably 2, 3, 4 years ago. We didn't really have data because data yet to say, did it work, did it not work? It was a study going on, several hospitals around the country. But what we know now that has come out fairly recently is that, yes, with IPASS, we did see in pediatric patients, by changing and doing these rounds at bedside, a 38% reduction in harmful medical errors. So you want to hope that's going to extrapolate across to all types of patients besides peds, but certainly that's the direction we want to go, and you can see that there's going to be a benefit by doing this at the bedside. And certainly while these kinds of studies are going on, patients, family members, parents, siblings have become very involved in these patient safety action networks. And you can see the website here, patientsafetyaction.org. This is a consumer-based network. You know, millions of people, unfortunately, do get injured in some type of medical error, and they do survive. And what's happening is that they're becoming safety activists who want to share their information and then have strategies to say, how do we prevent this from happening again to other people? So this is where, if something's happened in your family, something that you know needs to be reported and talked about so it doesn't happen again, this is a good place to go and look. So what are some of the things that come out of all this for strategies? Certainly the need for medical coding for errors. This has never been. It's been talked about a while too, saying, you know, these errors need to be made more visible. They need to be discussed at conferences. And then this recommendation to change the death certificate's been out there a couple of years. Hasn't happened yet. So there's not as much mentioned on medical errors through the coding as we would like to see, but we keep hoping that that's going to change.
And then the next question is, what do you do when an error happens? And so what's important is that if there's a negative outcome, it gets documented. And then you try to figure out what are the precipitating factors that led to this error. Was it a technical error? Was it a lack of training? A new person? Was it a normative error? And normative errors are those that, if repeated often enough, become standard practice. So it's really important if somebody knows that they did something wrong, that they call it out and they talk about it with someone so it doesn't become just the normative error. Even if it doesn't have a negative consequence, you want to practice that idea of identifying things that don't work and aren't best practice, and then moving to something that is best practice. And you can look at the professional standards, you can see where the holes might be and what they know, but all of that is to prevent having this become a serious medical error. So these are some of the things that you can do to teach when an error happens. Obviously, a lot of people realize that they've made a mistake, hopefully before there's any harm associated with it, and that's called self-correction. So they're able to stop whatever it is. And we're going to see some examples of that a little later. Damage control is, oh my gosh, it happened. Now, how do I fix it quickly and prevent any damage from occurring? Disclose and counsel. Talk to somebody you trust about what you did. And certainly your supervisor needs to know that an error happened or was about to happen. Practice apologizing, because at some point in the career, you'll probably have to do that. I'm sorry this happened. Here's why. We're doing everything we can to fix it, and we're going to make sure it doesn't happen again. And then you change what you individually do and share those changes with the people you work with so they can benefit from your experience as well. And then there have to be system changes. You know, how do we think about errors that happened? Are we really punitive in these settings? Do we fire people? Do we get rid of them? In some cases, if it's a really egregious error or caused a patient death, that probably will happen. But hopefully with the smaller errors, and all of us make them, we can learn from those errors and prevent the bigger errors from happening in the past. But that's going to require a system change and a change that focuses on helping people figure out what went wrong and not blaming them for those small errors so that we can prevent those bigger errors from occurring. So this was a really recent article that was just published in the Heart Association's journal Circulation. And I thought it was interesting because they focus specifically on diet quality and the importance of having diet quality assessed and discussed at the point of care with all the members of the healthcare team. And the idea of that was to reduce the incidence and improve the management of diet-related chronic disease, especially cardiovascular disease. Of course, this is the Heart Association, so that's what they're interested in. And so that what they're recommending is that there be what's called an automatic diet screener as part of the intake of every patient, and it would be entered into the electronic health record. And the other thing that came out of this article that was really interesting is they admitted in the article that physicians and other clinicians are willing to talk to patients about their diet, but they don't really know how to do it. They're not trained to do it. They don't really know what the recommended, they know generally what the recommended dietary recommendations might be for a patient, especially if they've taken care of a lot of patients. But there's a barrier that they don't really have a lot of time in their curriculum to train them up how to do nutrition. Of course, dietitians have a lot of time in their curriculum and they know what to do. So they're the go-to people that can help fill this gap that's been identified in medical nutrition education and also in hospitals and clinics when people are out there working. And basically what this does is just reinforce the skills and knowledge that we have that will fill this gap that's been identified in this brand new article in Circulation.
And really, you know, it's one more reason that that bill that's up right now to be voted on that would just enhance the fact that dietitians could then be referred to by all medical professionals for so many things beyond renal disease and diabetes. I think right there it just shows we have the skills. Let's just pass the bill, make it easy, and utilize, and don't expect MDs to try to do nutrition counseling. They don't have the time, and that's our expertise. Anyway, going on, have you met Andy? If not, we all know that technology and health informatics is really the future, and Andy is part of the Academy's health informatics infrastructure. And it's a great place where a lot of data is going to be collected for outcomes and for what the future is. So data like this, for example, in the bill that we're talking about, it's going to enable us using Andy and using informatics to track nutrition care outcomes. And why do we want to do that? Anytime we want to advance RDs and our practice, and while evidence-based nutrition is so important against nutrition that's less evidence-based, is that we have data, and collecting it through Andy and being able to show that this can make a difference in malnutrition, falls, pressure ulcers, all these kinds of things, and save money. If we can go back to Andy, pull that data, be used to show and prove the benefits of nutrition care, then it pushes dietitians to the forefront and increases our salary, increases the number of hires. It's beneficial all the way around. So we know already that at least a third of the hospitalized patients are being admitted are malnourished, and we see malnutrition. But so often it just goes unrecognized. And that's why one of the reasons for these screening tools that we've been hearing about, that Kathy was mentioning from Circulation. And often the nutrition care gets delayed just because of a patient's medical status, or maybe a lack of diet order, or the time needed for a consult. And then you may have the risk of ulcers not even being assessed. So we know that these things have been problems in the past, and certainly a place for dietitians to be right now. So what becomes more and more important than ever is this early identification, assessment, and intervention of malnourished patients, which is some of our focus today. We know so many individuals are at risk, And we know that improving the nutrition is going to improve their outcomes. But it really varies. You have to look at the patient and client population and the disease severity. Also, their access to nutritious food, where you're looking at food deserts and how that affects people's health, and how malnutrition is being defined in practice settings. You see a lot more of it. I don't see as much in telehealth. I tend to see the overweight, malnourished versus the malnourished in terms of very, very thin. And screens. Okay, remember, right here we're talking about screening, not the actual full assessment. So if we're looking for just basic screens, what we tend to look at quickly is, has there been an involuntary weight loss over the last 6 months? What is the BMI? How low is it? Is there a decreased appetite or reduced food intake? Those are just little triggers that make you say, you know what? I need to now go to the next level here and do a lot more looking and do a full assessment. Slide.
So this is a study that was published just recently and looked at malnutrition prevalence and the effects in Spain. And what they found was the elderly population, 66 to 98 years of age, was at risk for malnutrition. 15% were at risk, and 12.6% were malnourished. The malnourished patients were older, they had lower functional status and more comorbidities than those that were not malnourished. So you can also see that the malnourished patients had more medication use, higher hospital admissions, longer lengths of stay, higher cost, and they were on multiple medications. So it just gives you a sense of what to look for when you're seeing a patient. If you see some of these things, multiple admissions, longer lengths of stay, and they're on a lot of medications, it makes sense, especially if you've got some weight loss, to do a full assessment. And the nutrition-focused physical exam is really important in that. Malnutrition risk screening for older adults and nutrition counseling has the potential to prevent some of this developing into malnutrition and also reduce cost of care. So the nutrition-focused physical exam is really, really important. We're training all of our students in that now, and so they will have those skills when they graduate. And we also need to think about policy and procedure training for outpatient dietitians so that they have a way of screening and also getting those patients in to be treated if they have it. You can do presentations to primary care providers that are working in the community to try to help them know when to refer to dietitians. And of course, ongoing malnutrition training about the numbers and the risks and the types of things to look for so that when they see those patients, they will evaluate and refer to a dietitian. These are some of the outcomes. One of our students at UNF did her master's thesis on this, and you can see looking at the identification of malnutrition. And what they found, this was in an outpatient setting, that after going through the nutrition-focused physical exam training, they saw an increase in the number of malnutrition patients that were identified. So that's really important. Training helps. It makes you aware. It makes you start to think about what you're looking for. And if they hadn't had the training, they missed cases, and then with the training that it improved. Yep. This looks at the codes that were entered, and so you can see from 16 to 17, the number of malnutrition codes increased dramatically. And again, that was following the training of related to malnutrition and how to identify it. So lots more cases identified after people knew exactly what they were looking for.
All right, raise your hand If you have gone through the nutrition focused physical exam technique or training, okay, I know I can't see you, but I want you to think to yourself, I raise my hand, because less than half of RDNs right now are routinely using the nutrition focused physical exam, which is the most current way of practice. So if you haven't learned it, you really want to think about doing it, because what it does is puts us actually hands-on in treatment with the patient, because you are assessing muscle mass, subcutaneous fat mass, fluid accumulation, and functional status. That means hands-on physical exam by the RDN, something we've never done in the past. There are really good articles in Jan and Aspen that you might want to look at, especially if you're in a private practice, into doing this. So why is it so important? It heightens our level of practice. It makes others realize how important it is to have an RDN on the team who knows how to do a full assessment that does require hands-on with the patient, looking at fat mass, looking at fluid. And it's so important that Ascend has now put it, the nutrition-focused physical exam training, as a part of the competency for all dietetics programs. So I think that says, this is the way of practice now. And if you're mentoring or you're training dietitians and don't know this, you're going to want to find a way to learn it, because they're going to learn it and come out practicing in it. And everyone's going to need to know how to do that. Well, and feeding programs, we've been talking about nutrition and malnutrition this whole way, and we know that feeding programs make a big difference. I'm really fortunate to serve on the advisory board at the University of North Florida, and boy, the program for dietetics does so many creative things. And I want Kathy to share a little bit more about one of the programs going on right now, feeding the elderly, and feeding programs that can make a huge difference just in contact, but also in this malnutrition risk.
So at UNF, we have a Center for Nutrition and Food Security, and basically the center started and had a project to find people who are on the waiting list for Meals on Wheels who were not getting served. And there are lots of thousands of people in Duval County that are on the waiting list that haven't been served. And so what they looked at was, could we repackage food that comes from the hospitals that they're not using, and repackage it into meals, and then deliver it to some of those people that are on the waiting list for Meals on Wheels. And Dr. Lori Wright is in charge of this program, and it's been so wonderful to see the effects of this, because for some of those older people, that's the only visitor they see. And some of them are standing outside waiting when the students arrive to deliver their meals. And the students repackage them and deliver them, and they have food to last them until the next delivery. So it's really, I guess, heartwarming to see the effect that this program has had on the recipients, but also the students, because they feel like they're really making a contribution and helping individuals, and they develop relationships with them over time. So it's a win-win all the way around.
And I love the fact that the intergenerations together working, these young students, seeing the elderly folks, having these conversations and building bonds. So we know how food builds bonds anyway, but serving that food and getting to know the people, it's really a great thing. And what happens is that malnutrition risk goes way down. Well, interestingly enough, though, about malnutrition, you got to look at the business side of things. And a recent audit, and this was in 2020, this year, found that hospitals overbilled Medicare by $1 billion by incorrectly assigning severe malnutrition diagnosis codes to hospital claims. And this is for the years 2016 and 2017. So very interesting. Kathy and I were talking about this when we saw it, and she has a little story that's real world that's come out of this.
So just a few weeks ago, I was contacted by a dietitian who said that in her setting, they were encouraged to code malnutrition as severe versus moderate because the reimbursement rate for severe was higher. That's really scary. This is an example from that audit that looked at coding and said that it was being overbilled. So a patient had moderate muscle wasting and edema, was coded with secondary severe protein malnutrition. But the dietitian nutritionist noted malnutrition secondary to obesity. The physician documented non-severe protein calorie malnutrition. They put the patient on a heart healthy diet, gave them a supplement, and the patient's diagnosis did not affect patient care. So the medical record really didn't support that secondary diagnosis of severe protein malnutrition, but they billed Medicare as if it was severe protein calorie malnutrition. So that was one of the examples, and you can see the overpayment was over $10,000.
And you know, Kathy, one of the problems there that we've talked about before is that the coders also, they're not trained in our fields or the physician fields. And so they're coding, if someone is marking it or they're being told to code everything as severe, but yet the chart isn't matching that, you can see very clearly where this is going to bring a case up of, hey, the medical chart's saying one thing, you're coding as another, and without that experience in coding. So where's the problem? Is it the coder not having the training? Is it somebody being pushed to put a code that's really not correct to what the assessment shows? There are a lot of different factors here at play.
And you can be sure the hospitals are looking at this because they don't want to have to pay back those overbills. So they're going to be looking very critically at their systems in terms of how these diagnoses are made and whether they're accurate.
So talk about the next slide, Kathy, on this GLIM program that we've talked about. This leadership program.
This is a global initiative that's looking at malnutrition and trying to come up with consensus criteria so that everybody everywhere is diagnosing malnutrition in exactly the same way. And so it's in addition to the fact that we have people who are trained in nutrition, dietitians, conducting comprehensive nutrition assessments. And that really is the key because we're the ones that know and we're the ones that should be making those diagnoses in order for it to be coded correctly. So the proposed international criteria is that there are phenotypic criteria, so weight loss, non-intended, low body mass index, reduced muscle mass, and then they have etiologic criteria as well: reduced food intake or assimilation, inflammation, or disease burden. And basically what they're saying is in order for it to be a diagnosis of malnutrition, you have to have one in that first category, the phenotypic, and one in the etiologic must be present for any diagnosis of malnutrition. And then the phenotypic metrics are in different stages, moderate or severe. So remember, the phenotypic is non-volitional weight loss, low body mass index, reduced muscle mass, and the reduced muscle mass is going to be caught in the physical exam. So all of this still requires the nutrition-focused physical exam for diagnosis of malnutrition, and it's that reduced muscle mass, levels of muscle mass, and the things found in that exam that determine whether it's moderate or severe. So hopefully this is really going to help us as we go forward in diagnosing more malnutrition where it exists and diagnosing it more accurately so that the coding and billing can get done appropriately.
And I think we need and you know, Kathy, what you were saying about these new things from GLIM are not in place yet. So they're being proposed. So I think what we need to remember in hands-on practice right now is that the nutrition-focused physical exam is our go-to. And the measurement of, looking at body fat, looking at fluid retention, the hands-on assessment of that person for us right now is the way to go. And so, the common theme across all of this is the lack of a correct diagnosis for malnutrition, thus the lack of treatment. That is why it's so important that we as dietitians all move forward into being able to do these assessments, do the hands-on part, code correctly, know what's going on. So we should be the ones leading the way and saying, this is the correct way to look for malnutrition. This is what they have, what they don't have. So it puts having this physical exam for us to be able to do really puts us more in the lead. So if you're thinking, okay, where can I learn more? This is a great little pocket guide. I know for sure it's on the Academy website because I remember the bookstore. That's where I got mine. It may be on other easy to obtain as well, but it's very handy, a small guide that will teach you a lot. It's still great to get into some type of training, but this is a really good guide to go with that.
So there's some other potential medical errors that are nutrition related, and there was a study that looked at how often are dietitian recommendations implemented. And this study, it's a little bit old now, but it found that they were only implemented in 42% of cases. So if we're the experts and we're making recommendations and they're only implemented less than half the time, no wonder we're having issues with some of these things occurring. There's also the advice from non-dietitians, everybody telling people what they think they know about nutrition, and that's a recurring theme we always talk about. There's misinformation online, so people do their own searches and then decide what they should do. Many people have trouble eating meals without assistance, and especially the elderly or handicapped population is where we see that. And then we're not addressing food insecurity. And I think COVID has really shined a light on how much food insecurity there is. We've seen food banks and others really step up during this time to provide food for people that need it. But food insecurity is the root of malnutrition, and so we need to be sure that we address that as well as we can.
So Kathy, and your all's program, I'm just thinking about this. We know right now during COVID that food insecurity has really shot up. Are you seeing a lot of increase in people asking to be a part of the program that you all have right now? And I know that you can only serve so many people. How do you handle that? Do you have other resources where you guys all work together?
Well, the food banks are doing a great job too, and they're handing out bags and boxes of food to people. But, our capacity is limited by the number of students that we have and also by the amount of food that we get. But we have doubled our capacity, which is really exciting. So we are meeting the need as best we can. But more food, more students, more volunteers, the program can only grow, and it's being done in other places in the country. So we're starting to see others sort of model after this program because it works well. But we can't do it alone. There's no way that we have enough resources to do it. The food banks and others are stepping up to try to meet the need as well.
So admissions and readmissions, I know that you saw the slide just a second ago for all the admissions. And one of the things I just want to notice is that mood disorders and alcohol-related disorders and schizophrenia, the mental health issues that we mentioned in the beginning, we're seeing that in admissions to the hospitals and readmissions as well. So COVID certainly, and not just in the deaths and the sickness, but has had an effect on mental health for so many people with depression, anxiety. So it's things for us as dietitians to be aware of. I've seen it in my practice numerous times in the last 6 months where patients have said to me, you know what, I just don't have the energy right now, the mental energy to work on changing my health for my diabetes or whatever it happens to be at the time. I'm just so scared. I'm so nervous about what's happening. I really just need to focus on my mental health and then I'll come back. And so I've actually seen that. I had a call from a client yesterday that said, I'm ready to go now. I've been working on things that have been going on in my life. And they're better. Now I want to work on my diet. So I do think that there's that interest and that dietitians are there, but the mental health right now, the anxiety that's going along is so important to take a look at. Since 1980, look at the contributing role of diabetes. So many cases are preventable, and the cost unbelievable that adds to our healthcare system. So I think this is really a place when people say to me, you know, where's the role for me in the future? Where do you think RDNs are going? And I'll say, if you have an interest in medical nutrition therapy, if you have an interest in diabetes, you can't go wrong here, because we see that and we know for sure that RDNs can make a big difference in reducing those hospital admissions and the costs. And when everything is coming down to money right now, to being able to show our value in that is so important. So the big opportunity for us.
So here we see the top 10 medical errors associated with hospitalization. Number one is misdiagnosis. So it's really important for all medical professionals that are screening to get that right. You can see treatments that are unnecessary, tests that are unnecessary. Those cost money, but may not necessarily negatively impact the patient. Medication mistakes is a big one. And then never events. Never events are things that, if they happen, definitely cause a medical error and can be life-threatening. So when you look at all of these things, we want to focus on getting the diagnosis right, and we want to focus on preventing those never events. And a little bit later on, we're going to talk about one of those negative events that has to do with nutrition, and it was documented and is actually used to train people about how to intervene differently so that a never event can't happen in the future. And those never events become sentinel events, and those are the ones with the worst outcomes. So that's what we want to try to prevent. So this was a poll on hospital safety, and pretty much everybody agrees that hospitals should be required to report medical errors to state health departments. Florida does have reporting, but they don't disclose facility-specific information to the public about mistakes. And 82% of consumers said they think that's wrong, and that the hospital's medical error record should be available to the public. So we'll see if that changes in the future.
You know, every year we talk about where's Florida in all of this. And I recall last year, Florida wasn't doing quite so well. So I have some really good news for all of us about Florida hospitals. If you need to visit one this year, take a look at number 2. In 2019, out of the top 120 hospitals, Florida was in that top 4 of that 120 hospitals. And 21 hospitals in Florida had improved their safety ratings and score up in the A's and the B's. So we have seen in the past sometimes that you remember us talking about some D's and F's and things that we had in Florida. Not anymore. We've really seen an improvement across the board in the quality of care in our hospitals. And of course, we know that hospital safety or medical errors is all part of determining this. But if you want to know more,
Yeah. This is national compared to national, not just within Florida or within the Southeast, but nationally, we're in the top 4 with 21 hospitals. That's huge.
Yep. That's great, right? I'm really proud of that. Okay, so how can you find out more if you're thinking, you know what, I've got some surgery coming up, or you've got a family member with some surgery coming up? Here's 2 websites you want to remember. One of them lets you compare hospitals. And then the other one, Leapfrog Group, you can find out scores of hospitals like we just talked about, and a lot of different information that might make you decide differently on where you're thinking about having your surgery done.
So what other settings besides hospitals carry risk? And you can probably guess from looking at this, but most litigation comes from long-term care. And there are a lot of issues there. One is wound healing, where the interventions aren't put in soon enough to prevent a decubitus ulcer or other injury.
Wait, hold on.
And yes. Sure. Okay. So the most litigation is in long-term care, and there are lots of issues in long-term care. Wound healing is one of them, and that is where we don't intervene soon enough. So if there's a consultant dietitian and they only come in twice a month, we need to have more screening about these wounds and how they might progress, and so we can treat them sooner. There's a Q selection guide and logic model that looks at improving pressure ulcer prevention in long-term care, and you can see what it involves. It involves training, it involves early risk identification, it involves clinical decision making on the part not just of the dietitian, but on the nurses and the physicians that are involved in that long-term care. And then the TURN study talks about turning for ulcer reduction so that patients don't just lie on their backs the entire time. We get them up and turned. And then there's another study called the TEAM study that is Turn Everyone and Move study to try to prevent those pressure ulcers from occurring.
So what, excuse me, what about outpatient care? We mentioned this is very new as of really in the last year or so, this area of focus called clinical inertia. And you kind of think like, what does that have to do with me and the way I practice? What it means is that there's a lack of treatment intensification when a patient is not getting the evidence-based goals for care. So in other words, let's just say that their blood sugar is high, their lipids are high, but the treatment is not being intensified enough to actually take care of these situations. That lack of treatment intensification can actually meet the criteria for a medical error. Surprising, but it's happening. So something for us to think about. And I think, again, what you want to focus here on this clinical inertia, because it's going to come back to things that contribute a lot to heart attack and stroke. So hypertension, diabetes, lipid disorders, and it all comes back to the three words, failure to intensify. So when patients are presenting with elevated blood glucose, blood lipids, blood pressure, you've got to make sure, or actually all the care, people providing care, that the therapy is matching what the issue is. Otherwise, it could, as we just said, fit the definition of a medical error.
Okay, so patient misdiagnosis is one of the things we really worry about because what it does is delay the patient getting the proper treatment. So you can see in this study, 21% of patients with serious conditions who sought a second opinion were misdiagnosed first by their primary care practitioner, and the second diagnosis was distinctly different than the first. Only 12% of cases had the same diagnosis. Isn't that interesting? So, patients need to be aggressive if they don't agree with the diagnosis that they get a second opinion and try to make sure that the diagnosis is correct. Because if you don't diagnose it properly, then the treatment's not going to be appropriate. And so the chances of getting better or improving the situation are going to be significantly reduced. So we know that
Kathy,
yeah?
Yeah, I wanted to jump in here and say something I'm thinking about just while you're talking about this. It's just a minute ago when we had the slides up of showing the top, admissions, misdiagnosis was right up there. That's pretty concerning if you think about one of our biggest issues is misdiagnosis and that you're not even being treated for the right condition. And then look at the data here that backs that up.
Yep, and this was pre-COVID. So now that everybody's focused on that and risks and a lot of people aren't going to see the doctor, they're staying away until this is over. This is something that's really, we need to pay more attention to in order to get it right.
Well, every year, we talk about what is new and exciting that's going on, because we want to see the positive and the good and the creativity that's going on out there. So what happened at the electronic show this year in 2020? Well, a couple of things to show you here. Number one up there, it's the Impossible Pork. You may have known about Impossible Burger before, but now trending is what's called Impossible Pork. You're going to see that more and more. It does have a large soy component, but these impossible meats have become very, very popular. Okay, over there, the Charmin robot. Just in case, one more time, let's bring up toilet paper. Should you run out and should you be in a place you just can't get up and go get it, you can call the Charmin robot and he will bring you your much needed roll. Next, you're going to see some great new watches that are in FDA clearance right now, as a matter of fact, and they're called the Scan Watch. They're going to do all kinds of things like even monitor atrial fib or monitor for that, looking at blood glucose levels, tracking sleep. We already have watches out there now that can do a lot of things, but you're seeing more and more medical components be put in watches as a part of self-monitoring and then being able to get in touch with your medical professional. Okay, a few more that I think are really neat. So up on the left, the woman that's had a stroke, what they're doing now is starting this training, this rehab, to make it fun and engaging after a stroke. So they're gamifying physical therapy, if you will, by putting gaming as part of this retraining to help rehab legs and balance and posture. I think that's fascinating, and there's so much popularity of gaming right now. This is interesting. And how about the prosthetic hand? It's designed to work with the amputee's brain waves and with various muscle signals so that they'll be able to make the movement that they want. Any idea on cost? About $15,000. Okay, tired of cooking? Have to cook one more meal? Think you might really need a new hairdo because you'll pull your hair out? Well, you can just call Flip Dish here, and Flip Dish will bring your airborne meal and deliver it to your door. And last but not least, what you're going to see, and it seems like we've become germaphobes, right? But these screen protectors, that's a screen, if you see up there on the OtterBox, these screens are going to have a antimicrobial protection actually built into the screens. So you can see that COVID is bringing out these things in terms of meal delivery and germs.
So every year we're required to talk a little bit about medical errors from the standpoint of what's the definition and how do we try to prevent them. So the failure of a planned action to be completed as intended is called an error of execution. So you plan something, but it doesn't turn out the way you hoped it would, or you planned for it to, or the plan that you're using is wrong. So that would be misdiagnosis, for example. So you're treating something that is incorrect. So those are two kinds of medical errors. And one example in nutrition is for malnutrition diagnosis using serum albumin or pre-albumin, because we know those are not indicators of malnutrition alone. So the other thing that happens is when we try to look at these medical errors, how do they happen? And some of them, as we've mentioned, are the result of system failure. And most are not individual negligence. Nobody starts out the day thinking, oh, today's the day I'm going to commit a medical error, or misconduct. So it's system breakdown that allows these to happen. And again, a little later, we're going to talk about a specific case that had to do with nutrition, and you'll see how the system caused that case to occur. So, when you think about healthcare today, and we ask this question every year, but I don't think it's ever been as pertinent as it is right now. COVID is happening, which could lead to system breakdown. So that's really our biggest challenge right now, is dealing with all of the non-COVID things that are critical in the age of COVID. So there are different kinds of errors. Active errors are those that occur at frontline personnel, and so their effects can be felt immediately. So if you operate on the wrong leg, that's an active frontline error. Latent errors are those that are removed from the direct control of people and could be things like a poor kitchen design so that water pools outside of the refrigerator and somebody slips and falls, incorrect installation of equipment, or lack of facility maintenance. So, and management also is a factor here. So if they make a bad decision, if the organization, there aren't enough people in a certain unit that are needed, those are all things that can contribute to medical errors happening. Latent problems are those that are difficult to identify. So these are things that are hidden. You don't really see them. They're not obvious, like the water on the floor, but they're things that get in the way of you doing the work the way you should be able to do it and your efficiency. So it's something that appears to be something that can't be fixed. So let's say there aren't enough computer monitors at the nursing station, so the person has to go down the hall and around the corner and up the stairs to get to a monitor to enter their information. They may not have written it down correctly. There's time issues, there's memory issues, all of those things could happen. And unfortunately, what we tend to do is think, oh, well, that's just what I have to do. I have to walk, upstairs in order to be able to enter, not realizing that we are normalizing that deviation in process. And if we'd said, no, this isn't right, I need my computer either in my hand so I can carry it and enter it as I'm talking to the patient, or right at the nurse's station so I can go outside and enter it right away. That changes, it deviates from what might be causing the latent problem. So these are things that a lot of times you need somebody from the outside to come in and look at how you're doing things, and they will catch those things right away. We don't, in the middle of the moment, don't catch them because they're normal to us. It's just what I have to do in order to get the job done. So these are things that need to be looked at. Next.
And don't you just wonder how much normalization of deviation, if you will, is going on right now during COVID because of such different situations everyone's working under? Makes you wonder. I bet when we look back, we're going to see a lot of things. Okay, adverse effects. Let's talk about these just a little bit more. So an injury that's caused by a medical or a nutrition error rather than the underlying disease. So that means something that didn't go right, the failure to check the blood sugar, blood glucose, and a patient starts exhibiting symptoms of hypoglycemia. Incomplete patient information, and you see this a lot. And of course, we keep bringing up, because it is coming to the forefront more than ever, the failure to diagnose malnutrition due to improper screening. So you have people looking for malnutrition that maybe don't know it as well. Other professionals, it might be the ones in the ER, the ones somewhere else that's saying, when they really need to say, let's have the dietitian do an assessment. And that's what we're trying to move forward to, so that we have less problems there. So again, an adverse effect is an error that's preventable. And certainly there are negligent adverse effects that have a subset for legal criteria. And we've seen that in the past, and we've seen those cases, especially in long-term care, become issues. That's why documentation by the dietitian is so very important, especially if his or her information has been documented isn't matching what someone else is saying. What are the errors of a medical error occurring, or what are the odds, rather, of a medical error occurring? So some of these really make you think a little bit, like, patients who had surgery in the afternoon were more likely to die. So does that mean I need to aim for the morning? And why is that? Are people tired? Have they been on shift all day? Are you like surgery number 8? What happens on the weekend that increases that risk? Do you have your ones who are newer, less training, less time in the surgical theater on doing surgeries on the weekend? Is there a standard or different care at these times? Or is it just who happens to be on at the time? If there's so many different things, are the patients more severely ill? So there are a lot of factors. I never think there's just one answer most of the time, but a lot of odds that you have to look at that could play a part.
So we always talk about errors of omission, and these are things that are hard to quantify because these are the actions that you didn't take that if you had taken might prevent injury, and then the injury happens. So you have to go back before and try to figure out what didn't you do, not what did you do that caused the error, but what didn't you do that caused the error. So without prevention and then the resultant injury are both considered medical errors. So omission of necessary steps is probably the most common human error made. Why? Because we're in a hurry. Why? Because we want to get through. We want to get to the answer or whatever, but omitting steps is a big problem. The things that are prone to omissions. So if you need a lot of short-term memory in order to do something, you're probably going to forget about it. The odds are more likely that you'll omit that step. If there's a cue that lets you know it's time to do something, without that cue, you're probably not going to be able to do it. So it's important to establish what those cues are and where they need to be in whatever you're working on. And maybe it's the nutrition-focused physical exam, and you always start at the head, or you always start somewhere, but having that isolated, those procedures set up, will help you not miss the steps. Things that are near the end of a sequence, and that's because you're tired. You've gone through all the ones that you know, and you're getting down toward the end, and it's easier to skip those things, not because you want to, but because you don't remember them. And if you get interrupted, and who doesn't get interrupted in clinical practice? We all do, all the time. And for that matter, in any practice, there are lots of interruptions that can happen. So tasks that follow that, you've got to get yourself back on track. You've got to think about, now, where was I? What did I do? How much of this did I finish? Is there something I didn't finish? And then you can go forward. But one thing that really helps with this is a checklist. And if you tick off the checklist as you do it, that really helps. Obviously, if you have a particular job that it requires the same checklist and you do it 365 days a year, you may not need to carry the checklist with you, but you should have some cue that lets you know whether you've completed all of the steps in that checklist. And be sure that if there's a problem, the person who sues you is going to have that checklist. So it's really important for their attorney will get it. And so it's really important that you follow it if you have a checklist that's made. So what else can we do to prevent errors? We want to have, go ahead, Susan.
I want to jump in and say one thing about the omissions, because think about the task now in the hospitals more than ever. Before you're even interacting with the patient, you've got to think about the steps now of, okay, do I have on the right PPE, gloves, mask, shield? Do I have this? Do I have that? Things, all kinds of things that you didn't even have on your checklist before that take a lot of mental energy just to get yourself ready to do what you're going to do. And then, like you said, there are interruptions constantly now. Okay, where was I? Am I doing all the things? So the short-term memory load, which then leads to anxiety and stress, or is really huge right now, I think.
Yeah, that's a great point, Susan. I mean, I think this has probably been, for health professionals, one of the most challenging times ever, because first of all, we didn't know a lot about it. Secondly, we didn't have protective equipment, at least initially, to protect the healthcare people as well as patients and family members. And we're working in a very, very high stress environment because people are scared.
I agree.
Okay, so some of the other things we can do is to make sure all of the policies that you create are deliberate and that they're there because they do something positive. You don't want to just have a list of to-dos that don't really mean much. And I think this kind of, I think, tragedy that we're dealing with now probably has a lot of people looking at those lists and deciding what are the most critical things that we need to do, because we probably won't get to everything. Students, trainees, and professionals need to be out there in these settings practicing. That's how we train our future practitioners. And so if there's something that's happening in a culture that's not conducive to the best outcome, we need to try to identify those things and support our students and professionals in these settings. And then having positive role models and student preceptor relationships, those need to be really positive as well. And so it's important to tell our students, if there's something wrong, if you don't feel like things are going well, or there's an issue that you can't seem to get addressed or resolved, it's really important that you talk to your program director and that we try to solve that, because no one's going to learn in an environment where the relationship is not good or the role model is not positive. And so we're always thinking about how we can improve those settings. Also, what do we do about organizational culture? And the hope is that the organizational culture focuses on teamwork. Every person is a valued member of the team. Every person has contributions to make to the team, from the highest level CEO down to the lowest level janitorial employee. Everyone contributes to the success of that operation. And unless the organizational culture agrees with that and makes everyone feel part of the team and an important link to their success, then you're going to have issues. So it's important to look at that in new cultures when you take a new job or you go to a different place that you haven't worked in before. What is the organizational culture, and what do they value? What are their must-haves to keep the patients safe? And so that's really important for us to look at. And again, we're going to promote health and wellness, and that's not just for the patients, but for the employees. When you think about the stress of just getting to work in the early COVID times, not knowing what you were going to face, not knowing whether you're going to have the appropriate protective equipment, but knowing that you're going to care from patients that have a virus that could be transmitted to you. Talk about healthcare heroes. We've got them, the people that were out there on those front lines doing that work early on and still doing it today. So celebrate those people. They are a major part of what's keeping us going, and it's not been easy because a lot of them have faced personal stress in their families. And how do they get their kids to school? How do they cope in these times? So those self-care skills, what we call resiliency, really an important part of healthcare professional training, and we're seeing it come to light now.
So dietitian burnout and stress, you can see why this has become a big issue. It was an issue before, but certainly COVID has put a spin on that we have never seen before. But at the same time that we're dealing with all that right now, I want to focus on a couple of things that have changed. Now, you see salary compression. And yes, salary compression has happened during COVID, where people have had their schedules cut back from full to part-time, or they've had to take a cut in their salary just to not be furloughed right now. But overall, if you look at what's happening, the new compensation report that is out shows that salaries for RDNs, the median wage has up 8%. And that median wage right now is around $68,000. So that means you've got a lot of people making way above that as well. So I think the good news for dietitians is that lack of value that has been perceived in the past is starting to change. We're being paid more. There are bills up in the legislature now to look at letting us do what we do, making it easier to refer out to us, making the things that we do be covered by Medicare and insurances. So as stressful as it is, I think there's a lot of hope for what we see in the future coming in terms of salaries, our perceived value, the work that we're able to do. All right, so let's look at our top causes of medical error. You know, every year, JACO puts this data out. It's never a surprise to us that communication remains at the very top. In the past, now, I mean, being able to communicate and communicate under really difficult circumstances becomes more important. So you can see, as we've already talked about, with the various ways that errors happen, how communication becomes critical right now. And then, of course, right now also, we've got to remember the safety and security issues. And that becomes very personal about the mask, about PPE, about what is available. So look at the goals. Every year again, JACO puts out their new patient safety goals. And we have to notice number one, improve the accuracy of patient identification. So just like we get the diagnosis wrong, we've got to make sure that we're identifying the right patient for the right care. So you can see many of the others that are going on that you may think apply in the work where you are right now. Is it the safety of using medications? Is it keeping them, safe from associated infections or from falls or from pressure ulcers? So these safety goals really apply many times in the clinical setting, as they always have. But I also think you have to look at where you are and your setting and what you can do to make sure that your patient safety is top of mind. And we always have to go back and look at that link between sentinel events and medical errors. Sentinel events being the events we never want to happen, and certainly if they do, to be very few and far between.
So here's the definition of a sentinel event. It's a safety event that is not related to the course of the patient's illness or their condition that reaches the patient and results in death, permanent harm, or severe temporary harm, and intervention required to sustain life. So these are the never events that we don't ever want to face. These, when they happen, require immediate investigation, and they use what's called root cause analysis. Sentinel events and medical errors are not the same. They're not synonymous, and not all sentinel events occur because of an error, and not all errors result in sentinel events. So when a sentinel event happens, you can be sure there's going to be an investigation immediately to try to figure out what did we do or not do that caused this to happen. And these have to be reported to JACO when they occur from our healthcare facilities, and there's the phone number. So this was a sentinel events alert this year that was focusing on developing a reporting culture. So now we're talking about the culture within healthcare facilities, learning from close calls and hazardous conditions. So this was the case we've been alluding to all along that has a nutrition component. It happened in a hospital where a pharmacy tech was preparing a pediatric solution, and the bag she was using ran out, and so she grabbed another bag that she thought was sterile water, but instead it was a bag that looked similar and contained Travasol, which is an amino acid concentrate that should never be used with pediatric patients. She prepared the solution with the Travasol and then sent it out for delivery. And somehow where she was working, she realized when she looked at the bags that were left that she must have used the wrong bag and hung it to go out and be delivered to the patient. Next. So, quote, she said, "For a few seconds, I couldn't move. I felt panicked, But I went directly to the pharmacist and told her I'd made a mistake, a big mistake, a mistake that could really cause harm. And the pharmacist immediately put out a call throughout the hospital that all deliveries should be stopped. No one should be given anything from a cart until they found the bags, and they were able to retrieve all of the bags before any of them reached a patient. Thank goodness. So then they went back and tried to figure out, how did this happen? And they determined that it was a system error, not the pharmacy tech was not at blame because of the organizational structure of where she was working. And they figured out that the bags were not labeled appropriately, and so she was looking at a lot of things, trying to fill the orders in a hurry, and it was not her fault that one of the bags had been placed in the wrong area. And so it was called a system error. And that means that anybody could have made that mistake working in that system. And so rather than being punished, she was, taken care of and thanked for reporting her mistake so quickly that she saved the lives of patients. And it's pretty cool when she said, I didn't care what happened to me, I cared about what would happen to the patient. And that's the kind of healthcare professional we all hope to be, right? So her story is a really good illustration of that. When something like this happens, and this turned out to be a near miss. It could have been a sentinel event. A patient could have been killed. So this is a close call. And what's recommended when this happens is that everybody takes a pause and looks at this. What contributed to this happening? Have we fixed it? And how can we use this to prevent things like this from happening again? So the Joint Commission announced that it supports allowing healthcare staff to bring their own. This is just a statement that was published this year because of COVID. People can bring their own face masks or respirators to wear at work when their healthcare organizations cannot routinely provide access to protective equipment. So the fact that they had to make a statement about this lets you know what was happening in healthcare facilities. They didn't have enough to keep the healthcare workers safe. And so it was better to have them bring things from home that they could wear to reduce their exposure than until they could get the materials they needed. So really, really another example of the heroes that were working during this time and the risks that they faced.
And I imagine too, Kathy, that a lot of people in our Q&A have stories like that, real world to tell from themselves or their friends. I know I do from some of my friends that are respiratory therapists in other parts of the country, and some of the struggles they have had getting PPE and in getting the protection they need when they're in the belly of the beast, so to speak.
Exactly. And here's where the Joint Commission recognized that fact that, homemade masks are an extreme measure, should be used only when the standard PPE cannot be used. There aren't any standards or requirements that prohibit staff from bringing it from home. So this was one of those, situations that you didn't know what was going to happen and the degree to which people would be at risk. And so good for the Joint Commission to come out and recognize that and allow people to do something to protect themselves.
And it may, the protection may not have been exactly as good as, of course, having the N95s, but when they're in short supply, you've got to be creative and come up with everything you can to protect yourself as much as possible. So it's, COVID-19 has challenged us, all of us, our healthcare organizations. And I think the future studies, as we have said, the future studies that are going to look back are going to teach us a great deal. You would hope that we'll never have another pandemic, but I think that the chance of that, we probably will at some point in our lifetime. Who knows? But what you hope is that studies coming up that are going to look back will enable us to get better and stronger and be even more prepared in ways we weren't before to deal with things that come up, for sure. And just a reminder of everything comes down when something happens. And as Kathy says, you take a big pause. When there's a near miss or for something that unfortunately does happen and you've got to look, you're going to go back to root cause analysis always. So if you look at what just happened at the near miss at the very top here, in the case of this, the pharmacy tech here, there was a near miss, but it did not happen. And in the second one, the harmless hit, if the bag had gone out into the room, well, it could still be a harmless hit as long as it wasn't plugged in. And then you would have had an adverse effect where the error actually reached the patient and caused harm. But we didn't get it into the room. It didn't get plugged in, which was good. And so, of course, it comes down to the unsafe condition, which the label wasn't written large enough to be seen clearly from where it was pulled out. So you go back to saying, okay, system error here, system error that we need to fix so that everything, the A doesn't happen at all, but if it does, it is up there at the near miss where it gets caught before it gets to the patient, or if it gets in the room, it doesn't cause harm because it's stopped before then and realized. So root cause analysis gets used not only in healthcare, but as we've talked about many times, in plane accidents and all kinds of different accidents, saying what happened, what was the root. It's many times a system error. What can we do about it?
So here's your definition. The reason for the failure or inefficiency of one or more processes, points where an intervention could reasonably be implemented, which would change performance and prevent a negative outcome. And the majority of these events have multiple root causes. So maybe the bags came in and the manufacturer had the labeling very small. That wasn't the fault of the system or the tech or anyone else. It needs to be corrected at the level of manufacturer or when those things were bagged. So these are some of the identified root cause categories and subcategories. So information, is everybody getting the information that they need in order to perform appropriately? Leadership, do we have the right leadership and policies and procedures that are going to prevent errors from happening? For medication use, and this fits the example we just looked at, labeling, ordering, preparing and distributing for medications or feedings. Nutrition care is on here, the planning, the timing, the storage, and patient monitoring of those nutrition solutions that are being used. And then in the operating room, some other areas. So basically, the root cause analysis is trying to figure out how to prevent these issues from happening by discovering what the causes and contributing factors are through data gathering. And it involves disciplinary people, everybody who's familiar with the situation, going back and looking at how did this happen and how can we prevent it. So the whole idea is to improve the process and get to that highest standard of quality care and service. We thought this was funny just because we're all so wedded to our computers these days and we haven't struggled to them. But I thought this was a good example of root cause analysis. Whoops.
And you know how it always asks you to, do you want to report the error? You know how it collects and then the little thing will come up. Do you want to send in a report of your error or not?
Right.
So what happens when it comes down to it? What is most critical to safe practice for RDNs? And of course, it's on everything, the scope of practice that focuses on food and nutrition and related services. But I think it's all of these things that we have talked about today, but especially medical nutrition therapy. It's what we know. It's what we're trained to do. And whether we're doing it in a public, a community setting, whether we're in a hospital, a clinic, whether you're doing telehealth or delivering an education program, I think what's most critical to the safe practice or just the practice of RDNs is that RDNs are the lead, that we are taking the lead and that we are the lead to make sure that things are done the way the evidence-based science shows, the way that we know, and that we are leading that information, and especially when it comes to medical nutrition therapy. Okay. So keep calm and continue to provide that excellent customer service that dietitians are known for. We're all about safety, quality, satisfaction, and our goal is to continue to provide exceptional care, and continue to ask yourself day to day, what do I do in my work, my practice, wherever you happen to be, so that I make medical errors less common?
So I was on a webinar yesterday, and one of the health professionals that was talked about 3 elements to excellent care: head, heart, and hands. And obviously the head is what we know and what we've been trained to do, and our intelligence and our desire to do the right thing. Heart is the care that we have for patients or clients, or the work that we do, the importance of feeding people, all of those things that nutrition and dietetics teaches us about the importance of our profession. And then the last thing is the hands, the ability to do the work, the nutrition-focused physical exam, all of the things that we do as part of our practice. So we want to say thank you for listening, and you're equipped to now go out and prevent medical errors. Thanks.
Thanks.
Thank you, Dr. Christie, and thank you, Dr. Mitchell, for such a wonderful presentation. You really gave us a relevant look at medical errors and even made this topic very lively. So thank you so much for being with us today. We are a little bit of a time crunch this afternoon. We did get a few questions for this session. So please know we have logged your questions, and we will be getting those answers to you via email. But now we're going to continue on for our last session, and that is human trafficking. So we're going to move to that now. Thank you.
Good afternoon, and welcome to this very important presentation. My name is Amy Sindler, and I'm a dietitian at the Orlando VA Medical Center. I also served as secretary for FAND from 2017 to 2018, and am now the president of the Central Florida Academy of Nutrition and Dietetics, CFAND. So again, welcome. And I do have the honor to introduce this session, which we all need for our licensure. This session is Human Trafficking Recognition, Response, Referral. Our speaker today is Robin Hassler Thompson. Robin has a MA-JD and is the executive director of the Survive and Thrive Advocacy Center, a nonprofit agency she co-founded in 2015 to assist survivors of human trafficking. She is an active member and co-chairs the Social Services Committee for the Big Bend Coalition Against Human Trafficking. Robin's consulting firm, Robin H. Thompson and Associates, represents a wide range of clients, including USF Center for the Advancement of Human Rights, where she assists in the center's work on human trafficking. In 2001, she traveled to Bangladesh as part of the U.S. State Department mission, which included visiting a human trafficking rescue shelter. This trip inspired her to build awareness about human trafficking. Robin has lectured extensively on the topics of violence against women and human trafficking. She contributes to numerous national and international publications and curricula, including a domestic violence and human trafficking online continuing medical education course for the Florida Medical Association. Robin's expertise also includes domestic violence and sexual violence law and policy. She served in leadership roles within local, state, and national boards and committees. Robin served as the executive director for Florida's first task force on domestic violence and sexual violence. She graduated from Florida State University College of Law in 1984. She holds an MA from FSU and a BA from American University in Washington, D.C., where she graduated summa cum laude in 1981. Please let's give a warm welcome for Robin Thompson.
Thank you so much, Amy. And thank you very much to everyone for attending. First, I'd like to let you know I have no disclosures today. And let's get right away into talking about the learning objectives. First, I'd like to help you understand what is human trafficking. We'll talk about the various characteristics of victims and survivors. We'll understand the risk factors for human trafficking, how to approach your patients or clients, connecting you to resources, how you can comply with legal documentation and reporting requirements, the signage that's important for you to know about starting January 1 of 2021, and advocacy issues. So why are we here today? First of all, this slide is illustrative of how come it's so important for us to understand and to be able to detect and assist human trafficking survivors. We know that survivors come to many people in the healthcare settings that you work in. So whether you're a nutritionist in a physician's office or a hospital or a clinic, we know that there's a good chance you're going to see a survivor. We also know that accessibility to medical services is one of the most important and common ways that you could see a survivor of trafficking. In fact, this one study that's cited here, almost 88% of trafficking survivors talked about accessing healthcare actually during their trafficking situation. Most of these people were seen in the emergency department, and that shouldn't be a surprise. In fact, on the right, there's a quote that also is from a survivor who basically says during the time that she sought services at hospitals and clinics, no one ever asked her about her situation. And chances are there were several red flags. So let's do a general overview of human trafficking and help ground you on this phenomenon. First, what is trafficking? We talk about human trafficking literally as modern day slavery. It's quite simply the exploitation, the commercial exploitation of one person by another for the purposes of some sort of commercial gain. It may involve movement of a person, and that's kind of an unfortunate connotation that comes with human trafficking. Often people think it requires movement, but it absolutely doesn't. It doesn't require movement anywhere. Certainly it doesn't require movement across a border. What we're seeing now more are that victims are really held by something called invisible chains of psychological coercion, and I'll talk more about that soon. And we know that it is at least a highly profitable, over $150 billion annual industry. We also know this is a global health issue. Over 40 million people are living in slavery worldwide, and I have to tell you, that's an estimate. Human trafficking, as you might guess, is a highly clandestine operation. And so it's literally impossible to know exactly how many people are enslaved, both in our country, in our state, and around the world. From what we know, though, we know about 80% of those who are trafficked are labor trafficked. That means even though we see very often shows, movies, popular media, prosecutions, and arrests that indicate that sex trafficking is more prevalent, I'm here to tell you today that that's not necessarily the case. Moreover, we often see that sex trafficking and labor trafficking are intertwined. You might have sex trafficking victims who are forced to commit acts of labor, including illegal acts like being a drug mule or stealing. And we might find labor trafficking victims who are sexually assaulted during the time of their labor captivity. We know that very often women and girls are more likely to be the victims in the commercial sex industry, and 58% or so in other sectors. And that comes really from the vulnerability of both women and children. This is a map that shows you in terms of the bright red areas, red orange areas, as well as the other areas where there is human trafficking in our nation. The next slide I want to show you too, and it gives you some statistics there. The next slide shows those same kinds of figures and depictions in Florida. You can see that, unfortunately, Florida is third in the nation when it comes to human trafficking. And in this map, you can see really where those trafficking cases have clustered. So you can see they happen in very populous areas around, Miami, Dade, Broward counties, across the I-4 corridor, and then really kind of across, you got I-75 there, and across I-10 along the Panhandle where I live. I'm in Tallahassee. But you can see that these are instances, if you will, of human trafficking that are reported to our national hotline. The statistics you see on the screen here can let you know how many have been reported. So we've had over 4,000 since 2007, and you can see the breakdown there. You might be saying, wait a minute, she said before 80% of the cases are labor trafficking. Why is that upside down in terms of these stats? And the answer is that really labor trafficking is not reported, and it's not as easily detected as sex trafficking, but we're seeing more and more cases come forward. More about that next. So there are three elements of trafficking, and I'd like our slide advancer to go through and just click 3 times to get all of these slides up for you. So this is called the AMP model: actions, means, and purpose for the trafficking that takes place. So know that in order for it to constitute trafficking, you need to have any one of these various things under the word action: the recruiting, harboring, moving, or obtaining a person, any of those things. So that someone who obtained, in a case that we worked on some time ago here at FSU, it was a case of people who were trafficked from Mexico. And there was a grandmotherly figure who was actually the recruiter in Mexico. She was the one who convinced parents and others to give them her girls and young women, relatives, in fact, to let them take them across the border. And so they were defrauded. The next box there shows it can be by force or fraud or coercion. In this case, the grandmotherly figure, the grandmother, lied and said that they would be given a great job in Florida. They'd be able to send money home. And yet what happened is those young girls and women were in fact enslaved. This was the Cadena case, and this happened outside in South Florida and up the coast a bit. And this was a case where they actually enslaved people in brothels that were on the outside of migrant farm worker camps, where they literally forced the women to be sex objects, if you will. They were raped numerous times a day by men who worked in the fields. And that kind of sex trafficking is what was shown in the purpose here, where they clearly were enslaved. It was the sex trade. There was debt bondage. They were told they had a huge debt they had to pay off. And in this particular instance of the Cadena case, many of these purposes were achieved, but you only really need one of any of those things for it to constitute human trafficking. So our definitions in Florida and federal law are important to know, and I know you're nutritionists and you're not really need to be steeped in the law, but I want to just kind of give you an idea so you'll know, because chances are it might come up sometime in your practice, and you're going to need to know that these things exist. So just briefly, the law separates sex trafficking and labor trafficking. In the federal law, you can see what all these things that I mentioned before: the recruitment, harboring, etc. And you needed force, fraud, and coercion unless the individual being trafficked is a minor. So in this case, what the federal law and Florida law both say is that if somebody is under the age of 18, they just need to be enticed or induced. They don't need to be forced or coerced into an act of a commercial sex act. When it comes to labor, the federal law says, again, here are all the things already mentioned: recruitment, harboring, etc. And that under the federal law, the person, if they are a minor, does have to be forced or coerced or defrauded. But under Florida law, which I think is much better, that's not the case. So if you encounter anyone who is a minor, know that you don't have to show that that person has been forced into it, because the law essentially imputes that they're not going to be needed to show that kind of force or coercion because they are a minor and because of their capacity to consent to things like commercial sex or enslaved labor. It's important to keep in mind that trafficking and smuggling are two different things. And I mention this because it's almost a pet peeve of mine that I see that quite often the media confuses them. And sometimes you think, wait a minute, was that smuggling or was that trafficking? Or people say it's smuggling or trafficking. Let me just help you out here. So the first thing to remember is, one, trafficking is really all about coercion. It's all about that forcing of a person. So it's a crime against the person where the person loses complete agency and can't make his or her own decision about what's next in their lives. Smuggling is quite different. Smuggling could mean I want to go from A to B, from Mexico, say, to the United States, and I'm going to pay you to do it. When I get there, I might have to pay you more, but our work together is done and I can go on my merry way. With trafficking, that's not the case. If you get to a destination, say a trafficker takes you over the border or makes a promise to you, you don't have agency to leave. You don't have the ability to get out of that situation. As I mentioned, you don't have to cross a border. You can have somebody, unfortunately, we see cases quite often of parents who traffic their own children out of their homes. So the commodity is the person, and the commodity is the border or that transportation. It's also, and this is maybe where the confusion comes in, sometimes a case that looks like it started out as a smuggling case can turn into trafficking. And that would look like someone saying, yeah, I'll pay you to take me across the border. And then when I got there, the person might tell me, hey, no, you can't leave. You have to give me another $10,000 and you have to go work in my factory or my restaurant in order to pay it off. So that's when it can turn into to a trafficking situation. But in the person's mind, the victim, it started out as a smuggling. So what are some trends? I mentioned before that we're seeing more cases of labor trafficking, and indeed that's happening across our state and across the nation. In fact, a lot of the federal agencies now are actually saying, unless you do labor trafficking cases, unless you talk about education, arrest and prosecution of labor trafficking cases, you're not going to be eligible to receive federal funding. We also know that traffickers are targeting people with disabilities. We'll talk more about this, but know that traffickers really go after anyone with any kind of vulnerability. And in this case, the disabled are some of the traffickers' most common targets. I mentioned before we had several cases, and this is the case all over Florida, that particularly when you think about the opioid epidemic, you think about other kinds of issues involving drugs in particular, that people are selling themselves and they're selling their children in order to satisfy their drug habit. It's a very disturbing trend. Another trend I wanted to bring to mind, especially now, is that traffickers during disasters are quite nimble and they take advantage. So right now, here we are in the midst of hurricane season. We also are going through one of our lifetime's worst pandemics. Disasters, whether it's a natural disaster, whether it's a political instability, whether it's an economic disaster, know that those who were at risk before are even more at risk now. For example, people who were not earning a lot of money, or they were in the gig economy, and lots of instability around that. Right now, after a disaster, imagine the people in Pensacola now after Hurricane Sally, where roofs were blown off and things were washed out, restaurants, housing, etc. Lots of vulnerability takes place. We also know that organized crime and any kind of traffickers are very nimble during crises. I work for the Survive and Thrive Advocacy Center here in Tallahassee, and I can tell you 2 years ago, after Hurricane Michael, what happened is, number one, we assisted somebody who was trafficked into our area to help reconstruct roofs because the devastation of a Cat 5 going inland was just incredible. Still, there are blue tarps over there. And a man, an undocumented man, and a whole group of men were seduced, if you will, lured into North Florida with the promise of a good job and good pay to fix roofs after a hurricane. And they were trafficked there. They were forced to work. That the man that we helped was able to get away. He had very serious medical injuries that went unattended to by the traffickers, of course. and we were able to get him medical help and housing. There was also a case that we saw where a man induced somebody into sex trafficking. A young woman lost her house, lost everything. And instead of the usual come on, which sometimes these guys use, posing as boyfriends, or that they'll make somebody a star or a model, this guy promised he'd help her with her FEMA benefits. And that we saw, thankfully, in our close work with the local housing agency, the local homeless shelter, we were able to get in there and help her get him out of the way. And she was able to apply for her benefits and get a check, and he was not getting that money. So know that traffickers are very nimble during these times of crisis. You might find, in fact, in terms of sex trafficking, we've seen advertising of trafficking victims where the traffickers have put online that someone will wear a mask and gloves. So please keep this in mind, that we're in a very vulnerable time now, and it's likely to become even worse. In particular, when it comes to COVID, know that what we've seen, and I think around the state, is that reports to authorities are generally down because of this isolation. We also know that kids, and when you think about kids online, a lot of kids aren't in school, and for safety reasons, which is good, but then they're online more. And whether it's online in a gaming thing like Fortnite, or whether it's social, that vulnerability is exposed to traffickers when the kids are online doing whatever they're doing. That could mean that they befriend usually a youth. They act like they're the same age. They have the same interests. They have the same kinds of desires to have fun, get together. And what happens time and time again is traffickers lure youth into sex trafficking situations. So we know that the risk of online exploitation has gone up since COVID started. We've seen a lot of increase of domestic violence during trafficking during this time, by the way. And that domestic violence also includes domestic violence abusers who traffic their victims and family members. People can't get away as easily. We see that some shelters are closed down because they couldn't stay safe during these adult congregate living facilities and during COVID. So we've seen sometimes some programs shutting down or limiting their services. And we know that law enforcement is focused on other situations, and so may not be able to respond as quickly to situations. So keep those things in mind. So know that minors in particular are at great risk. They always have been during the situation. And we're talking about U.S. citizen minors as well as others who are come to this country. We know Florida is a magnet for runaways, for labor trafficking, for sex trafficking, and for both. And very often, though, these kids are exploited in the sex trade. It's important to keep in mind that boys are also trafficked. Quite often, our materials that organizations put out or reports show that only happens to girls. But know that boys similarly are trafficked. Very often, people characterize what they do as, quote, survival sex, where they might be trading sex for a place to stay, for drugs, for food. And very often they're not necessarily being trafficked with the help of a pimp trafficker. So it's important to know who the traffickers are, because there's a chance that you'll see a trafficker in your healthcare setting or in your practice, because very often they are quite controlling of their victims. But anyway, so here's a list of who are possible traffickers. I'd ask you to take a look at this and say, does anything surprise you? I mean, you might see somebody who's a neighbor or friend. I mentioned the Cadena case. Those are relatives trafficking their nieces, right? Labor subcontractors in Florida are notorious for trafficking people from other countries into our area and horribly abusing and exploiting them. And very often families. So know that it can be pretty much anyone in a business context. In some cases I've seen it's been the most popular, the most well-heeled person in town, well-respected, et cetera. So don't think they always are going to look really creepy or look somehow nefarious. In fact, here are some pictures of some sex traffickers. So know that all of these people were sex traffickers, convicted. The guy on the left was trafficking young men and women. The woman on the top, she was trafficking her daughter from age 3 to 13. to support her drug habit. The guy on the far right is trafficking women out of Lowell Correctional Institution. He'd find out he was going to be about to be released from prison. Before then, he'd start putting money in their commissary accounts. And then when they got out, he promised them a nice place to stay and a good job. Turns out he forced them into sex trafficking. So know that these are all the guy on the right next to the skinny guy, the white guy. He was trafficking young boys and men. So know that it doesn't matter. You know, a trafficker could be anyone. And they do these 3 stages that are mentioned on the slide. They lure them in with promises of something that's too good to be true often. They build trust over time. And then there's a payback stage. That's when they say, okay, so I've done all this for you. I just need you to do this for me. And that could include having sex or committing illegal acts or committing some other kind of labor. So who's at risk of being trafficked? I think I want to draw your attention immediately to the bottom of the slide that says anybody who's vulnerable. So on this list, there are lots of examples of people who are vulnerable. And know that, again, during this time, we have more economically vulnerable people. We have people who are who might be having substance issues that might have increased now during COVID, foster care, kids in general, kids who are abused at home, or adults who had been abused physically or sexually at home. We find high rates of vulnerability to being trafficked. So in the healthcare setting, what does it look like? And I know that you're, say, not classically involved in, say, an emergency department necessarily, but you are indeed connected all the time to people's health and well-being. So it is so important that we're here today. So what are the signs? So sometimes it's hard to catch those signs. There's a lack of training, although it's getting better and better, especially with this new law in place. And most say they don't know how to respond, even if they did detect trafficking. A study that was just recently done that I learned about was wonderful. And it said, when people get grounded on what is going on, what trafficking might look like, their confidence increases. And with that increased confidence, they're able to ask the questions, which we'll talk about in a little bit. And they're more confident in being able to get help to the person affected. So that's what I hope we'll accomplish today as well. More often, this is where people present, and know that traffickers will bring their victims to the doctors. For example, a case I knew of a colleague in Washington, D.C., there was a diplomat who was trafficking young girls from their country to be house slaves. And one of them got sick and they needed to take them to the doctor, right? So she didn't want them to infect her children. So that particular victim was seen in a normal family health practice, right? So a victim can appear in any of the practices that are listed here. Here are some physical indicators. And as I go through these, I also want to mention something else, that you might see these kinds of indicators when somebody is actually in a trafficking situation or has recently gotten out of one. But understand too, these are highly traumatic situations, and someone might be presenting to you with nutritional needs or deficiencies or other things that are going on in their lives because they were trafficked 5 years ago, 10 years ago, right? So don't think that this is only going to be a situation where you see someone who has recently come out or is in a trafficking situation. It could be a long-term trauma and injury and health effect. But some of the more recent things that you might see is immediate things like malnutrition, branding, certain tattoos. We have a picture there of an RFID tag, which we know some of us put those in our pets so that we can detect them if they get loose, right? It was actually a case in Orlando where a woman was told by her trafficker that he was actually tracking her with an RFID tag, which of course is not how they work, but she believed it. And an x-ray revealed indeed that he had chipped her in order to play with her head and to convince her that indeed she was under his complete control. So also know that any other kinds of these health effects, frequent STIs, pregnancies, abortions, things that you can't get help, even though you need it, you might see chronic conditions go unaddressed. Some behavioral indicators, we might see depression, substance use, and know that in terms of substances, what often happens is someone might take drugs in order to cope with a trafficking situation. They might be forced to take substances because it makes them more compliant. or they might not even take drugs or substances at all during the trafficking situation. But because of the horrors that they endure, to cope with them, later they become addicted. We also see other kinds of behavior like poor eye contact. You might see hypervigilance, particularly if someone is actually in a trafficking situation. And often we see that people have no real sense of time, and it's or place. Often they forget where they are. They're never told where they are. This is classic information from a lot of domestic violence trainings, if you've ever been in one of those, where they talk about how a domestic violence abuser often refuses to leave the side of the victim, right? They want to make sure they're in control. They want to make sure no information comes out that could implicate them or put them at any risk. And that's what you see with human trafficking as well. And in fact, we saw this again in the Cadena case when we interviewed survivors years later, that the abusers, traffickers, were their interpreters in an emergency setting, right? They're the ones that answered questions for them. They wouldn't let them be alone. You might see a victim, and I suggest strongly that you have a no cell phone policy if you have someone that you're seeing, because often traffickers will say, put your phone on so I can hear the interaction, even if I'm not physically present. You can also have somebody frequently texting somebody that you're trying to have an intake or an interview with, and then all of a sudden she can't stop looking at her phone because she has to be accountable to that person instantly if they text. And you might also see a lack of proper identification. In labor trafficking, and this is something that you might observe in terms of someone's health and well-being, they've been exposed to harmful chemicals. They have no safety equipment that they need if they are performing a very dangerous job or any job. They might be forced to live with the employer at the employer's place of business or home. I just heard of a case recently where someone talked about being forced to sleep in the same closet, if you will, or small area as the dog on a mattress on the floor. They're given a few breaks, few access, not a lot of access to bathrooms, to water, et cetera. And they're often, particularly women, abused at work, threatened sexual harassment or actual sexual harassment on the job. I mentioned this earlier, but just to keep in mind, just because someone might come to you showing, say, that they had been sexually assaulted, or they might be a victim of domestic violence, don't discount human trafficking, because it's very likely that in a lot of human trafficking situations, there are other kinds of victimizations, and whether that's sexual harassment or sexual violence and assault, or whether it is as I mentioned before, a human trafficking, or a domestic violence abuser trafficking his or her partner, or forcing the partner or the child into labor situations. And also know, again, that labor and sex trafficking can happen together. It's not just one or the other. So I hope a lot of you, if not all of you, have had trauma-informed care or have had information about the neurobiology of trauma and how trauma affects us so deeply. We know that trauma, we've all had traumas in our lives, and it's too much to go into for this slide presentation or this presentation with you today, but know that, no surprise, human trafficking victims have suffered a great deal of trauma. And it's important for you to be conversant on the triggers, to be trauma informed, and to understand the extent to which trauma can affect somebody's decision making, their life choices, how they react even to you in a particular moment during an intake or during an interview. So understanding trauma is vital. So what are some red flags that you might detect if you're talking to someone? You might see, something inconsistent between what they're saying and what you're observing. That could be injuries, that could be something that just doesn't make sense. You might have someone who isn't clear about where they are or why they're there. You might find them dressing inappropriately for the season. For example, really skimpy clothing during cold weather times. They might give a very scripted story. And you'll see it sometimes when you ask somebody a question that wasn't part of the script. Now, they're expected to be asked, say, about their age. But if you ask them exactly, say, what year they were born, or other information about where they come from, or where they might have had lunch, you might see this kind of stopping where they hadn't been coached, right? So know that there are various red flags like that. So what would a good response, a victim-centered, a true patient care response look like? So one thing to just keep in mind is that it's so important that you, again, try to separate the person you're speaking with from anyone accompanying her. It might be a partner, it might be a male-female situation, it might be a parent with a child. And that's trickier, of course, because parents have a right to be with their children. But again, think about if you're able to ask questions for, say, an older child that might give you some insights. Even though there are times when you can't assure confidentiality, say in cases of child abuse or other kinds of harms, know that it's important to reassure people often that this is a confidential encounter. I'm sure a lot of you are covered by HIPAA. All of that still applies, and you can share that information, and should, with your patients. Know that that it's really important to just proceed, let someone narrate, let them be in charge of how the story comes out. Let their agenda be the agenda that drives you in your particular interaction. If someone just wants information about, say they have diabetes and they just want to know what they need to eat or not eat, then you don't have to kind of range far from that. So make sure they stay in charge. And why is this? Well, part of it is a survivor's perspective is pretty clear. For example, I've never found or heard of someone who right out says that they are a victim of human trafficking, right? They're not going to self-identify. And it's very unlikely you're going to get all the information about that person's life in your brief encounter with them. You're not going to know details about where they sleep, how often they have access to food. You might see language barriers, or they might not want to talk about anything else but their exact reason for being in front of you. They also experience a great deal of fear and just physical fear about their own security and safety and that of others. Also know that very many of them, this idea of being rescued is not correct. They have survived using their wits. They've gotten to a part in life where they're still alive, and they feel very much like they are in charge, and they do have some degree of power. So coming in and acting like you're a rescuer, or you see anybody else doing that, it's a good thing to not go down that road. They also might fear retaliation, and very important, they might also have something called trauma bonding or traumatic bonding, sometimes called Stockholm syndrome, where they're actually connected to their own traffickers in a way that they defend them. They don't want to leave them. They want to protect them. And that can be kind of throw you off as a helper or provider, but know that it's actually quite common. Again, the idea of responding with compassion, not only because you're dealing with someone who is highly traumatized, but it's important to make sure you check your biases at the door. For example, you might find someone who discloses that she has had sex with, say, 40 men in the last 3 days. It's important for you not to be judgmental about that. It's important for you to look to that person as a helper, right? As someone who's going to assist them with what their needs are, and just be aware of somebody who might be coming to you or who might obviously be someone who has been in sex trafficking, forced into prostitution, but you might have your own ideas, say, about prostitution. But again, checking those at the door and being non-judgmental is super important. Know too that we see people, both U.S. citizens and people from other countries who are trafficked here in Florida, and make sure you have access to interpretation from people other than those accompanying the victim, as well as others who might be, say, just happen to be in your waiting room or on staff, unless they're trusted. So it's important now, before maybe when you go back to your practices, that you make sure that you've got some good, reliable interpreters for the languages that are spoken in your area. And know too that very often, whether they're from this country or not, it's highly likely that the patient isn't aware of their own rights, isn't aware of the services that are available. And we'll talk more about how you can be a link to those things. So here are some questions you can think about asking. And I often think about these being questions that you may not ask, but you actually might just receive answers to as the patient narrates their own story. First, it's always important to make sure you can attend to their immediate needs. Are they thirsty? Are they comfortable? Do they want the chair to be facing the door, away from the door? Where do they, where are they living? Are they safe in terms of how they're staying? How's it been going? And then you might be able to get into some other information about whether someone's been threatened, whether they've been physically abused or harmed or forced to do something that they didn't want to do. And then, and I say screening, it might be intake, it might just be a part of your conversation with your patient. But it's, if you get information that, again, they're living and sleeping and working in the same place, right? If they don't know where they are, we work a lot with some of the people in our homeless shelter, and we were surprised at first when our advocates started just asking people, have you ever had to trade sex for anything? And so many people did, particularly women. So that's an indication that they might have been trafficked or that they might be at risk of being trafficked again. If someone talks about a huge debt, being compelled to work, for example, there was a case in South Florida where a judge kept hearing a kid say, I got to work. This was in a dependency proceeding. I got to work, judge. No, I don't want to go to school. I have to work. That sort of absolute insistence on work by a child thankfully raised the radar of an advocate in the courtroom who said, Judge, something else might be going on here. So a judge who thought he was giving this child an opportunity to live and go to school instead of work, learned that child was actually in a forced labor situation. These questions, by the way, just get at issues around agency. So are they free to come and go as they please? Are they free to make phone calls to their family? Do they have access to phones? If someone says, I haven't talked to my mother in 3 years, I'm afraid for her health, she has the same thing I have, you can say, why? What's going on? Well, the boss doesn't let me. I don't have, so you get the point. Remember that the goal with any encounter with anyone is really the building up of trust. So it's not your job to play detective or to be 100%, assured that this person is a victim, a prior, survivor of trafficking or currently is being victimized, right? It's your goal to build trust with that person, however you can do it. Having them be a resource, having you be a resource to them is vital. For example, in our work, our victim advocate told me the other day that someone we hadn't heard from for months, we'd helped her for a little bit. We helped her get clothing and some things she needed to get, through the day and through the night and, be stable, get what she needed to stay safe and be safe. She just went off the radar for us. We didn't hear from her, but she came back into town, and one of the first people she called was our advocate to say, can we have a cup of coffee together? That meant the world, because that meant we built up the trust needed for her to reach out again for help. It's important to let your patient or client know that they're not alone and that help is available. We'll talk about that in a minute. And that you are not the service provider necessarily, right, for human trafficking assistance, but you're the link to organizations like ours called STACK and other organizations and other lifelines to help that person. If someone does disclose and says, yeah, this is what's going on, it's important to send a lot of solid messaging around, look, this is not your fault, that no one deserves this, help's available again to let them know, and then to help them get that connection going, right? Never let them use their own phone. If they have their phone with them, let them use your phone or an office phone, because again, that technology is traceable by the trafficker, and she could suffer severe penalty, if you will, harm, punishment for doing anything that means reaching for help and getting out of the situation. So asking them if they want to talk to an advocate. You might, if you're in a hospital situation, you might have social workers and other people who are there really to be patient advocates. And then just asking them point blank, how can I help? The other part that's important about this, and it's something that we do as an agency that advocates and others might do, but you could get a sense of safety. So what does that mean? If someone says, I just can't go home, I don't know what's going to happen, I'm afraid to go home. Now, this might be trafficking, this might be other kinds of violence or harm, but you can start to get the resources needed to help that person. We've seen cases certainly where the trafficker has actually brought the person in. We helped a young woman who the trafficker actually said she didn't know what was going on with her. He said, call 911 and go to the hospital. When she got there, she got assistance and help. And then thankfully the people at the emergency department called us and we were able to get her further assistance. But the trafficker might not say call 911. They might actually be there in the waiting room. Understanding that they might not have access to ID, help them to get that. And then to just get a sense of how safe they are. You know, going back with the person who brought them, who might be a trafficker, could actually be safer at that moment. And that person is the expert on making that decision. So getting a sense of safety, and it's something that we do as a local anti-trafficking organization, and others like your domestic violence programs also do. And then here are some other indicators that you can go through. So again, how can I help? What is the assistance that's needed? It's kind of putting it in an open-ended way to help the person dictate that kind of help to you. And again, it's all about building trust. So this is to give you an idea of some of the things that we've seen that survivors need. So all of these things are there perhaps in your communities, or they're there with an agency like ours, or your health, your healthcare provider agency that you work with can help provide those connections too. So we know that, the safety planning I just mentioned, an advocate can do that. We find that housing is really the number one need for people, that they need a safe place to be. And in some cases, we've seen trafficking survivors that are well free of their traffickers, but because they've had they don't have a bank account, they don't have a job, they really need housing, number one. We also do tons of work with our local legal services providers. So I will tell you that it's not just related to the trafficking situation per se. For example, we have a law in Florida that allows someone to expunge trafficking from their record if they were, committing a crime while being a victim of trafficking. So that's a specific legal need related to trafficking, right? Tons of other legal needs can spring forward. We might need someone who needs help with insurance, consumer issues. We might need help for someone who needs help with getting a divorce, child custody. So really anything that any of us need legal help with, a survivor might as well. We also work really closely with the faith community. We find that it's important, again, for survivors to have those linkages, whatever it is they need to get through their situation. And here are some other examples. Again, mentioning some of the legal remedies for those who are here from another country. There's something called a T visa as well as a U visa that's available for people who are trafficked or who are victims of serious crimes. In our state, we have a series of or a number of safe harbor shelters for youth. Some are for boys, some are for girls. These are really important programs. Not enough of them are out there, but are there to really help kids that have been primarily sex trafficked. Know that there are all these other things that a survivor could need help with. And again, linking them with those of us in the community or others in your area like legal services, pro bono help, it's really, really important. Remember that you are a mandatory reporter, particularly those of you who are in a healthcare setting. So mandatory reports are there absolutely in all cases where there is a gunshot wound or a life-threatening injury. Those are mandatory reports to the sheriff. Now you can see why this is a good slide to have if I'm talking to a group of emergency room nurses or doctors, right? Because that's where they're going to see these kinds of injuries. But know that if you're on a team, which we highly recommend, that's important to know, that's the report to the sheriff. Failure to report is a misdemeanor, first degree, but it doesn't absolve you or remove the requirement to do other forms of mandatory reporting. So on this slide, you can see that you are a mandatory reporter for DCF if you are suspecting human trafficking of a child or a vulnerable adult. Absolutely no question, that's a mandatory report to DCF. This is your phone number, 96 Abuse. Some of you might have called that number before in the past, but know that this is a mandatory report. We do not have mandatory reports in Florida for, quote, human trafficking as an entity, only if you have these other things happening. If you have somebody who is, again, gunshot wound, wound indicating life-threatening violence, and then in this case where you suspect trafficking or any other kind of abuse, exploitation, or neglect of an adult or a child. The call is anonymous, and they will bring forth information. They'll start their investigation. They may reach out to the individual right then and there, but that's something that you absolutely have to know that you must do. So again, I've given you some information. Local human trafficking programs like STAC are around our state. There are also a way for you to find out where they are, who they are, by going to the humantraffickinghotline.org. That will connect you directly to the program in your area that provides some kind of support for human trafficking victims. This is some of the stuff that we do. Again, we're in North Florida and the Big Bend of Florida, and we do all this kind of work many places around the state. Not enough, but a few of us are out there. So other action steps that you can consider. First, know that one of the things you absolutely have to do in your workspace as a healthcare provider is that you have to post a sign in English and in Spanish about human trafficking that displays the National Human Trafficking Hotline number and details the help that's available. And that's, by the way, that's the Florida Department of Health. This is the Florida Department of Health's actual signage that they've developed that you can just take and use. And this is what you have to, again, have posted, and there are details in the law about how and where that's supposed to be posted, and just make sure that it's in a very open space. You know, I want to tell you too that that's one of the reasons why we think all the time, I mentioned before how Florida's number 3. We think that Texas probably has been number 1 in the past because California has been number 1. Texas has been up there because they have had a mandatory signage requirement, not for healthcare providers, but for restaurants, bars, strip clubs, etc., for 10 years, 15 years maybe. So we know that helps facilitate calls to the hotline for help and information, which is really important. Everybody always asks in these trainings, what do you do? So, you know, in addition to being a nutritionist or dietitian, you know, you're a human being in the community. You're a neighbor. You're someone in a faith community. You're someone who's a parent or someone who's a coworker. So know, you know, outside of your work, these are things that you should know about. Number 1, to mention again, if it's an emergency, call 911. This is the National Human Trafficking Hotline number. It might look weird. It's actually 888-3737. 888 is another way for it to be kind of memorized easily. There's the DCF number, again, 96 abuse if you suspect children and vulnerable adults. So this is who you should call. This is some really good information for you to show that when you do make those calls to the Florida Abuse Hotline, you can see what difference it makes. In 2009, when this first started, when they first had a maltreatment code called human trafficking of a child, 43 reports, right? In 2018, 21, over 2,000 reports, and it's still over 2,000 in terms of last year's stats as well. So know that it can make a huge difference. And I encourage you, even if you don't know for sure, because you probably won't, you can say you suspect human trafficking, and that will really help the investigation proceed forward. So here are the things that you can do. Posting materials, know your resources, including that national hotline. This link on the slide right now, or you can just Google Florida Attorney General Human Trafficking Coalitions. You can find your local task force or coalition, connect up with them, know who they are, let them know who you are. All healthcare settings and all of the literature for healthcare providers highly encourages the development of this multidisciplinary team approach. Everybody, social workers, physicians, nurses, nutrition, everybody who has anything to do, including anybody in your offices, people on the janitorial staff, receptionists, everyone should have some solid basis of knowledge around human trafficking so they can know what to do. Here are some resources. Again, this is a lot of intense, dense information, but this PowerPoint should be made available to you so that you will be able to take advantage of these links for there's a great deal of information out there, especially for healthcare providers, but you can see again that there's information regarding mental health, and also I have some information about our work and a specific toolkit for healthcare providers. And here's my contact information. And with that, I'll conclude, and we'll go forward next, I think, with some questions and answers. Thanks very much.
Thank you so much, Robin. This was very difficult to hear and such a horrible topic. But one question is, why did human trafficking become a requirement at this time?
You know, it might be kind of hard to put the legislature in perspective exactly and say this is why any particular law passes at any particular time. But I think it was part of the legislature recognizing how human trafficking is much more prevalent than is coming forward to law enforcement, and then having them see who are the most important contact points in our communities. And I think those in the healthcare sector are the most important in a lot of ways. You will see people that law enforcement may not see. They may not disclose to others in their circle of friends, or they may not have access to any other kind of helpers besides healthcare providers. So I think that's why the legislature zeroed in on this requirement. And if you'll notice, you all are part of a one-time only requirement. 2 years ago, maybe 3 years ago now, the legislature passed a law to require nurses to have 2 hours of human trafficking training every licensure cycle. And it's really for those same reasons. So how it extended out, my guess is they saw that it was helpful and important for nurses to do this. And then they kind of incrementally went forward with 1 hour for everybody. And then further on, you know, down the line, they figured, well, we might as well include as many people as we can in this.
Also, what do you think local dietetics associations can do as a group?
Well, you know, I was almost going to give you all a video, and I want to direct you to our website called surviveandthriveadvocacy.org and ask you to take a look at a link there called Imagining Freedom, because what we do as an organization is we focus on not just assisting survivors and providing information, but we also want people to take a really hard look at the food that they're eating. So we have an event called Imagining Freedom, where we have food featured, purveyors of food, restaurants, farmers, lots of folks that are producing things that are slavery and trafficking free. So we know that in the supply chain, that you know that the foods that you're consuming, preparing for your family, the restaurants that you're going to, the coffee shops you're visiting, are using ingredients that are slavery free and trafficking free. So one of the things I think you all are in a really unique position to help advance is to help people realize what's going on in terms of their food consumption. So our event is all around that. We highlight that. We celebrate the people that are walking the talk and doing the right thing and supporting fair trade, fair labor, and supply chains that are free of human trafficking. This is another thing I wanted to mention. There's a website called yourslaveryfootprint.org. And if you go on that, you can actually see in terms of what you consume, from your cell phone to your tires on your car, I think, or your house, your food, how many slaves globally might be working for you. And so that is one thing you can do. The other thing is, I mentioned earlier how the Attorney General's office, if you go on Florida Attorney General Human Trafficking, there's a link, and it was in one of the slides earlier, but you can connect with your local human trafficking task force or coalition. They are all over the state, And you can simply ask them what's going on. For example, January is Human Trafficking Awareness Month. Maybe you want to sponsor a local lunch and learn during that month. Maybe you'd like to help see if food is needed. I can tell you one of the things we're working on up here is getting information to our local food banks and others who are helping people who are really at risk now, who are on the edge economically, who are, who may be about to be homeless or who are needing food from food banks, and giving them some information about what is human trafficking. So know that I think connecting locally to your local organization would be awesome. Supporting them during their end of year campaigns, helping them to do their jobs is great. And then also thinking, if you think about it, would you want to be consuming food that was, picked or harvested with people who were enslaved, right? So that is one thing you can think about. Do you have any thoughts, Amy? Is there something you were thinking about you all might be able to do?
I was thinking we could hold maybe some type of fundraiser for a local shelter.
Exactly. And the other thing is you all might be working with people right now who are helping the vulnerable in our communities, so that I will tell, and I love people to think about this, but if you are helping someone to not be homeless, to learn a language, to become empowered in any way, you are actually doing anti-trafficking work. And as you could tell from some of my presentation, when I talked about the needs that a survivor might have, he might need a job, he might need a place to live, he might need medical care. There are so many things, and there are places in your community already doing that work. I would say if you're already doing some work, or you have an affinity or are connected to one of those organizations, like your local domestic violence or rape crisis program, or your homeless shelter. If you have a Second Harvest, we have a Second Harvest of the Big Bend, is connect with them to make sure they and their staff understand about how human trafficking is on the continuum of really victimizations or things that might happen to the people that they're assisting now. So I think forging community around this issue is one of the best things. And that's why, as a side effect of these trainings, it often does link people around this issue. And that's what we do now. We work with our local homeless shelter. We work with our 211 Big Bend, our local substance abuse programs. We do training constantly. We do cross training, homeless providers, et cetera. So I think that's another thing, to see any of that work as being really important anti-human trafficking and survivor support work.
Thank you so much. These are wonderful suggestions and advice. Thank you so much. We do have one more question. Are there any training resources for labor positions, such as food service workers?
Absolutely. It's so the Florida Restaurant Lodging Association, FRLA, has a training on their website, and it has been free. So you can take a look at that website. I don't know if food workers, are they licensed under DBPR? Is there a DBPR licensing program for them? Do you know?
I'm not sure.
I'm only asking about. Yeah. So if there is, I only mention that because the Department of Business and Professional Regulation, they do have a requirement that they're doing for some people in the hospitality industry. So people who are in hotels and who are front desk, housekeeping, and others, but they are developing training programs for them. I will say, if anyone is interested, you can contact me, Robin at surviveandthriveadvocacy.org. I'd be glad to help do a little bit more research on that. But I know that, for example, in our jurisdiction, we will be having a training in January for hospitality workers. I'm not sure if food service is going to be directly linked, but I think we could probably work something out. So if someone would like to contact me, I'd love to work with you.
Great. Thank you so much. And do you know the date in January for the conference?
We have not set, yeah, we haven't set that yet, but if you would go to our website, and we'll be posting kind of all of the January events for our area shortly. Usually before
Great.
Thanksgiving. That's the goal.
Okay. Thank you so much. And thank you. I think we're maybe out of time for questions. This was a great talk about a horrible situation that's continuing to happen. So thank you so much, Robin.
Thank you. And thank you all so much for featuring this. I really appreciate it.
Thank you everyone for joining us on our first ever virtual annual symposium. We hope you enjoyed it. Remember to get those last bids in for the virtual silent auction, and we will be in touch soon. Thanks everyone.